Recording in progress.
My dear esteemed friends, my teachers, Professor K.C. Samal, who taught us diabetes, endocrinology, metabolism, my professor, Professor Niranjan Tripathi, who taught us medicine and many other things in life, how to face the challenge. And my dear audience, I cannot but take the name of S.K. Bansibhai. I can take, I can see Jargar Saab all the way from Kashmir. I'm seeing Jayant and I'm seeing, I think Sunil is joining. He just now said to send me a message. And I will not take the name, it take time, but I must welcome all the faculty and all the people who have joined for this program. To make a long story short, Nucd has finished 9th year and today is the Nucd version 10. And 10 is a number which is, from the occult point of view, very important. Therefore, this meeting today that we'll be inaugurating in a minute is absolutely, we have called it the latest, the fabulous, and interactive. And someone about 2 years back thought that we should have the program starting with an interview, short talks, and 45 minutes of interaction. And that was the blessed day. And today, this is centered around that. Dear friends, I must tell you, this program has got about 10 sessions, and each session has about 5 talks, a interview, including interview, has got a panel discussion with celebrated panelists. The topics that are discussed, I will not take time, but must tell you, it is what our name stands for, clinical and practical. It is a clinical update. It is meant for the people who are practicing diabetes in the tier 1, of course, but tier 2 cities. It is an explosion of the knowledge. We have faculty from far and wide, and the topics are contemporary and challenging and will change the way we look at diabetes. Dear friends, 10 years back, when Nucd started, there was a very good beginning. Over the 10 years, there have been well progression. Dear friends, on this particular day, on the beginning of Nucd version 10, I pray there is no end, an endless progression. Thank you.
Thank you, Ashok Bhai, Professor Ashok Das, the mentor and the spirit behind this program. He has worked day in and day out to make it a success. I will not, there are two important people who are boarding the flight. I'll request them to speak fast. Then Professor Samal will inaugurate. One is Professor Sunil Gupta, he is boarding, and one is Mr. Vikrant Sotria, head of Novo Nordics India. So he is here with us. Vikrant, I'll like to speak for 2 minutes, and you have brought GLP-1 to India and revolutionized the insulin treatment.
I think you have made it affordable, appropriate, and accessible. It is most affordable today.
Vikrant, please.
Thank you very much. Thanks a lot, Dr. Alok Kanungo. You know, it is fantastic to be here. And I was just hearing what Professor A.K. Das was actually talking about. You know, I say that eighth wonder is the consistency. So when you hear anything very consistent, it is the 12th national update on clinical diabetes. I think so it is fantastic to hear. And the kind of program which is happening is one of the state of the art in terms of clinical updates and also the research, which is actually getting eluded in this particular session. Now, when you see a mix of what you call it digital and physical, we call it phygital, you know. So you are having a face-to-face and you are having a you can say, digital connect with all the doctors, with the
Exactly.
kind of faculty which you have taken from the national forum in India. I think it is the state of the art. And what you talked about, bringing the innovation, that has been the foundation for Novo Nordisk. I really take pride not only bringing it the innovation, but also making it accessible, what Professor A.K. Das just now talked about. For last 40 years, we have been bringing innovation in India, and we have got still state of the art insulin formulations in India. Sometimes people are really talking about when we phased out this human penicillin, and I would like to talk about it, that are we going out of India? And I keep on saying that we still have 20 formulations in India. Every second person depend on our innovation and our factories to provide insulin. We will continue to provide that. And now, once we have come with GLP-1, whether it is oral, whether it is for diabetes, whether it is for obesity, we will continue our commitment for the cause of the solution when it comes to India, and also bringing it better and better access. So thank you very much. Pleasure to be connected with the faculty out here, and we are keenly looking out in terms of the deliberations for the next 2 days. So pleasure to be here.
Thank you, so Vikrant. Thank you for finding time at the airport to join us. Thank you very much. I'll request
So
Sunil
thank you
if you
very
have
much.
joined. Thank you. Thank you. I'll request Professor Sunil Gupta, President RSSDI, to join if he has not yet boarded. Sunil, are
Yeah.
you there?
Yeah, I'm very much here, Alok. Thank you very much, and heartiest congratulations for this 12th NUCD meeting. And I was always a part of it every time. And it is one of the meeting which I have seen with full of all kind of clinical upgrades, its application, relevance to the people in the urban and rural area, as well as giving even enough importance to the research and academics. Your orations, your deliveries, everything is par excellent. And with Dr. Professor A.K. Das as our patron, it makes a additional interest and impression to the whole system here. So with his blessings, every time any meeting is going to be successful, I'm sure about it. My all best wishes to you and everyone. I'll be really missing for not coming there because I have got my other commitment for Jharkhand. I'm on the way from the Kolkata airport now. I'm on the way to Devgar for the meeting. So unable to make it this time. But next time, I promise you, Alok, that I'll be there to for the NUCD. And congratulations once again, and all the best. RSSDI will always be proactively a part of such endeavors whenever it is needed when it comes to academics and education in public and masses at large. Thank you very much.
Thank you so much, Sunil, for this taking this time. Before the inauguration, I'll take only 2 minutes I'll take only 2 minutes to give little introduction about the program. Professor Das has already told. So, these dear friends, colleagues, brothers, my mentors, and everybody, well wishers and everything. This meeting has been running for last 12 years with blessings from Professor Samal and Professor Niranjan Tripathi and Professor Ashok Das. I would like to pay my homage to Professor R.K. Das, Professor Sabyasachi Das, Professor B.B. Tripathi, the stalwarts in this Odisha for this program and for diabetes management. And I'll thank all our sponsors, USB, Novo, Sanofi, and all other sponsors for helping us. And now Professor Samal is going to inaugurate this. Professor Samal is the first person who brought endocrinology to Odisha. He is the second endocrinologist of the country, and he has his blessings for this program, and he is always there where there is academics, where there is people. So I think I would like to thank Saurav, my son, for making this program a success, designing and everything he has done. Mamta, my wife, for all her cooperation, and members of the kids
11:27 on the 11th floor, sir. That's the executive category.
Can you give me one more key?
Doctor, all my friends, colleagues at Kids Hospital, Dr. Kanungo's Diabetes Center, and Kotak Diabetes Research Foundation, those who have been helping us. So I want all of you are so known in the Indian soil, abroad, internationally known. So I don't need to give any introduction of yours. You are all known by yourself. And thank you very much for joining us. And Joyasri, Sambit, Jayant, Abhay,
I'll
and
manage.
everybody
I'll
has
just
been
finish.
so cooperative. I'm thankful to all of them. Thank you very much. I'll request the organizer to plan for the inauguration. Then Professor Samal will speak.
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Thank you. Professor Das, please invite Professor Samal.
Sir, it's my great honor and pleasure to invite Professor K.C. Samal, Professor Kitish Chandra Samal. He has been already introduced to kindly give his inaugural address. Sir, Professor
Hi.
Samal, sir.
Hi. Hi, Ashok.
Thank you.
Hi, everybody. I thank you all. Very good morning. And it's my pleasure to be here amongst you to inaugurate such a auspicious meeting. Clinical diabetes has become very popular. Laboratory diabetes has fallen back. Now, in the clinical diabetes, patients always ask, sir, when my diabetes is going to be reversible? Well, from where they have heard it. Every patient is now coming that when I am going to get a cure of diabetes. In fact, I have not seen a patient who is cured by me. But going through the pure journals, there some people have claimed that somebody has got cure of diabetes. That is under laboratory conditions, very strict conditions of diet and medications, etc. Now, the problem is, what type of diabetes can get cured? Is it FCPD? Is it MMDM? Is it type 2? Is it type 1? Is it gestational diabetes? Is it all other forms of diabetes? Now, to me, some of the cases of gestational diabetes have really got cured. Examples are there. And I have seen many patients who are really diabetic during the pregnancy, and afterwards they become completely normal. Otherwise, FCPD getting operated. These are the points to be discussed in the update program. Actually, in near future, we are going to get it or not. Otherwise, it has become havoc among the patients, ordinary patients. They are coming and asking, sir, we have heard that diabetes is getting cured. Number two, the therapeutic approach. There is no strict guidelines in this country. A patient comes, you start immediately insulin, or start immediately oral antidiabetic, or insulin followed by oral, or oral followed by insulin. In many cases, you see, they give everything except the strict dietetic control, and they find no treatment in that. So these are the points which should be discussed in this program, and a guideline should come up for therapeutic approach for patients, especially clinicians who are treating diabetes day and night. Now, with the words, I have great pleasure in inaugurating the National Diabetes Upgrade Program. This is 13th annual.
12th.
12th.
Yes.
12th is past or 12th. This is 12th.
Yes.
This is 12th. I express my thanks to the organizers for having invited me, and I hope the take-home message from this program will be spread amongst the physicians dealing with diabetes, treating with diabetes. Thank you all.
Thank you.
Sir, thank you very much for your Ashirvachan and those two important points that you pointed out. There are thousands of people who have joined. Now they've registered the two important points that you spoke about. Now it's time to please invite Professor Niranjan Tripathi to speak few words.
Sultan.
Namaskar, Professor Samal. Namaskar, Professor Ashok. And I will recite a Mangala Charan praising Lord Jagannath and his family and praising Dr. Alok Kanungo and his family. Because Jagannath is a family man and Alok is a family man. Jagannath is maintaining the world with his family and Alok is maintaining the diabetic world with his family. So let us pray now. Niladro Shankha Madhye Satadala Kamale Ratna Singhasanastang Ratnalankarajutam Navaghana Ruchirang Sanjutang Chakrajayam Bhamaya Bhamabhage Ratacharana Jutang Brahma Rudrendra Vandyang Sarameshang Swadana Paribrutam Brahmadarum Sparani. I pray Lord Jagannath, who with his family in his great abode of Niladri maintains the entire world. So also Dr. Alok with his wife Mamta and his son Saurabh, they are maintaining a national conference for last 12 years. Please give him a big hand. Friends, diabetes has become an epidemic affecting over 589 million, approximately 59 crores, 60 crores people worldwide. To lifelong medication, what Professor Samal said. Diabetes is a major cause of heart attack, kidney failure, stroke, and blindness. It is estimated the number of people affected 53 million by 2050. That means 85 crores. So in coming 20 years, there will be another addition of 25 crore people to diabetes world. And the field of diabetes care is rapidly changing. Kids, the Kanungo Institute of Diabetic Specialities, established in 2009 by founder chairman Dr. Alok, is a 5-star specialties center which provides top-notch treatment, surgeries, and many other procedures in the clinic. This great organization, over the years, organizing national updates on clinical diabetes, featuring some of the India's foremost authorities and world authorities on the subject of diabetes and obesity. Progress in management, both of T1 and T2 diabetes and an era of other diabetes has gone sea change ever since discovery of insulin in 1921 for last 105 years. New medications like tirzepatide, Munjaro, a dual GIP and GLP-1 inhibitor receptor agonist offering enhanced glycemic control and weight loss benefits is a major achievement from 1925 in India. But before that, rivals us, that oral semaglutide also has come into the market, and KIDS is the first center in Odisha who is the largest prescriber of rivals in Odisha. So also tirzepatide Munjaro. Munjaro honeymoon is now little below because of facial fat loss, making 40-year-old immediately 60-year-old men, and featuring the loss of libido, which is another factor for middle-aged people and young men. Or orforglipron, an oral GLP-1 agonist, is in pipeline, and I hope kids will be trying that. Artificial pancreas will integrate continuous glucose monitoring, insulin pumps, and algorithms that will automate insulin delivery, improving glucose control. All three are there. Artificial pancreas are likely to come to kids because Saurabh is now trying very hard in this direction. Immunotherapy with teplizumab delays type 1 diabetes onset in high-risk individuals and preserves beta cell function. That might be tried in kids in the near future for type 1 diabetes, which is a major center for type 1 diabetes in Odisha and India. Stem cell therapy, VX880, a stem cell derived islet therapy, has shown insulin independence. So this may come to diabetes. I hope this has not been done. This is a very difficult process. Probably this can be done in kids in near future in coming time. All these facilities are available in kids. Bhubaneswar established 17 years back, and this Nucd just established 13 years back is having continuous national updates. And I hope Alok, Mamta, and Saurabh doing wonders, making a diabetes treatment center of world class at Bhubaneswar in shape of kids. With this, I present to you kids and its chairman with his families who are holding national conferences, one of its kind in the world. And for this, I must thank Padma Shri Vinod Kanungo, our mentor and guide, which did diabetes, started Diabetes Association India as a member, founder member, with Professor B.B. Tripathi, Professor K.C. Samal, Professor N.C. Panda, who motivated his young son then reading MBBS to pursue the course of diabetes. In the process, Professor Samal was his PhD guide, which he pursued in Sweden, and he's one of the foremost diabetologists of the country doing research in type 1 diabetes and classifying diabetes. I'm sure KIDS is a natural center which will grow with the Saurabh at its helm of the affairs. I wish them all success and NUD all success.
Thank you, sir. Thank you so much for your kind words and academic excellence in going to the deepest of the latest advances. I'll request our Honorable Dr. Bansi Sabu to say a few lines. Bansi, please. Bansi, are you there? Professor Bansi Sabu, if he's
Yes,
taking
I am
time,
there, very much there.
please.
First of all, congratulations, Dr. Kanungo. During this time of when we are meeting physically, you kept the meeting online, but that's again, there are a lot of advantages of keeping online meetings. So I really congratulate you for that because we can reach out to remote part of the country. The physician, the doctor who is not able to attend the meeting face to face, it's not possible for everyone. As you know, the cost of traveling, cost of doing a meeting physically also. So what's more important is dissemination of knowledge, and that you have continued. So we congratulate you. Definitely missing hospitality of Dr. Kalungo, missing Bhubaneswar, and missing meeting people physically. But yes, definitely it's a great meeting, and congratulations to you. From IDF Southeast Asia as a chair of International Diabetic Federation, we do now because of after post-COVID, a lot of online meeting, not only for education program, but also for advisory board, for many of interactive meetings, and plus board meeting of organizations also we are online many times. So wonderful way of disseminating knowledge across the country, and congratulations to NUCD and to Dr. Alok Kanungo and team for this wonderful meeting which they are hosting, and also to my friend Dr. Jayant Panda and my teacher Dr. Ashok Kumar Das. Thank you, Dr. Alok, for giving me an opportunity to join for this. Thank you.
Thank you, Dr. Bansi, for your wonderful thing. You have taken India to world level, so there are a lot to your credit. I'll request Dr. Jargar to say a few lines. We are. I can request the organizer to extend by 10 minutes, please. Inauguration.
Professor A.K. Das and Dr. Alok, it has always been a pleasure right from the inception to be associated with this NUCD program. And today when Professor Das was talking about his teachers, Dr. Samal and Dr. Niranjan, I cannot but help remembering our great teacher, Professor R.J. Dash, and Professor B.B. Tripathi. I think, in decades back when Professor Tripathi was talking about malnutrition-related diabetes and pancreatic diabetes, there was a period when people started doubting the existence of that form of diabetes. And now their stand was venerated when last year IDF said, yes, there is a definite malnutrition-related diabetes. This particular form, NUCD, right from the beginning, has emerged a huge national platform for discussion on metabolic diseases, not diabetes alone. And whatever new developments have come over a period of recent decades. So it's a sort of a review of whatever has happened in the last 1 year in the field of metabolic diseases. And some of the best people from the country and abroad do bring up their knowledge, the recent developments in clinical trials and new drugs that are coming consistently now in the field of diabetes. I wish a great success to this program, and I am sure, like the previous programs, the current program also would be an academic feast and a great success with Dr. Ashok Kumar Das and Dr. Alok at the helm of affairs. My best wishes and my respects and regards. Over to Alok.
Thank you, Bhai Sahab. Always great to listen to you. I'll say Pandit Ji, Dr. S.K. Sharma to say a few lines. Dr. Sharma, please.
You're muted, sir.
Yeah. Good morning to all the stalwarts like Dr. A.K. Das, Dr. Samal, Dr. Tripathi, Dr. Jargar, and all my other friends who are in this platform. It is very, very important to connect to Dr. Kanungo's NUCD. We are having a relationship with this for the last 12 years. This time, of course, you have done a great job of combining the virtual with physical, because in North India, we are having a problem of, you can say, flight disruptions. So in Delhi and in Jaipur, fog is really causing disruptions. So that's why I am happy to be connected to you by webinar, and I know that you have a very beautiful scientific program, and every time we learn a lot from your program. So with that, I will say my regards to all of you. Thank you very much, and good wishes for your beautiful program. Thank you.
Thank you, Dr. Sharma. I'll request one unusual guest. He's our special guest, Mr. P.K. Das. He was the Chief Commissioner of Central Excise and a teacher, professor of their institute. He is equally a physicist, scientist, and a literature specialist. Mr. P.K. Das, please, 2 minutes.
Good morning. Am I audible?
Yes.
Yeah, good morning. Thanks, Alok, for kind words. It's indeed an honor to be with all these eminent doctors. I am really humbled. I may not be able to contribute technically anything, but I would say only this, that this 12 NUCD is a great effort by Dr. Alok and his team at KIDS. And incidentally, 12 numerologically is an angel number. Across philosophies, cultures, from Greece to China to India, 12 has been not just a mythical number. In science, time also, 12 is a unit of measurement from 12 hours to dozens. Even Jagannath takes a Navakalevar on 12 years. And this 12th NUCD, I hope and pray, would probably bring this diabetes discussion to a new format and enrich everybody's knowledge. As Dr. Ashok Das said, the primary purpose is to spread knowledge. And knowledge to me is a continuous process of unlearning and relearning, without which the knowledge will not spread. And as Dr. Professor Tripathi said, a Sanskrit verse in praise of Jagannath, I can say a verse probably in the virtue of knowledge, as our scripture said, Nochoro harjang, nacharaja harjang, nocha nabhatru harjang, nocha bharakari, beyakrute bardhat eva nityam, vidyadhanam sarvadhanam pradhanam. It means essentially that no thief can steal it, no king can tax it, no brother can share it, and it's not heavy on anybody. As you spend, it grows, and knowledge is the prime of all the wealth on earth. With these words, thank you again. Keep spreading knowledge. Thank you.
Thank you. Thank you, Prasanna. I'll request Professor Jayant Panda to say a few lines.
Thank you, sir. My most revered Professor Kitish Samal, sir, endocrinology to Odisha, and it's a blissful experience seeing sir, though virtually, long after sir has blessed all of us, inaugurated the function. I'll tell that this is the greatest moment of a new city, that sir has again come, though virtually, and blessed all of us. And I must congratulate Dr. Al of all challenges and difficulties, in spite of COVID, in spite of all issues around. The NUCD is doing very good year after year for last 12 years. I've been very closely a part of it, and cherished every year the science, and his like and his aspiration to spread knowledge has made it very prominent event and only flagship event of Odisha in the field of diabetology for last 12 years. So a single-handed effort by Dr. Kanungo. Give a big hand to Dr. Kanungo. I pray God that this should continue and perform year after year and make Odisha and Odisha's metabolic physicians proud. And the brain of the function is my mentor, Professor Ashok Das, who has changed the pattern. The interviews you see, the panel discussion you see, the didactic lecture you see, the orations you see, it's innovative. Globally, you go, this is an innovative structure which keeps the audience absorbed. That's why this program is very popular among people. And this year, it's a one-day online and one-day physical as well as online, makes it very special. And as Prasanna Shah told, the 12th is a very lucky number, and we are very happy to reach the 12th edition of Nucd. My regards to all, Dr. Jargar, Dr. Sharma, Dr. Bansi, Mamta ma'am, Jayashri, Niranjan sir. My salute to all stalwarts who have been supporting the Nucd movement from the beginning, and it's an honor to be part of Nucd like any time. And I pray Lord Jagannath that this scientific endeavor should be a great endeavor and should continue year after year. Thank you.
Thank you,
for the
Jayant.
opportunity.
I will have the last speaker, Professor Jayashree Swami. Jayashree, please.
Yes.
Yes, Jayashree.
Yeah. Yes, sir. Just a minute, sir.
Yeah.
Yeah. A very good morning, everybody. My namaskar and Jai Jagannath to you all. Sir, it is a 12th national update on the clinical diabetes. It's my great honor and privilege to be part of this great scientific conference. Sir, it is just like translational research from that of the bench to bedside. It is the counterpart of the translational research, like that of the you are translating this academic from that of the practical, bridging this gap. This is a unique, NUCD is a unique conference. It is the hybrid mode, sir. Those people who are not able to join practically, physically, they will take this benefit of this conference. And the uniqueness of this conference is the stalwarts from this every corner of this country are joining in this conference. And these panel discussions are there with very interactive sessions, and interview, one-to-one interview is there, which is very much uh, grateful for all these delegates. And this thing is that in this conference, we are covering every aspect of the diabetes, from diagnosis to that of the complications. We are covering the oral drugs, newer oral drugs, insulins and newer insulins, and so also anti-diabetic medications, newer ones, and technology also, sir. We have covered everything. You have covered everything, sir. We all, Dr. Sapit, Professor Jayant Panda, and we all are working for last 2 months for bringing this scientific conference as a part of scientific committee with this leadership of Dr. Alok Anungo sir and Professor A.K. Das sir. So it is a unique conference which all these delegates, they will take a crispy take-home message from this conference for their clinical practice. I wish all the success of this NUCD, and I hope that all these delegates, they will enjoy this academic for the last 2 years and great live
Thank
this
you, Jayashree.
NUCD, sir. Thank you, sir.
Thank you, Jayashree, for your kind
Thank you, sir.
words. I have only one last job to do, then Professor Das will take over. I have to thank our sponsors. Tuti, will you put the slides? I think Sambit could not come. Abhay, are you there? No, I think he is also not able to come. So, slides, our partners are, the major is USB. They have given their heart and soul for this program for last 12 years, from Farida ma'am to Prasant and Lina Tiwari, and down the earth. And I should thank Rupesh and Chandan and their team, and Sankar. Everybody is there. So thank you, USB team. Thank you, Sanofi team, for your work and support, academic support. Thank you, Nova Nordics, and Vikrant Sotria was here and he spoke very nicely. Medley, Rishi and others, their team, Boringer, Ingham, and Dr. Kanungo's Diabetes Center, Lupin, Three Dots, Drois Jha and his team, Abbott and Kids Hospital are our partners. So we are doing it in a very modest way, and I thank all our partners for supporting the academic event. Professor Das, please conclude.
Dear friends, at the end of this Mammoth inaugural session, it is time for the oration. I request RS7 to take the center stage. I request my dear friend, Professor Dr. Jyotidev Kesavdev, to please unmute and also visible. Jyoti, this oration, Jyoti, are you there? Jyotidev?
Mute.
এটা বন্ধ ধর্ম কলি করতেন ধর্মটাকে লগে জায়গা এটা বন্ধ হয়ে গেল
ଆପଣ ସାର୍ ମ୍ୟୁଟ୍ କରିଦିଅନ୍ତୁ ଭିଜୁଆଲ ଥାଉ
ବନ୍ଦ ହେଇଗଲା
Jyotidev? Jyoti?
ବନ୍ଦ ହେଇଗଲା
Yeah. Yeah. Dear friends, Jyoti, are you there? Jyoti, are you there?
Yes, he will be talking.
Is he available? Has he joined? Jyoti,
No,
has you joined?
No, sir. Dr. Jyotidev is not here.
I'm calling him. I'm calling him.
No, he's recorded.
Then
Dear friends, as you just heard, there was a son of the soil whose fight for the freedom of India, his association with Bhudan and Vinoba Bhave, whose contribution to Odia literature
Go back to the previous
to bring
slide.
out the Gyanamandal, the compendium of Odisha dictionary, and above all, a patriot and a loyal sevak of the mankind. He was the illustrious father of our illustrious chairman of KITS. He was Professor Padam Shri Vinod Kanungo, father of Alok. Dear friends, it is my great pleasure and honor to present to you the orator for this year to deliver the Padam Shri Vinod Kanungo Memorial Lecture. This year's the recipient of this unique honor is Professor Dr. Jyotidev Keshavdev. Dear friend, to give this oration after the Gandhian freedom fighter, visionary, encyclopedist, we have Professor Jyotidev Keshavdev amongst us. Can I go back to the citation? Dear friend, can I go to citation? Professor Dr. Jyotidev Keshavdev is a nationally and internationally renowned diabetologist and a pioneer in the cost-effective management of diabetes through the use of technology and the telemedicine. He currently serves as the National President of the Diabetes Technology Trust of India and a Central Executive Committee member of RSSDI and ARO, the Obesity Society. He is the Editor-in-Chief of the International Journal of Diabetes and Technology, organizing chairperson of the National RSDI 2025 at Kochi. He conducts monthly diabetes education programs through dedicated YouTube channels and had been publishing a free internet-based diabetes newsletter for over 17 years. He has more than 300 publications. And Jyotidev Diabetes Center is an ITF-recognized center of excellence in diabetes care and education and is accredited for the RSSDI certified course for diabetology for doctors. Dear friends, before I close and invite him to give the oration, I must also tell you, Jyoti is the son of a game changer, a poet par excellence, a famous orator, famous writer, whose the country has recognized. Dr. Keshavdev Jyotidev is the son of Professor Keshavdev. And Jyoti, I invite you to accept this great honor to have Dr. Jyotidev Keshavdev delivering the Padam Shri Vinod Kanungo oration. And I have read about him. I will not take time to read all this. It is my honor now to kindly present the honors to him. Can I have the presentation of the honors? RX7, can we have the virtual presentation? Or we can start the oration. We'll have the presentation at the end of the oration. what Jyoti is going to speak about is insulin pumps and AID
Namaste from
It has
Trivandrum.
started. It is started. Sound.
In Kerala. I know the importance of this memorial lecture, and I am very glad and delighted at this opportunity. Let me start sharing the slides. In the next few minutes, I'll be discussing on the present day pumps and the future of automation. But before that, let me remember the outstanding personality, Padma Shri Binod Kalingo, the beloved father of Dr. Alok Kalingo. Binod Kalingo is well known as a freedom fighter, educator best known for single-handedly compiling Jnana Mandala, and that is the most comprehensive encyclopedia in Odia language. Let me thank Dr. Ashok Kumar Das sir for giving me this opportunity. With these words of introduction, let me now move on to the topic which is allotted to me. And let me start with a storyline. And these are some of those old pictures. And this is almost 24 years now when I was a fellow at the Department of Endocrinology at the Mayo Clinic in Rochester, where I got trained in insulin pump therapy and the continuous glucose monitoring systems. And only insulin pumps were popular at those times. And when I was back in India, I soon realized that these devices are not available in our country, whereas there are thousands of patients, both type 1 and type 2 diabetes, who deserve, who are eligible, who can afford these life-saving devices. And then the journey began. And if you look at this picture, this is when I was working in the government medical college before I began our own hospitals. This is Adrian Good introducing two devices, and sitting on my table, you can spot on two devices. One is the first ever continuous glucose monitoring, that is a CDMS Gold, and the other, the insulin pump from the United States. And in 2004, when the insulin pumps were launched, they were the refurbished pumps from the US. And soon it got replaced by the Paradigm insulin pumps. There are some fortunate children in our country. I do have more than hundreds of children, and this is one among them. I have deployed an insulin pump. You can see the tiny pump over there. And this is when the child was only 6 years old with a diagnosis of type 1 diabetes. And now the same girl is now grown up. She is 23-year-old professional. She's a dancer. And she's having a consistent ER around 80 to 85%. And no time spent in significant hypoglycemia. And now, why fortunate? The reason being, these are fortunate children not born in a rich family. They are average from a middle class family, but the parents were aware of the importance of devices for managing diabetes. And these fortunate children were the ones who had upgraded the devices once in every 5 to 6 years. And now, for the last 2 years, she is on 780G, the automated insulin delivery devices with no complications of diabetes, with, I would say, profound quality of life, which is most important in diabetes, quality of life. That counts. And over the years, from the journey from a Paradigm insulin pump 722 to 640 to 780G, you can see the significant improvements in all the glycemic parameters, the mean glucose, the time in range. And now it is a possibility. The dream has become a reality of accomplishing a time in range consistently above 70%. And this has been the journey in our country. from 2004 onwards. With all humility, let me tell you, I have been in this journey from the beginning onwards. From SAP to low glucose suspend, that is the threshold suspend pumps in 2012, to predictive algorithms which can stop the delivery of insulin even before the onset of a hypo, and the 2022 launch of advanced hybrid closed loop systems. And that has been phenomenal. And that is when we started observing a TAR of more than 70% in people, even with type 1 diabetes. So now the dream of parents, the dream of patients, the dream of children, the dream of all the doctors like you and me, it has become a reality. And if somebody is asking you to define an automated delivery device, it is a new term for artificial pancreas, where you have a wireless networking of sensor, the insulin pump, and an algorithm. These are some of the terminologies that you can remember. SAP stands for Sensor Augmented Pump, and that was originally launched in India in 2006, as I have shown you earlier. These are not closed loop systems, they are not connected, but the sensor will display the glucose levels. And in the low glucose suspend, it will suspend insulin delivery when there is a hypo. And in the predictive low glucose, it will predict the glucose before the onset of a hypo and can stop it. But they were never closed loop systems. They were only partly closed loop systems. And now let me discuss the generations of automation, from first gen to second gen to the future of automation, and that is the fifth and the sixth stages. Currently in 2025, we are in the fourth stage of second gen automation, where there is automation of both basal and bolus. But I would say that 20 to 30% is still manual, still manually operated. But the stage 4 of automation is a phenomenal step forward when compared to the earlier stages. And it is no longer an insulin pump therapy. It is controlled by an algorithm which can sit inside the pump or the pod or even in the mobile health application. And most of the currently available systems can connect to multiple sensors, not just one sensor. So how do the system adjust insulin? It is slightly complicated. It gets the input from the CGM, and it also assesses the rate of glucose and also the magnitude or the direction of change of glucose. It can predict the glucose at least 30 to 1 hour, 30 minutes to 1 hour in advance. And multiple systems have different thresholds to set. And some of them requires manual setting to begin with. So now, if you have a serious question, I am having a very bad throat. Sorry for that. So if somebody is having a question, why do you require so expensive automated devices for insulin delivery? Why not insulin pens? Are they not sufficient? The answer is 70% of type 1 people and at least 5 to 7% of people with other types of diabetes, they require automated insulin delivery. Whatever you do, whether it is continuous glucose monitoring, paired with insulin pens, or independent along with an insulin pump, they will never reach a timing target of more than 60 or 65%. And more than 70 is possible only with automated insulin delivery, which will change. For example, with Minimed 780G, it will keep on changing the basal rate every 5 minutes. And once it reaches the maximum basal, and if the glucose is still on the higher side, it will deliver once in every 5 minutes micro boluses. So that is now available. In India, it is available for the last 3 years. Don't confuse automated insulin delivery with a pump. It is no longer an insulin pump. AIDs, this is from our own clinic where we published the data on the first 20 to 25 people on 780G reaching a target of more than 80%. And when I say more than 80%, this is again with negligible time below range or acceptable time below range, which has never been a possibility before this era. It can never be possible, especially in type 1 diabetes. And the people are celebrating. They are excited with the innovation. Better sleep, no worry about hypoglycemia, hypo-free nights for the first time, sleeping peacefully at night ever since the diagnosis of a diabetes. User satisfaction is very high, but there are challenges. That is why we need further more advances. But if there is a question on which is the best device currently, the best device is the best technology currently available. And that is true for 780G, and that is true for the smartphones as well. And in the upcoming smartphones, there will be better innovations. But the currently available one is the best which we can recommend to our patients. And this is International Journal of Diabetes and Technology. I am the editor-in-chief where we publish papers related to advancements in technology. And this is a historical review on how the delivery devices have advanced over the last more than 100 years, ever since the diagnosis, ever since the launch of insulin. So when compared to the ordinary or standalone insulin pumps, the AID systems have algorithms. So it is algorithm driven and not user driven decisions. And CGM is mandatory. So this is something which I wanted to stress upon. If you are recommending an AID to a patient, tell them that without a continuous glucose monitoring sensor, it is useless. So never use it as an insulin pump, use it along with the CGM, and then only the algorithm can automate insulin delivery. So this is the current space, the global space, I would say, the landscape of the available systems globally. I have listed around 9 automated insulin delivery devices. There are merits and advantages, merits and demerits for each of these devices. 780G is the only commercially available device in India. Omnipod is the most popular patch pump. No strings, no tubes, and the algorithm is smart adjust, whereas Minimed has got an algorithm and they call it smart guard. Tandem is again a very, very popular AID system with control IQ algorithm. These 3 are approved for type 2 diabetes. So if you look at one example, for example, Minimed 780G, it was compatible only with the Guardian sensors, but now Medtronic Minimed has got a new sensor that is simpler, and now it is also compatible with Libre sensor. And the Libre 3 Plus sensor, which is made only for 780G, they call it Instinct sensor. It is soon going to be available in India as well. And with Omnipod, more than 100 Omnipod users are there in India, the patch pump. It is compatible with Dexcom G6, G7, Libre 2, and even 3 Plus. And this is one algorithm which is recommended, strongly recommended in pregnancy, because the requirements are different, the thresholds are different, and that is the CAMP APS effect system. And this is another space. So the automated insulin delivery devices can be divided into commercial, and the other one is open source AIDs, which are created by the patient community. You have the Loop, we have Android, and so on, which is outside the scope of this discussion. But we do have a review article published by us on DIY, which is referred to by ADA, AS, etc. in their guidelines. So this is the RSSDA recommendation. Every recommendation, whether it is RSSDA, our own organization, or is it American Diabetes Association 2026 Standards of Care, everyone recommends devices to be used in diabetes. And AID is the preferred delivery method over injections and even insulin pumps. and over the old sensor augmented pumps in type 1 diabetes. Universally, this is recommended. And other types of diabetes, including type 2 diabetes, when there is an indication. And you have to go for devices based on individual circumstances, preferences, and needs. That's also important. So now, whether the patients are happy or not, with the currently available systems, of course, the patients are satisfied, the parents are happy, but they are waiting for much more. Look at one of the most expensive devices. So this is a comment about the minimal 780G, difficult to adjust the post-meal hyperglycemia. I have to cheat the carb entry. Auto correction boluses are taking a lot of time for correction. Still, it is heavy, it is big, it has got a tubing. So obviously, the patients are not happy with any of the currently available devices. They, of course, they are happy with the innovations, but they are waiting for much more. Even for the patch pump. This is with Omnipod, one of my own patients. And at school, there is a CGM alert, and remotely the parents are receiving the alert. The glucose is more than 350. So the child is heading for a diabetic ketoacidosis. And soon they realize that there is a leakage in the pump. So it can happen. So all these technologies can fail. So those who are doctors who are recommending the technology, those who are patients who are the end users, they should be willing to get trained and also should have the knowledge, expertise to troubleshoot in case of emergencies. And these are some of the complications of infusing insulin via the pump. It can get occluded, not that uncommon. Pump occlusions are relatively common. Lipohypertrophy, then cost and affordable issues. Accessibility, that is a big issue, the biggest challenge globally. One of the reasons for inequality of care in type 1 diabetes. And then some of these big devices are interfering with the daily routine activities and of course the financial burden. And now it is time for us to identify the challenges and it is time for us to overcome the prevailing challenges. And multiple challenges are there. And the dreams are also, the wish list is also a long list, completely a hands-off system with no carb counting and with no user announcements when compared to the currently available hybrid closed-loop systems. And that is the future. That is the fully closed-loop systems we are looking for. And this is a question for you. Will fully closed-loop systems a reality in the next 3 to 5 years? And the answer is, it's going to be 100% a reality. And in the DIY community, already some of these algorithms are popular. And all these advances are thanks to not insulin pump, it is thanks to the algorithms and thanks to the rapid advancements, I would say, for reliable continuous glucose sensing. And this is from Roche, the AccuCheck Smart Gauge CGM, currently available in 3 markets in Europe. And it has got a neural network algorithm, XBoost decision tree-based classification model. And this is for prediction and for forecasting, even for nocturnal hypoglycemia before going to sleep. So when all of these get integrated, when it gets incorporated with automatic insulin delivery, definitely it is going to be far, far better. Currently, there are 2 different apps, but it will actually, these 2, one is a CGM app and there's a Predict app. It will be together available in the My Sugar application. And this is Instinct from a 780G, and that is from the Abbott family, which is custom made for 780G. So the future is already here, and there is mix and match with cross-company collaboration, which the doctors and the patients were looking forward to for so many years, and now it is happening. And this is Damiano and his son David, who created an insulin pump for his son with type 1 diabetes. And these were originally DIY, but now it is an FDA approved system. So happy to witnessed their relatively big booth at the ADA in 2025 at Chicago. At 2024 also, I visited their small booth. So the DIY community is also getting approved and they are commercializing with much better devices. This is twisted system, another AID, and this connects with the tide loop, and that again was originally a part of DIY community. Very small. You can see the size of this pump. You can compare it with the size of my palm. So let me now briefly go through stage 5 and 6 of automation. And these are AI-powered algorithms with the digital twin helping doctors and the clinical trial personnel. AI systems train and practice how to keep glucose in range. And this is a copy of insulin and glucose dynamics in the body. I will go through one or two studies, and this is the ABC study, which stands for Adaptive Behavioral Component. So just imagine that you are in a self-driving automobile and you are trusting the car, you are sitting relaxed, and the car learns the road. In the next stage of automation, that is with Adaptive Behavioral Component, it upgrades the car brain to precisely predict the traffic, the favorite routes, and so on. So when you are comparing these two algorithms in tandem control IQ, with the integration of the ABC and the BAM, there is improvement in TA and also improvement in time in tighter range, and that is between 70 and 140. And driving towards, and the future will be fully closed loop systems with the help of algorithms, where we are identifying the challenges, because the currently available rapid acting insulins may not be that rapid acting. So they have a bolus priming strategy. So the moment the meal is recognized, that is automated recognition of the meal, then a bolus will be delivered. So in the bolus priming strategy, there is control of glucose much earlier, and the glucose has gone back to baseline also much faster when compared to no bolus priming strategy. And the third generation, sixth stage will be multiple hormones. So we had multiple earlier clinical trials with insulin and glucagon, but now there are further advancements, and this is a AI-enabled model predictive control algorithm for insulin and pramlintide. So with insulin and pramlintide, there are meal detection and dosing algorithms. There is a dual hormone MPC core algorithm, and there are different strategies for pramlintide delivery, such as a co-formulation, fixed ratio of pramlintide with insulin, basal only, independent. So if you compare with insulin only MPC, which is only 64.1%, the time in range which has been accomplished with the dual hormone with fixed ratio or independent is more than 90% and 90%. So these clinical trials, some of them in silico experiments, so they are actually accomplishing much more better time in range. So currently there are devices already in the market. This is from the Libre family. Alongside continuous glucose monitoring, there is continuous ketone monitoring as well. As O'Neill once said, you may never require an airbag in your automobile, but once that airbag can save your life. And the same significance is with continuous ketone monitoring alongside continuous glucose monitoring. So the future will be continuous monitoring of multiple other parameters as well. And this can also connect the automated insulin delivery devices. I'm stopping here with a conclusion. Let's believe in the magic of all those technologies. And with the pace of automation in this space, I am pretty sure that very soon we will have much affordable life-saving solutions for people living with diabetes. Let me, with the consent of organizers, invite all of you to the 14th year of JPF convention in the city of Trivandrum in the month of July 10th, 11th and 12th. Thank you again, Dr. Alok, Dr. A.K. Das sir, and the team for inviting me and giving an opportunity to deliver this memorial, a very prestigious lecture. Thank you so much.
Jyoti, thank you very much for a very updated, like a scientific fiction, starting from the 2004 pump going to FCP, which is the latest, and also talking about the AI-enabled pumps, the pumps which can predict hypoglycemia coming in next 30 minutes, etc., etc. I have no words to compliment you, but I must tell you that this will go down in the history of 12 years of NUCD as one of the best orations centered around modern advances. Jyoti, thank you very, very much. Big round of applause for Jyoti. With that, we finish this and we pass on to the session 1. Dear friends, me and Alok will set the context. I'll start and then Alok will take over. Now, dear friends, I call it one of the most important cream de la cream sessions. Why do I call it? You know what is the buzzword of diabetes care today? The buzzword ECKLM. We should provide treatment in diabetes today for organ protection like cardiac protection, K for kidney protection, L for liver protection, and metabolic protection. I will not take any more time, but I must tell you, this center is centered around that, bringing liver to the center of the metabolic syndrome. And liver is an organ credited with producing and contributing maximum to the diabetes onslaught of masses, centered around the heart failure, the most important concept in diabetes, most important malady, centered around the glycemic durability with the contribution of Buildup plus metformin, the verified trial, and also most important, the kidney protection, etc., etc., Wilina and IMPA. With this, I will invite the first speaker, hand over to Alok. After that, he will take over others. I invite Professor Dr. S.K. Sharma. Can I have his biodata, please? Professor S.K. Sharma, please. Biodata. I don't need biodata to include Professor S.K. Surinder has been a veritable contributor in the field of diabetes. He has been the DM-Endo from PG Chandigarh in 1993, consultant endocrinologist at the famous Galaxy Center, past professor at the MGMC Jaipur, chairperson Diabetes Welfare Society, chairman Diabetes Thyroid Endocrine Conference, the TECON, and foundation of India. He has been in the CCDM course, awarded orations at Vijayawada and many other places. Dear friends, it is my great pleasure and honor to present to you Dr. S.K. Sharma to speak what I told the most important topic, interlinking mast cell, or what we call previously, whatever name you called it, and diabetes. A call for integrated diabetes care. Surinder, all is yours. Can you have the talk, Hardik? Yes. Yes.
Yes, he's there.
Yes.
Good evening. Good morning, dear friends. I'm thankful to Dr. Kanungo for inviting me in his conference. Today we are going to discuss a subject which is very interesting, that is interlinking MASLD and diabetes, a call for integrated metabolic care. So dear friends, we all know there are three epidemics which are going on. One is obesity, other is diabetes, and now we all realize that there is a epidemic of MASLD, what we say metabolic dysfunction associated steatotic liver disease. And you can see that our large number of population is suffering from obesity. There is large number of patients who are diabetic, and among our general population, 30% of patients are suffering from MASLD. We all know the complications of diabetes. We usually discuss microvascular and macrovascular complications. But today we are going to discuss a emerging complication just like cancer and infection. Today we are going to discuss liver disease in our diabetic patients. So here you can see that MSLD prevalence in our population, in our comorbidities are very common. So you find that 90% of patients of obesity, 70% of diabetes, and 68% of patients with hypertension are also suffering from MASLD. It is a steatotic liver disease which is seen in 60 to 70% of our type 2 diabetic patients, and it is having, you can say, silent features to start with, and it ultimately progresses to hepatitis and then to cirrhosis of liver, and many of patients develop hepatocellular carcinoma also. So this is the progression of this disease. From a healthy liver, it goes to patients who are having more than 5% of their hepatocytes having fat. Then it progresses to MASH, that is metabolic dysfunction associated steatohepatitis, where there is a steatosis along with ballooning of the hepatocytes, inflammation and fibrosis. And then many of them progresses to chronic condition like diffuse fibrosis, severe dysfunction and cirrhosis of liver, and 7% of these patients may develop hepatocellular carcinoma. So important thing is there is a slowly progressive disease of these patients. But in diabetes, the progression is very rapid and very severe. As compared to patients without diabetes with MASLD, you find that patients with diabetes and MSLD, you find that there is a large number of patients who are progressing from simple fat accumulation to MASH, and then 20 to 25% of them progresses rapidly to cirrhosis of liver, and they have a very high mortality, and 5% of them may develop hepatocellular carcinoma, and this is a very important cause of liver transplant in our patients. Type 2 diabetes is an independent risk factor for the fibrosis in liver, and in this study they looked into liver stiffness measurement, and they looked into within a period of 8 years there is a significant rapid progression and fibrosis in patients of diabetes as compared to those without diabetes. Insulin resistance is the root cause of MASLD, and you can see here that insulin resistance lead to there is a dysfunctional adipocyte releasing large amount of free fatty acids and triglycerides. In addition to hyperinsulinemia and hyperglycemia, a healthy liver is now converted into a fatty liver. With inflammation, apoptosis and oxidative stress, it goes into hepatitis, that is MASH, and then ultimately end-stage liver disease like cirrhosis. Other environmental factors and genetic factors are also important in the development of MASLD. So mechanism, if you look, there is a inflow of fatty acids from the adipocytes, from the dietary source. There is a de novo lipogenesis occurring in liver because of insulin resistance. There is a decrease in triglyceride secretion from the liver, and there is a decreased fatty acid oxidation in the liver. And type 2 diabetes and MSLDs are now considered to be the two sides of the same coin because of the common pathophysiology, and insulin resistance is considered to be the main, you can say, risk factor here, and it drives the problem in our diabetic patients also. So we find that there is a insulin paradox which is occurring here. You can see here that on one hand there is a resistance to the insulin action at the liver, so that liver continue to have increased hepatic glucose output. On other hand, in spite of insulin resistance, the liver is continuously producing fat production, and you find that de novo lipogenesis is occurring in the liver in presence of insulin resistance. Dear friends, there is a correlation of diabetes with MASLD, and you find it in twin cycle hypothesis, which says that there is a positive calorie balance leads to increase in caloric deposition in the liver, and liver is converting it to the free fatty acids and triglycerides, and de novo lipogenesis, then these lipids are now transported in the form of VLDL, and this VLDL is going and depositing triglycerides in ectopic sites, and one of the important ectopic sites is pancreas, where this increase in triglycerides lead to decrease in insulin response to glucose, and the patients will be having diabetes. So chronic caloric excess leads to accumulation of liver fat with eventual spill over into the pancreas, eventually causing inhibition of insulin secretion after meal and onset of hyperglycemia. And if we reduce the caloric intake significantly, then there will be reversal of diabetes, because cycle can effectively improve beta cell function. All the clinical guidelines from different bodies are highlighting that in your patients of type 2 diabetes, we should always warrant the workup for MASLD. So whether it is AASLD or EASL or ADA, all says that in this type of patients of type 2 diabetes, we should be always looking into and evaluating MASLD in these patients. So how to evaluate MASLD? First step is look at whether the patient is suffering from diabetes, obesity, or persistent elevation of AST and ALT. Then assess the alcohol consumption. Look at common comorbidities like cardiovascular disease, dyslipidemia, kidney disease, and diabetes, and also look at other conditions and to rule out other causes of chronic liver disease, and then look at polycystic ovarian syndrome, sleep apnea, etc., and calculate the cardiovascular risk with the help of some of the calculators like ASCVD risk calculators. The third important step is there is a stratification of severity of the MASLD, where we go for a FIB4 calculation. If it is less than 1.3, we say that a patient is normal, and we repeat this test every 1 to 3 years. If it is more than 2.67, then we say that there is a significant hepatic involvement and the patient requires hepatology reference. If it is in between 1.3 to 2.67, we take the help of fibro scans, and here we will measure the CAP, and patients are also looking into what is the amount of steatosis in these patients, and liver stiffness measurements are done. And if the LSM is less than 8, then we say that it is normal. If it is more than 8 kilopascal, then we say that problem is significant, and we can also go for ELF testing. So these are the blood-based non-invasive testing in MASLD. FIB4 score is very useful, which requires 4 things: age, AST, ALT level, and platelet count, and then other like NAFLD fibrosis score, and then enhanced liver fibrosis is requiring, you can say, it is accounting for 3 things: high uronic acid level, amino terminal propeptide of type 3, collagen level, and TIMP1 level, and it calculates the enhanced liver fibrosis in this patient. So how to manage these patients? These are the patients who are having diabetes as well as MASLD. So here lifestyle recommendations are very important, and weight is very important consideration. So if we can reduce the weight by more than 5%, there is a significant reduction in the liver fat composition. If we reduce it to 7 to 10%, then liver inflammation is reduced. And if we reduce the weight more than 10%, there will be improvement in fibrosis. So patients of MASLD require even significant caloric restriction and dietary modification and exercise. So we usually follow a Mediterranean diet, reducing saturated fat, increasing fibers, and giving vegetables, lentils, nuts, olive oil, and unprocessed poultry and fish. And we limit sugar, ultra processed food, and we avoid sugar sweetened beverages. And then of course exercise is very important. At least 150 to 300 minutes of per month moderate to severe exercises are very useful, and we reduce the sedentary time. Of course we will be avoiding smoking and try to avoid alcohol consumptions also. But it is very difficult to stick to lifestyle measures, as on one side we see that if we can reduce weight significantly, there will be improvement in steatosis, ballooning, inflammation, NASH, as well as fibrosis regression. But on right side, we can see that very few number of patients are sticking or sustaining the weight loss because of poor adherence to the lifestyle measures. So in type 2 diabetes and MSLD, the treatment algorithm according to the ADA 2025, on one hand, we adopt a healthy lifestyle, weight loss if required, optimal diabetes management, cardiovascular risk reduction, and need for metabolic surgery if patient is really obese like grade 2 and grade 3. And then we look into the severity of the fibrosis, whether MASLD without any fibrosis like F0, F1, and here the diabetic treatment is continued in this type 2 diabetic patient, and patients are helpful when you give GLP-1 receptor agonist or dual GIP-GLP-1 receptor agonist or pioglitazone and SGLT2 inhibitors. If the significant fibrosis is there like F2 to F3 at risk in this MASH patients, then of course we will prefer all these drugs which we discussed there. And this MASH pharmacotherapy in the form of resmetirom is now recommended. If the patient is having compensated cirrhosis, of course, we will be treating these diabetes as we just discussed. But now in compensated cirrhosis, we don't give resmetirom. And then in patients who are decompensated, of course, insulin is a treatment of choice in these patients. So looking into the pharmacological approaches, targeting the key pathogenetic mechanism of MASH, on one hand, we have to reduce the steatosis. Other hand, insulin resistance has to be reduced, inflammation, and of course, liver fibrosis is to be targeted. So these are group of drugs which are targeting all these aspects in the patients of MASLD and MASH. In a diabetic patient with MASLD and MASH, they say that diabetic patient require looking into fibrosis status. And if F0 and F1 fibrosis is there, then in addition to lifestyle, we will give semaglutide, tirzepatide, SGLT2 inhibitors or pioglitazone. If the patient is having significantly higher fibrosis like F2 and F3 fibrosis, then in addition to lifestyle, we can add here resmetirom in addition to all other drugs what we discussed. And saroglitazole is also considered to be a drug which is recommended in India by DCGI. So saroglitazole is a dual PPAR agonist. It is having PPAR alpha and PPAR gamma agonistic property. Alpha is looking into fat aspect and gamma is looking into the insulin sensitivity aspect, and it is showing significant reduction in the you can say FIB-4 score in one of the study. When you give it saroglitazole, there is a FIB-4 score of 2.13, which has reduced in 3 months to 1.7 and in 6 months to 1.4. So a significant FIB-4 index was reduced with saroglitazole. GLP-1 receptor agonists, we all know, are very useful, not only in diabetes, but also in MASLD and MASH. And here we have a study which is looking into this aspect. This is the ESSENCE trial with semaglutide, and you find that there is a resolution of MASH without worsening of fibrosis in 62% of patients as compared to placebo 34, and worsening or on the other hand, improvement in fibrosis without worsening of MASH in 36% of patients as compared to 22% in placebo arm. So with this FDA approved data, and now FDA is approving semaglutide 2.4 milligram per week as a drug choice for MASLD. Similarly, there was a study with tirzepatide by the name of Synergy NASH, and here again you find that there is a significant MASH resolution without worsening of fibrosis and more than one stage fibrosis improvement without worsening of MASH. And again, tirzepatide appears to be a useful drug, and it will be recommended, I think, in the future for the treatment of MASH and MAFLD. So SGLT2 inhibitors per se are not recommended yet, but we all know that they are reducing significantly glucose as well as weight of our patients. So if you look into concept of insulin resistance causing on one hand diabetes and on the other hand type MASLD, then we find that MASLD is a reflection of insulin resistance. So insulin resistance is acting at adipose tissue, muscle, liver, endothelium and platelet. On one hand, it is causing hyperglycemia. On other hand, it is leading on to increased cardiovascular risk. But in between, you find that these are the patients of MASLD, which are again because of insulin resistance. And pioglitazone is the good drug for targeting insulin resistance. So the primary action of pioglitazone is to enhance peripheral insulin sensitivity in muscle and adipose tissue. And secondary action is that it increases adiponectin, good hormone. It redistributes the fat, decreases free fatty acids, and decreases lipotoxicity, thereby indirectly improving MASLD status. So there are studies looking into the role of pioglitazone, which is a potent insulin sensitizer, which preserves beta cell function. It is having a durable reduction in HbA1c, corrects multiple components of metabolic syndrome, and improves the non-alcoholic fatty liver disease or steatohepatitis. So there are many myths regarding pioglitazone. One is that it causes heart failure. No, it do not cause heart failure. But if the patient is a susceptible patient for heart failure, fluid retention may worsen the existing heart failure. Pioglitazone always leads to weight gain. Of course, there is a small weight gain of 2 to 3 kg on an average, but it is redistributing the fat into the subcutaneous fat, which is less harmful as compared to visceral fat. And it improves the fat quality, improves adiponectin level, and reduces lipotoxicity. Pioglitazone increases the bladder cancer risk. This is one of the myths. No, we now know that it is safe and can be given appropriately in our patients of diabetes as well as patients of diabetes with MASH. Pioglitazone is outdated and should not be used. No, now there is a resurgence in the usefulness of pioglitazone, and we know that it is the best insulin sensitizer, having unique among all the oral agents which we are using in the treatment of diabetes. And here you can see that looking into pioglitazone and its optimum agent combined with SGLT2 inhibitors like dapagliflozin or empagliflozin. So on one hand, pioglitazone is decreasing stroke. There is a slight increase in the stroke by SGLT2 inhibitors. Myocardial infarction is reduced by both these drugs. Cardiovascular death is also reduced by pioglitazone as well as SGLT2 inhibitors. Heart failure, on one hand, you can say that pioglitazone precipitates a ill heart, but on other hand, SGLT2 are very useful in the heart failure patients, and fluid retention is there in pioglitazone, but SGLT2 causes fluid loss, so they counterbalance each other's side effect. And weight gain, why pioglitazone is also counteracted by SGLT2 inhibitors. So on one hand, you find that the role of this combination of SGLT2 and pioglitazone in patients with metabolic continuum, blood pressure is reduced, HbA1c is reduced, insulin sensitivity is improved, and beta cell functions are improved, and renal disease is reduced by the combination of pio with SGLT2. So there is a mechanistic synergy of dapagliflozin plus pioglitazone. There is a sustained glycemic benefit in combining these two drugs, mitigating the effect of weight gain and fluid retention. And dapagliflozin is useful there. Direct removal of glucose by dapagliflozin improves the insulin sensitivity action of pioglitazone. And once you see benefit and risk therapy of these two drugs are very useful in type 2 diabetic patients, and they also reduce blood pressure. So these are some of the studies which looked into FIB-4 score in pioglitazone alone, in SGLT2 alone, but in combination you find that there is a significant FIB-4 score reduction in these patients. There is another study which is a fibroscan mediated study. Again, there is a 86% favorable effect in reducing the, you can say, liver stiffness, and this is a combination of pioglitazone with dapagliflozin, and this combination appears to be effective, safe, and practical for MSLD management in our diabetic patient. As we discussed that resmetirom is another drug which is a thyroid hormone receptor beta agonist. It is approved by FDA in patients of MSLD with a fibrosis score of F2 to F3, but it is avoided in F4 and a significant fibrosis in like cirrhosis. But this drug is very costly and not yet available in India. So the drug which are approved for our usefulness in India is that anti-diabetic drugs like pioglitazone, SGLT2 and GLP-1 receptor agonist for treatment of diabetes, GLP-1 receptor agonist for the treatment of MASH, and you know that the dual combination of tirzepatide is also useful in diabetes and reducing obesity. Resmetirom is useful in MASH, and dual PPAR gamma and alpha like saroglitazar was approved by DCGI in the management of MASH or MSLD. So dear friends, in the end, there are future directions making the integrated metabolic care in this situation where we are having a patient of you can say CRHM syndrome, where cardiovascular, hepatic, renal and metabolic diseases are coming in a cluster. So what they say is that we have to embed the MASLD screening in our diabetic patients, which because of so significant correlation of diabetes with MASLD, routine use of FIB score and using the fibroscan is useful. Exploring the therapeutic pathways like SGLT2, GLP-1 receptor agonist, and a combination of SGLT2 and this pioglitazone and then tirzepatide are very useful. And we have to look for collaborative care. We have multi-specialty, multifactorial intervention is required. And of course, still we need more research in this field of MSLD. So dear friends, in the end, in summary, we can say there is an increased epidemic of obesity, diabetes and MASLD. Insulin resistance is central to MASLD and MASH, which is developing and progressing rapidly in our diabetic patient. MSLD and diabetes are interconnected outcome of the same metabolic dysfunction. Type 2 diabetes leads to increased risk as well as rapid progression of advancing fibrosis, cirrhosis and hepatocellular carcinoma. Weight loss is very useful. 7 to 10% improves the steatosis, inflammation and fibrosis. Saroglitazar is a PPAR alpha and gamma agonist, which are approved by DCGA for the treatment of MAFLD and NASH. Dual therapy, as we discussed with pioglitazone and SGLT2 inhibitors, deliver comprehensive and durable control across the glucose, liver and heart. And it is a mechanistic synergy which is tackling the insulin resistance on one hand, hepatic fat and cardiorenal risk modification on the other hand. And the drugs like UDCA, vitamin A, vitamin E and omega-3 fatty acids or silymarin and orlistats are not recommended due to lack of evidence of their action in patients of MSLD in diabetes. So with that, I thank you very much. Thank you.
Thank you, Dr. S.K. Sharma, for a very vivid, very comprehensive lecture on a very important topic, MASLD. We'll be having the panel discussion where Professor Sharma will answer the questions subject to time availability. Now I call upon Professor Abdul Hamid Jargar, who is a phenomenon in the field of diabetes and metabolism, and he has been a very eminent endocrinologist. Can I have his biodata, please, and invite Abdul to kindly come to the make himself visible, and he's going to speak to us. Can I have him? Can I have Professor Jargar? And can I have his first slide? Professor Jargar is the very important person as a member of High Power Committee for the Government of India for the Vision 2035. Once upon a time, he presided all the three institutes, AIMS, PGI, and the Sanjay Gandhi as the chairman of the board. He has been won many awards, past president of the ESI, member of the MCI. No, he has many hats. Now, what I would say that in spite of all this, Abdul is a great friend, very simple to the core. And today he's going to speak to us on a very important thing that, diabetics get heart failure. They have HHF, hospitalized from heart failure, which comes again and again. He's going to speak to us how do we fast track this heart failure care to prevent HHF, to give optimal treatment to heart failure. We call it GDNK, guideline based care, and also with a special focus on SGLT2 and ARNI, which has become the cornerstone of heart failure management in general and diabetic heart failure management in particular. Over to Professor Jagat. Yes, Dr. Jagat, start.
Dear friends, this morning we're discussing heart failure and its management and what has changed in the recent decade. Very important contemporary topic, and what is the role of SGLT2 inhibitors and ARNI? ARNI, a combination of sacubitril and valsartan, neprilysin inhibitor and angiotensin receptor blocker. Now, this is very important. 1/3 of people with type 2 diabetes have established heart disease. And if you look at this cartoon, you will find out after coronary heart disease, the second most important cardiac complication is heart failure. And this heart failure did not get the attention so far what it deserved. In patients with diabetes, we always kept on talking about coronary artery disease, lipid management. As I told you, just look at this total study on almost 2 lakh people, 2 million people, 16.2% people having coronary artery disease, 14.1% having established heart failure, and then angina and peripheral arterial disease. Heart failure fundamentally means reduction in functional capacity and entails frequent hospitalization and very high morbidity and mortality. And it is believed in the Western world today, 1 to 2% of total healthcare is spent on the progressive worsening of this heart failure. If you look at people with diabetes who are 65 and above, look at the longevity. And the top line is in people who do not have a heart failure, means survival chances beyond 65 is almost 90%. And now look at people who have been having recurrent heart failures. And that speaks on its own in a big way about the possible mortality associated with heart failure. If we look at the diabetes component, we know that it's associated with hyperglycemia, insulin resistance, hyperinsulinemia, dyslipidemia, and most of the people with this type 2 diabetes have hypertension as well. Associated atherosclerotic cardiovascular disease, progressive narrowing of the coronaries, which with microinfarcts, macroinfarcts does lead to ischemic cardiomyopathy. Hypertension as such leading to hypertensive cardiovascular disease, initially left ventricular dysfunction, hypertrophy dysfunction, diastolic dysfunction, and then cardiomyopathy if it remains for a long time unattended. And in diabetes, the metabolic disturbances as such, which is sine qua non of dysglycemia, decreased glucose oxidation, increased free fatty acids, lipotoxicity, and disturbed cellular functioning, mitochondrial dysfunction, and increased oxidative stress. This can lead to cardiomyocyte dysfunction, 1, because there might be a macrovascular disease, and 2, advancing glycation and products get deposited into the cardiomyocyte, which makes them dysfunctional. Then in diabetics, we have a cardiac dysautonomia, the neurohormonal abnormalities, particularly abnormal activation of RAS system, which leads to fibrosis and cardiomyocyte hypertrophy. So this metabolic part, along with whatever it does to mitochondria and microvascular system and dysautonomia leads to diabetic cardiomyopathy. And all these together do lead to recurrent heart failures if not attended to in time. Now, first we talk about this Vimada or sucralfate-valsartan combination, which is a true drug combination. Sucralfate is a prodrug which is metabolized to neprilysin inhibitor. And what this neprilysin inhibitor does, I'll tell you in a minute. And second component is valsartan. Valsartan is angiotensin G1 receptor blocker. Just look at this. If you look at ANP, BNP, CNP, these are vasoactive peptides that are getting metabolized by neprilysin. And neprilysin inhibitor, which is ernie, sucralfate, and this active component, inhibits the degeneration or the metabolism of these vasoactive polypeptides, which causes vasodilatation. These substances, after vasorelaxation, will cause decrease in blood pressure, decrease in sympathetic tone and aldosterone levels, and decrease in fibrosis and natriuresis. This, on the one hand, helps the vascular system in easing out, relieving heart failure. On the other hand, when we block with valsartan, angiotensin receptor, again, angiotensin receptor activation will cause vasoconstriction. But once you block this receptor with valsartan, we again have vasorelaxation, sympathetic tone goes down, because this receptor, once it's active, does all these things. And once this is blocked, the two together work in a symbiotic fashion. Look at just the biological compact activity of this dual component substance. Vimada AT1 receptor blockade. So this has also been shown to increase insulin sensitivity. Vimada component, the neprilysin inhibitor component, increases natriuretic hormone, because neprilysin, as I told you, helps in metabolizing many of these hormones, so their half-life is truncated. But when there is a drug given that causes neprilysin inhibition, these drugs remain in circulation for a long time. So there is natriuretic hormone increase, which causes many of these actions that are salutary, including the salt excretion. Bradykinin is increased, and very importantly, this also has an innate DP4 inhibition activity, this neprilysin inhibitor. So there is a moderate increase in GLP-1, and beta cell function gets better. So that again, not only would help in heart failure, but might marginally impact also diabetes. The subsets of this sucralfate-valsartan combination analyzed: heart failure trial, paradigm heart failure trial, and also in diabetes, and looking at hemoglobin A1C as well as read for insulin. Now, in summarizing heart failure data with Vimada, just look on your left side. Subjects who have diabetes get benefited. Subjects who have recently been detected diabetes get benefit. Subjects who have pre-diabetes get benefited. People who never had diabetes but had a non-diabetes related heart failure get benefited. Overall, 20% reduction in hospitalization for heart failure. Prior to this Vimada, enalapril was the standard management tool. And it is in comparison to a well-established drug that this add-on benefit comes on. Quality of life becomes better, because many times, effort intolerance decreases. Walking becomes difficult. A leisurely activity becomes difficult. Sometimes, depending on the severity of the heart failure, symptoms would worsen. And this is looking at the quality of life progressively getting better with Vaimada alone. And this also shows, I was telling you, that this has a marginal impact on GLP-1 because it has also a DP4-like activity, the neprilysin component. So you can see a marginal improvement hemoglobin A1C also in those people who have diabetes. And 20% reduction in the new use of insulin in patients. What would it effectively mean? That those people who were on follow-up who were diabetics, those who were on Vimada and those who were on enalapril alone, because in this trial, there's a standard treatment at that given time was enalapril. Basic data had come up from enalapril. Those who were on Vimada, succobutyl valsartan combination, 30% reduction in the need for insulin. And that is because of that GLP-1 elevation. And that's quite something to think of. Not only did it improve glycemia, and in 1/3 not requiring insulin, at least for some time during the trial period, this also did slow down the rate of fall of EGFR. So it means also had a renoprotective effect. Now, if you look at it before Vimada, what did we have? We had RAS blockers in general, as I was telling you. Enalapril was the drug that we're using. Beta blockers, different beta blockers over a period of time to look at the benefit unless there was a bradycardia. And diuretics are different types. And lipid-lowering drugs, believing that there will be an underlying coronary artery disease. And then came this early. In the last decade and a half, we have been using SGLT2 inhibitors in a very big way. And huge amount of data shows that they have a huge cardioprotective benefit. SGLT2 inhibitors as such. SGLT2 inhibitors basically brought to the market for managing diabetes. Then with the cardiovascular outcome trials, particularly starting with AMPERAG, and the renal benefit started with DAPA kidney, and then heart failure benefits starting with DAPA heart failure, and then all, AMPA heart. Benefits were shown to be beyond the glycemia. Heart failure data with dapagliflozin and reduced ejection fraction, amazing data in diabetics as well as in non-diabetics. Incredible data, and you can see it. These are data on non-diabetics. Cardiovascular death and hospitalization for heart failure remarkably decreased. And that what was the main aim of decreasing the hospitalization for heart failure and reduction in mortality. DAPA heart failure study, after DAPA heart failure study, SGLT2 inhibitors in particular became a good tool for managing diabetes, as well as coronary artery disease and heart failure. This study unambiguously shown there's a risk reduction in hospitalization for heart failure and cardiovascular death. And it improves the quality of life and improves symptoms, slows deterioration in kidney function over a period of time, as was shown by the DAPA CKD. This one cartoon tells you us about all contemporary SGLT2 inhibitors. If you look at AMPERAG, CANVAS, DECLARE, if you look in this slide, the lower two lines, hospitalization for heart failure and kidney outcomes. In primary outcomes, 3-point MACE or cardiovascular death, there might be some difference in the data because the patient studied were different. But whatever patients were studied with SGLT2 inhibitors, including dapagliflozin, marked reduction in hospitalization for heart failure, almost 1/3 reduction. That's remarkable. And remarkable reduction in renal outcomes also. So empagliflozin in this study was studied in patients who had heart failure with reduced ejection fraction. You can see the benefits. risk reduction by 25%. Heart failure risk reduced, hospitalization reduced in a remarkable way. And then Emperor Preserved also looked at people who had symptoms, but heart failure, left ventricular function was preserved. It was better than 40%. Reduced is less than 40%. And you can see it in that group also. If you look at males and females, both benefited. Diabetics and non-diabetics both benefited. EGFR overall benefited. Atrial flutter fibrillation reduced. The same data had come up with many studies from about dapagliflozin as well. And this summarizes this whole thing. Story of SGLT2 inhibition in heart failure. Preclinical or clinical stage or detectable cardiac involvement. Data available in all these areas over the last decade, more than a decade. Overall benefit with them. So they became sine qua non of not managing only diabetes, but also managing heart failure. And not only managing heart failure in patients in diabetes, but in non-diabetics also who had other forms of cardiomyopathy, left ventricular dysfunction. This is a paper that some of the senior guys from the country published summarizing this whole area on concurrent management of diabetes and heart failure, epidemiology, and I'll not get into the details of that with diabetes or without diabetes. The only point is, when you have diabetes, when you have hypertension, you have obesity, you have dyslipidemia, you have a possibility of a kidney disease, a coronary artery disease, always look for signs and symptoms of heart failure. And the sooner we start the treatment, the more cohesive treatment we start, the better the outcomes. And today's guidelines, what do they tell us? This summarizes the whole underlying pathophysiology and all. Today's world, the sooner we start treatment, the more drugs we give initially. We may give a smaller dose of more drugs. Current guidelines do advocate giving multiple drugs with different actions, even if they give them in a smaller doses, because sometimes, giving multiple drugs may be having problems of electrolyte disturbances, managing blood pressure. So even if we have to progressively start a smaller dose of a secopetal valsartan combination, starting with a smaller dose, then over a period of time escalate it, and then simultaneously start a smaller dose of a SGLT2 inhibitor, and whatever beta blocker you choose, or a diuretic we choose, or angiotensin receptor blockers are a part of this, and many newer drugs. The point today is, initially we would give one drug and then build on this. But now we believe that we need to give more than one drug, even though we give them a relatively lesser dose, and give them simultaneously and escalate the dose in a rather quicker period rather than waiting for months together, because the prognosis of this is pretty bad. And this is a data that we published last year about the global data about the diabetes, because why it's important. We have today the one-fourth of the total diabetic population in the world living in our country. And many of those, if you look at the diabetes is not very well controlled. You can see even in the Western world, this is US, high income. Diabetes care becoming better, but still a significant group not getting a treatment. And this is us. Even though in the last 3-4 decades, diabetes management is getting better, but we are nowhere near it. And this means the underlying complications, particularly vascular complications, renal complications, are very high. We have a very high index of coronary artery disease already. We have been screening people for hypertension and its management regularly. We have a very high index of suspicion of renal dysfunction, retinal disease. But this heart failure did not gain the attention that it deserves. So in summary, I would say heart failure is still under-recognized and misdiagnosed. And this has significant clinical implications in terms of prognosis, in terms of management, and particularly in diabetics. The incidence of heart failure is 2 to 4 times higher in people with diabetes than in those who do not have diabetes, but who have other predilections like obesity, CKD, dyslipidemia, hypertension. So the sooner we make that diagnosis, the sooner we take a call on the current guideline-directed multiple drugs, the better for all of us. So the key message is make a diagnosis early, institute the proper therapy early. Not only will we have and combination therapy, more than one drug. You don't have to escalate over months together. You simultaneously give the drugs. Even if there is a problem, give smaller doses. Watch for any side effects, and the outcome is going to be amazing. Thank you so much.
And very comprehensive. You have not left anything untouched. Dear friends, I do realize that we are going a little late in the program, but this is so fabulous, so well designed and so well delivered. So we'll see, we'll adjust the time during the discussion. But Jargar, I offer on behalf of all of us sincere appreciation for covering all the aspects of the simple drugs that we use, the ARNI and the SGLT2. Also alluding to the other drugs which can be used in the heart failure and how that changes the scenario. Now it's my great pleasure and honor to invite Dr. Rishi Shukla. Rishi, and can I have Rishi's presentation? Rishi is here. Rishi is one of the most important endocrinologists of our country. He is director and head of the Department of Endocrinology, Regency Hospital, Kanpur, owner and chief consultant of the Center for Diabetes and Endocrine Disease in Kanpur. He is an authority on the type 1 diabetes and of course also in type 2 diabetes. He has about 60 plus publications. His area of interest, diabetes education, social issues and type 1 diabetes. Invited faculty in the EASD and various other international organizations, and he is part of the CDIC, Changing Diabetes in Children, and also has kept the flag high. Recently, he hosted the ISPAD meeting, which was absolutely fabulous. And Rishi is going to speak to us. Very important, this synergy, from durability of the combination to synergy, the vildagliptin and its combination in beta cell optimization and glycemic longevity or glycemic durability. Over to Rishi.
Thank you, sir, for the kind words. We missed you in Kanpur, and thank you. Good morning, good afternoon, Dr. Jargar. I'm seeing Alok also
For Jargar, it's always good evening. He is always in the clouds.
He's always in the cloud.
But for even me, it is good day.
Let me share my slide.
Yeah.
Sharing screen in a minute.
Can you, Stuti, help Professor Shukla to go back to now he's come back to slide.
Yes. I'm just.
This is a very sensitive system. The moment you touch a little, shake it, it goes to the different screen. Yes, now it is okay.
My slides are visible.
Can you make it full?
Yes, I'm trying to make it full screen. Just a minute.
Yeah, correct. Absolutely correct. Good.
Is all visible? Yes. I'm moving also. Yes. Thank you, Dr. Ashok Das sir, for the kind words, and your introduction increased my blood, so I'll be enthusiastic in next 10-15 minutes and seeing all my friends. I'm going to talk nothing big, but a basic thing about vildagliptin, but I'll try to create some interest. Actually, the story of diabetes starts much before. And as diabetes progresses, all of us know, but what is required is if we can intervene much before the obesity level or the pre-diabetes level, and then we grab at this stage and we can do a lot. And actual intervention is needed at this stage. And if you look at your right side, there is a slide where the beta cell reserve is there. I think Dr. Jargar is there. We have been taught, our mentor is same, Dr. Dash. So we have been taught long back that the basic culprit is hyperinsulinemia in all metabolic diseases, which stands true even after I've been working as endocrinologist for last 32 years. So we need to tackle the hyperinsulinemia, and at the same time there is a relative beta cell deficiency that we need to address. There are a lot of unmet needs in type 1 diabetes in the Asian population. Increasing prevalence of diabetes and high prevalence in between 50 and 60 years, but not only in 50. We have started seeing a lot of young people developing diabetes, and the worst part with them is the beta cell reserve is much less, and they land up with full doses of oral hypoglycemic agents, and then they remain uncontrolled for very long, and they end up with the complications. So the risk of complications is more, and high cost of not treating type 2 properly. Actually, cost is not very high. Every time people talk about the cost, and I don't believe in cost, I believe in mindset. In our city, people can spend 2,000 rupees in pan masala, or in other parts of the country, they can spend 3,000 or 4,000 rupees in 2 drinks per day. Why can't they spend 2,000 or 1,500 rupees in controlling their blood sugar? And now with availability of all those medicines in such a cheap rates, companies have reduced the price. The other modalities are also there. So I think the basic problem is not, of course, basic problem is to understand that they need to control their diabetes, and they should be really careful. And the problem is that they don't understand this. And another problem is probably we fail to make them understand that this is asymptomatic disease and we need to be really careful. And so it is difficult to control the diabetes. Stop. Am I not visible? My slides are not visible there?
Visible.
Okay. What to do with the individual control for glycemic control? I'll be discussing a bit about vildagliptin. This is an old salt, and we all know probably it was the first salt that we were introduced, and afterwards came the sitagliptin. There is low risk of hypoglycemia, ease of the safe medicine, long-standing diabetes we can use, elderly population we can use, cardio, renal safe, and it has a sustained action. And verifying the forces of beta cell, the verified trial that came, it also enhanced and strengthened our understanding. And it was the first study to demonstrate long-term glycemic durability in vildagliptin metformin combination in people with newly detected diabetes. An individual presented with early DM diagnosed with HbA1c range between 6.5 to 7. So the A1C was not very high, and at that point, if we look what happens, then we looked at the A1C, blood sugar, and the HOMA-B model, which is the model for insulin reserve in the body. It is a mathematical model. We need to feed the blood sugars and a couple of other things and the insulin levels before and after therapy. And it was the first large-scale prospective study of its kind. And it offered the unique opportunity to examine the benefits of initial early success in type 2 diabetes in setting. In context to other setting, if you look at other trials on right-hand side, there VADT, lead et al., where intervention started much later, even TCOS. Here, the intervention started much earlier, like UKPDS. Of those of you recall the DCCT trial, diabetes control and complication trial. There also intervention started early. So if you start intervention early, it is easy to control, easy to maintain, and easy to sustain. So it is like a marriage from day one. If you behave properly, it is easy to sustain and maintain it for long and forever. The sub-analysis showed The sub-analysis showed significant improvement in HOMA-B model, which is the model for insulin. So beta cell function were preserved, and we all know that all DPP-4 inhibitors, they reduce apoptosis. So the compliance was more, because if patient is maintained on one tablet, they will be comfortable. So it was easy and it is safe for CV prevention and with it durable glycemic control. So 100 milligram is a sustainable agent. It has a 90% DP4 inhibition throughout the day. If you look at the time in range, so as time passes, we focus it on your left side, baseline versus 1 week, 2 weeks, almost 70% time in range. So whenever you look at time in range, you should always wait for a while, for a week, and then you look at the time in range. So more is the duration, better is the time in range, because by the time medicine truly starts functioning well. The hypertension, with and without hypertension, it was tried, and it was found that there was no difference in HbA1c with well-diagnosed platform information. If you look at right-hand side, this was information to me. My understanding was DPP4 inhibitors are blood pressure neutral salts. But if you focus on your right side, the baseline and the follow-up, the blood pressure control improved. The grade 2 blood pressure on baseline from 68% was reduced to 46%. So blood pressure control, it has some role in blood pressure control, so which is again an information to me. We always talk what is difference between Vilda and Sitavi, and it has been a long time debate. So this was a prospective trial on Vilda versus sitagliptin, and at 3 sites, and Professor Jargar was also part of this trial, and patients were randomized to receive either vildagliptin or sitagliptin, and it was 84 days, so very long duration of trial, and almost 2-3 years back this trial was done. And look at the A1C value for all 84 days. It was comparative. Something similar was seen in blood sugar fasting and PP. Here you can see the glimpse more closely. Look at the vildagliptin. The A1C fall was 1.3 versus 1.11. However, it was not significant. The fasting blood sugar fall was little more. The prandial was more or less same. There is a need for CV risk protection. Adding to the cardiovascular continuum, patient on the left side present. So moment diabetes starts, even moment obesity comes, obesity, hypertension, endothelial dysfunction, and this builds up the story. There is endothelial dysfunction, if it is prolonged, the atherosclerosis, cardiovascular disease, then other coronary event, and finally myocardial infarction, heart failure. And not only this, it covers other parts of the body like cardiorenal or cardiohepatic renal. So this is the continuum, and if we start in the beginning, start grabbing in the beginning, so it is easy and we can reduce endothelial dysfunction or make it normal. These are the fixed dose combinations of DAPA and the vildagliptin, and if you notice the middle two slides, percentage of patients, so up to 1.28 on an average A1C reduction if you use the fixed dose combination. However, up to 3 A1C reduction was seen in a subset of patients. In cardiology practice also, and the best part of I think today's presentation is we have almost all the data from India. If you look at the systolic and diastolic blood pressure, this is again the interesting thing which I have shared. There is little fall, but with dapagliflozin, we have noticed. However, we have not noticed this with well-degliptin. So to sum up, it can be used as a monotherapy and a combined therapy, 50 milligram, 100 milligram with metformin, with DAPA. So we can use it with, except I think GLP-1, we can use with any combination, and it is found to be useful. It is cardioprotective, not cardioprotective directly, but it has a role in terms of good control to begin with and sustaining the long-term glycemic durability. So we have a plethora of clinical evidence to prove efficacy and safety, assurance of earlier and better glycemic control, benefits of durability, low hyper risk, no body weight gain, and offers more opportunities to address individual patient needs, improves patients' adherence to treatment. So always better to start with 2 salts instead of 3. So thank you so much. I'm stopping here. I think I finished faster compared to
You
sir.
have not only finished faster, you have talked from your heart and you have said, you have developed the story from your heart. We really appreciate. We'll come back to the question and answer. Now it's my duty to invite somebody whom I adore, whom I love. He's my Dada, Debmalyada. Can I have Debmalyada on the screen, please? Dear friends, just I've heard of one combination in the use in verified trial by my friend, and the 4 years and beyond it has shown its values. We have somebody amidst us today, Dr. Debmalya Sanyal from Calcutta. He has got MBBS, MD, DM, and special certificate from UK. He's the professor at the Department of Endocrinology KPC. And beyond that, he has been also a teacher and faculty for the Newcastle course and always keeps the flag flying very high. Today, he's going to speak to us on a very important topic, the Good Fit Duo. The title is new, the Good Fit Duo, the linagliptin and empagliflozin combination. Over to them, Malyada.
Thank you, sir.
Welcome,
Thank you for the
Debmalya,
kind
for the welcome.
invitation, and thank you for the kind introduction.
Dave, Professor Kanungo is welcoming you.
Yes,
Dave, Professor
yes,
Kanungo is
sir.
welcoming you. Thank you.
Yes.
Thank you. Thank you.
Thank you. Candice, yes, thank you. So today we'll be talking on the Good Fit Duo, that is linagliptin with empagliflozin for smarter and safer type 2 diabetes care. Next slide. So we already have this data where we see that majority of our patients are not getting to target, more than 70%, and also 26% and 21% respectively have CV and renal complications. Even 50% have CKD at diagnosis. So we require early aggressive treatment, and which has shown cardiovascular benefit, especially in the early years, first year, and within the first 5 years. Next slide. So if we use a combination therapy with complementary modes of action, they can improve the target achievement, weight reduction, reduce hypoglycemia, and delay the progression and the complications, as well as lead to better blood pressure and glucose control as well, and reduce the long-term diabetes complications. Next slide. So we have already published data way back, with the combination of EMPA-LINA, and that has been done not only in medication naive subjects on diet and exercise, as well as on a background of metformin maximum tolerated doses. Next slide, please. So the evidence is there, the published data is there, the first of its kind with any of the combinations with the DPP-4 SGLT2, that is EMPA-LINA, which showed A1C reduction up to 1.8 to 1.9% in drug-naive patients, and also up to 1.6 to 1.8% in patients with metformin. So a huge A1C reduction, especially in patients who have an A1C baseline more than 8.5%. Next slide. So very important, this A1C target is achieved very quickly. The motto which we have, that early good glycemic control within first 12 weeks, both in drug-naive as well as in metformin background patients. Next slide. And very importantly, we have additional benefits which are translated from what is there with empagliflozin. With this combination, that is blood pressure reduction, both systolic, diastolic, as well as a weight reduction to the tune of 3 kgs. Next slide. And despite this high efficacy and also benefits, there is no additional risk of hypoglycemia, especially when it is given in the background of either in patients who are de novo or who are on metformin background. So no additional risk of hypoglycemia. Next slide. And so we have the appropriate use of SGLT2 DP4 combination as a initially in treatment naive when the A1C is more than 8%, even in combination with metformin as a triple drug, if the A1C at baseline is more than 9, or in metformin uncontrolled where the A1C is more than 8.5. It can be also added in patients who are on insulin as well. Next slide. Now, with regards to GFR categories, linagliptin can be used with GFR across stages, even in stage 5 CKD without dose adjustment, whereas empagliflozin can be started with a GFR more than 20. Next slide. And we have had the recent publication where we tested the EMPA-LINA combination in patients with type 2 diabetes who had also early CKD as well. Next slide. And we published, and what our data shows, the efficacy in this population remains significant. The A1C reduction 1.5%, 50 and 90 milligrams respectively reduction in fasting and PP, a weight reduction of about 2 kgs, and this is persistent over 1 year data. There's an additional reduction in ACR, and most of these people have a GFR shift with regards to stabilization of GFR after an initial drop. So GFR is also well maintained. So we have this data over 12 months, the first of its kind published with a combination in early CKD, showing benefits in terms of stabilization of GFR as well as improvement in the UACR as well, urinary albumin creatinine ratio. Next slide. So we see that across the board, the DP4 inhibitors, linagliptin, also have similar efficacy, 0.7 to 0.8%. And where there are doubts that linagliptin may be less efficacious, these trials show, though it does not suggest that these are head-to-head trials, but it has comparative A1C lowering up to 0.7%. Next slide. And what has been seen that we have a greater HbA1c lowering efficacy in Asian subjects, where especially in India, seen up to 1.5 to 1% reduction in A1C, especially in patients with higher A1C levels at baseline. Next slide. We also published about 10 years back, more than 10 years back, with regards to evaluating in new onset diabetes patients after renal transplant, showing that linagliptin, even as monotherapy, was effective. No dose adjustment in rapidly changing GFR patients, this category of patients, and no alterations in immunotherapy regimes also was required. Next slide. And this has been actually quoted in most of the guidelines, especially the transplant guidelines as well. Next slide, please. So the Carolina and Carmelina, both the safety data with linagliptin early and in advanced disease suggest benefit and safety especially. Next slide. So there is safety with regards to 3-point MACE, mortality, next slide, and heart failure in this high cardiovascular risk patient, as well as there is additional 14% lowering in albuminuria, which may be an additional benefit. Next slide. And what we see is that, the meta-analysis, that there is a neutrality or absolute safety in terms of CV, death, MI, stroke, and heart failure hospitalization with linagliptin, which has been shown in the Carmelina study. Next slide. And so you see linagliptin being safe, whether it is MACE, all-cause death, CV death, MI, stroke, and heart failure, absolute safety. Next slide. And we also published quite recently with regards to long-term safety of and efficacy of anti-hyperglycemic effect in transplant patients as well. Next slide. And this 1-year data, next slide, please, suggested that we have an A1C reduction up to 0.8% in this category of patients, and there was minimal weight gain, actually minimal weight gain, and also GFR improved. So this can be considered as first line, followed by metformin and secretagogues in this group of patients. Next slide. And Carmelina consistently showed benefit in CKD. Next slide. As well as with regards to it can be used as an option with this data also in patients with cardiovascular disease as well. Next slide. We have already seen the data with regards to empagliflozin, which is robust in terms of CV death, all-cause death, as well as 3-point MACE. Next slide. And this is actually consistent across CV risk category, whether the patients are having background peripheral arterial disease, prior stroke, prior heart failure, or prior atrial fibrillation. So the benefits are all across the board, especially in terms of sudden cardiac death. There was significant benefit as well. Next slide. So in the Emperor, already we have seen the Emperor reduced as well as Emperor preserved, as elaborated by Sir Dr. Zerger, with regards to benefit in both with preserved and reduced ejection fraction, the benefit of empagliflozin. Next slide. And with regards to the EMPA kidney, what is very interesting is that this was one study which actually had a very broad patient population, which included patients also without any albuminuria, the only SGLT2 inhibitor having this data, and as well as advanced CKD. Next slide. And there was a stabilization and improvement in the hard renal outcome as well as the GFR slope.
Sir?
Next slide.
Sir?
So this combination is appropriate to be used in patients with high CV risk and established cardiovascular disease, or even patients with heart failure, and also is preferred over other combinations with regards to patients with diabetes and CKD. Next slide. So in summary, this SGLT to DP4 combination represents a very important combination that can provide robust glucose lowering, acting on the pathophysiological defects without a significant adverse, even without the burden of hypoglycemia when it's used alone or in combination with metformin. Again, it has a robust reduction of more than 1.5% glycemia and can achieve a good glycemic control quickly within 12 months and 12 weeks, and also they have sustained glycemic benefit. There is additional benefit of weight reduction, blood pressure and albuminuria, and improvement in vascular function. They have robust evidence, especially with CV, heart failure and renal outcomes, benefit with empagliflozin and established safety with linagliptin. Also in patients with renal transplant, and also proven mortality benefits with empagliflozin in type 2 diabetes patients with ASCVD and CKD. So we need to use these agents judiciously to provide benefit as well as safety with this combination. Thank you very much. And I would once again thank Sir Dr.
It has
Ashok
been a
Kumar Das as well
veritably
as Dr. Alok
well-dealt
Kanungo for the
subject.
invitation.
Absolutely, you have covered everything, and it's a great combination. So we'll start the questions with Debmalyada first, and of course it will mix and match. My first question to you, Debmalyada, is for the purpose of our thousands of delegates who have joined from the tier 2, tier 3 cities. There are some GPs even from the villages. There are no more villages, they're from the towns, small time towns. Can you describe to us the exact present profile or profiles which will be ideal for the early use, as you rightly said, early use of Lina-IMPA combination? Any particular
Yes,
present
sir. With
profile
regards to, as I
that in
said
your
in
mind?
yes, Yes, sir. With regards to patients where we require, because early glycemic control is important for cardiovascular and all the renal complications. So patients who have a baseline A1C of more than 9%, we can start with the Lina as well as metformin combination. With a baseline on metformin with a A1C of more than 8%, we can add this Lina combination. And also patients who are intolerant on metformin with a A1C more than 8%, we can add. And also patients having CKD and carditis, we can add a round of insulin.
Okay, I think that's a brilliant answer. Like we say, give a gliptin and forget about it, fill up and forget. So like that is a very safe drug. Can you give a little bit of idea its additional safety profile? Additional safety profile in elderly and additional safety profile in people who have those minimal renal impairment.
Yes, sir. With regards to, I would first come to the minimal renal impairment. Now we have also published data, first of its kind with this combination. We just recently published that, showing that in early CKD, there's a significant benefit, not only in terms of albuminuria reduction and improvement also in the GFR. So there is an early dip which will occur in the initial months, but that stabilizes over time, and that's why the GFR is improved over time. So there is less likely progression of CKD and improvement in albuminuria. So at all stages of CKD, albuminuria has a higher risk. And so that is something which is very, very important with regards to this population of patients as well.
Now, I find that the Malada very widely were published in many ways. I know you write regularly, but on this area itself, you showed us 5 papers which were published in Scopus and in various journals. now, 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 can you tell us that how does this dual combination, in contradistinction to other dual combinations, overcomes clinical inertia? Is it the assurance that patient will not go into kidney failure, patient will go into hypoglycemia? What exactly drives?
Sir, first is the efficacy. We have the robust efficacy of 1.5% or more. Second is if it is combined, it is used alone or in combination with metformin, then the hypoglycemia risk is minimal. That is there. If it is combined with, of course, any will can cause hypoglycemia, but alone and with metformin, minimal risk of hypoglycemia. Additional weight and blood pressure benefit. Not only that, we have the benefit across the board with regards to cardiovascular benefit, renal benefit, heart failure benefit with empagliflozin, and cardiovascular, renal, and kidney safety data with linagliptin, which is there, established data. And not only that, this is one of the combination which has for a long time, as I showed, sir, a 2014 diabetes care publication with this combination specifically having established this molecule as a safe and effective molecule as well. So we can use it early on as well as in patients where the A1C is higher, as we discussed, as well as late. The spectrum, and very important, even in patients who don't have albuminuria, there also we have the option of using this with this molecule.
Great answer. I know we coined the term after the Lina trial, Carolina trial. We termed the term for the sulfonylurea that it is glucose smart, but it is cardio safe because compared to Lina, it also showed. So linagliptin has been in the fulcrum, and Lina and EMPA combination have been one of the most. It was costliest. Now it has come down, and people are using it plenty. And in the today's parlance, if you ask me, 1914, the first cardiac benefit was from EMPA. Am I correct? In the ASD meeting in 2014. Of course, then followed the part all that. And Lina similarly has also produced great benefit in the heart and in the kidney. We'll come back for the further questions. Now I pass it to Rishi. Please stay with us, Demalida. Rishi, I just want to know a very important point from you. How should clinicians practically factor the beta cell protection and the beta cell action durability in day-to-day clinical practice? if I'm starting my practice, how do I factor that I must protect beta cells without producing exertion, da 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 da. At the same time, safety.
Yes, yes. I think this is a very useful clinical question. I appreciate for the question, sir. If you look at the patient, if the patient is obese, chances are that he would be responsive to the beta cell reserve probably is good. Again, the age of the patient. If the patient is young versus old, if the patient is middle age, chances are that beta cell reserve is all right. If the patient is young, 20s or 30s, chances are that the beta cell reserve, whatever is reserved, they're going to last, going to exhaust faster. Even if the patients are younger, now we see adolescent type 2 diabetes, they lose beta cell reserve within a year's span of time. So we need to be really active. Other hand, if you look at very lean individual, chances are that they have a lesser insulin resistance, more of a beta cell deficiency, more of insulin deficiency, number one. Second, very interesting clinical parameter is the poor responsiveness to uh, the oral hypoglycemic agents. If the responsiveness is bad, chances are that probably patient is landing. And there are contradictions to both the sides. Sometimes patient is obese, but they're poor responsiveness. They have dominantly insulin deficiency compared to resistance. So we need to keep all those things in the mind and act accordingly.
I think brilliant answer. I like two things you mentioned. You talked about the cost and you said the apparent cost reduction may not be finally beneficial. Similar thing also, our orator for the day had written that to treat diabetes appropriately is cheap. If you do not treat appropriately, it's going to be costly. You also echoed that.
Okay.
You also echoed what you said just now, that for the type 2 young diabetes, which are more in India, this may be one of the very first and foremost combination because of the years ahead. But I have a very small question to ask. Where do you position this patient? Early on, oblique, long-standing, oblique, progressive diabetes? Where will you position this combination?
I
With
think
the metformin.
Vimal Sanyal has already answered. We can use it at any time, sir. At any point, it will
But
work.
what will be your message to give it early on Vildameta combination or a prolonged disease
Right.
or a
I
patient
think
which is progressive?
Thank you, sir. Actually, earlier we used we are going to reap better benefits or more benefits.
Yeah,
And
I also thought so. Earlier will be more benefit to
because
this.
then the beta cell reserve would sustain longer. And one important thing we were discussing with a couple of endocrinologists and my colleagues will also agree that with the use of DPP4 inhibitors, vildagliptin, the use of insulin has definitely been delayed. What PDS data showed at that point of time that beta cell gets exhausted in 6 years, which is now pretty prolonged. It is now 10 years, 12 years, maybe more. So this is one thing earlier we used, we're going to reap more benefits.
Fantastic answer. We'll come back to
Dr.
you.
Dash,
I'll come to Jargar
Dr.
now.
Das, can I make a
Yes,
comment
yes,
on this?
please. Short one, very short one.
Both of these elegant speakers did mention that, and it's important to realize that one is whatever beta cell protection or provocation gliptins do. And understandably, in the natural history of the diabetes, beta cell mass will keep on varying depending on how much you protected it, how much it was unprotected, what apoptosis occurred. But one great thing about gliptins is that they also cause a reversible suppression of glucagon. And that is sine die health because alpha cells do not go off. And when you talk about beta cell apoptosis or beta cell dysfunction, there is also alpha cell resistance. So hyperglucagonemia also plays an important part in hyperglycemia. And vildagliptin was the first molecule on which it was documented that it can cause reversible suppression of glucagon. And that paper came in 2009 in Journal of Clinical Endocrinology and Metabolism. And then other gliptins started looking at whether they can cause reversible suppression. So one, that particular mechanism
I
of
think
action.
very good point you highlighted, brother. And I was also looking at whether David will do a long-term study. Long back we have published Verify. That was a 4-year trial of glycemic durability and effectiveness. Now, I hope that with some more data, I just met and asked him, some more data will be covered, longer duration study. Good. Jagar, I have a
Yes, sir.
question
One
for you.
comment, sir.
Very simple. Yes, Dhammadhar.
Yes, one is that again means corroborating with regards to Sir Zargar sir. Also, in insulin patients, receiving patients, there is data with vildagliptin suggesting the hypoglycemia risk is less because during hypoglycemia, because of the GIP action is still there, the glucagon levels actually go up during hypoglycemia, having additional protection of hypoglycemia. And with regards to young patients, there is now data from NICE. The recommendation, the recent NICE guidelines have suggested that gliptin and especially the flozin to be used early on in young diabetes patients, type 2 diabetes patients.
I think great comment, and in a jocular vein to break the barrier of listing so many talks. All that is Americans is not good. Builder was never approved in America, and the current scenario of what's happening, I think Builder is a molecule of the Europe and Asia, and it has stood well. Am I correct, Dhammalyada? Thank you. Now, Jagar, very important question to you. How do you have, the early clinical clues in a diabetic that the patient must be evaluated for heart failure? Just pointed answer, very short.
Professor Das, earlier on, there are very non-specific symptoms. If at any stage, a person who was otherwise doing well complains of easy fatigability, say whatever walk he was taking is becoming difficult. He finds it difficult to come out of bed. Easy fatigability and effort intolerance. You should keep on thinking of probably development of a heart failure. And if at any stage you find out there has been a mild pedal edema and you find there is no proteinuria, you should think of a possibility of a heart failure. If at some stage a person complains of a right upper abdominal discomfort, and you should think of a congested liver and probably an early sign of heart failure. But most of the times you need to have a very high index of suspicion. It's not, it's something like you wait for ECG changes of a myocardial infarction to make a diagnosis of coronary artery disease. We need to do it much before that. So in a similar scenario, in heart failure, we need to be someone who has had a diabetes for a long duration, somebody who has had dyslipidemia, hypertension, and dysautonomia, we need to be on guard. Anytime easy fatigability, going to the shop becomes difficult, working in office becomes difficult, get an opinion, get a echocardiography done, find out what is the EGFR, this ejection fraction, and make a decision.
Great answer. I think in the same continuation, we have less time, Jagar. A very short answer, what a diabetologist, who are the majority of the people joined today out of 5,000-6,000 people, referring in the advanced stage of heart failure to cardiologist is done. That is a different issue. But early on, what diabetologists like you and me or people who have joined us, they can do early on from the point of view of preventing heart failure?
Firstly, like anything else, Professor.
My question stems, sir, I will say that I will prescribe SGLT2 unless otherwise contraindicated. I'm just giving the thinking aloud. Yes, Jagar.
It's something like, as a general physician, as I was just now telling you about the symptoms, and now in the current times, we are moving more towards SGLT2 inhibitors and gliptins, and now thereafter to GLP-1 receptor agonists. Anytime we have a suspicion of those symptoms that I alluded to earlier on, one can at least, we know there are many drugs that are available to us for managing heart failure. And there is a definite sequence of events that was there in the past, but now people believe that more than one drug should be started simultaneously. For starters, if a general diabetologist has a suspicion or a clinician, SGLT2 inhibitors at least should become a part of innate management protocol. And at least that is one thing that might give him some relief and some time before a decision is made whether it needs a more advanced care in a cardiac center. Professor Das.
Thank you. I think, Jagar, I have got a prompt you must have seen also. Somebody from the audience has asked, dear Ashok, how much late we are. We're enjoying this question answer. But how much late we are, my dear friend? We are late today just now by 16 minutes, but I assure you we'll make it up. Last two questions to Dr. Surinder. The first question, very important for all of us. Now, frequently NAFLD is underdiagnosed. Can you tell us what is the clinical approach that is to be adopted for early diagnosis of muscle, not in the ultrasound room, but in my diabetic clinic? Very brief, very pointed answer because people are asking for the time.
Very important question, sir. And if you look into the prevalence of this disease, in diabetes, it is 60 to 70%. Many of our diabetic patients are obese also. In obesity, it is 80 to 90%. So consider that your diabetic patient, type 2 diabetic patient, will be having a MASLD. So there is a screening method, which is to look at disease like diabetes, look at FAB4 screening method. And if there is a 1.3 or less,
Yeah,
it is okay.
1.34.
If it is
1 point, very correct. 1.34 for score.
It is okay.
Is the cutoff.
It's okay. Yeah. But if it is more than 2.67, then of course we have to take the help of a fibro
I
scan.
thought so. I think that must be answered. FIB4 score must be answered. The second
It
thing
is very easy. It is
Second
very
thing.
easy to calculate SGOT, SGPT, age and platelet, and you can derive it on your mobile phone, and you can calculate it.
So
And
Surinder,
accordingly you can
FIB4
identify.
score we have said. Second point. Second point, I'm just going to suggest to you that everybody has in the clinic, like you and me, have a small ultrasound, maybe portable one. So portable ultrasound, smaller ultrasound can give up to stage 2. Am I correct? Stage 2 of the muscle. It may not give elastic
Sir,
vibration.
it is a bit crude method actually, because
Crude
in
method, I agree, crude
ultrasound
method.
you can identify that if it is 30% or more fat, only then you can say that there is a attenuation of blood vessels in the liver and diaphragm is not visible. Otherwise, it is not a very sensitive method, sir. But FIB4 score
I
is
do agree.
very,
I
very
was just
important.
thinking that, we are trying to do a study by simple ultrasound to diagnose stage 2, because there's a point of return. Beyond stage 2, very advanced drugs to be done. The second I want to ask you is very simple. I just want to popularize that, the prevalence you said 29.8, the first, then it went up to 60%. 60% of people having, and they're having cardiovascular death, you rightly said that. Now, to prevent it, while choosing oral anti-diabetic drug in a type 2 diabetes, what will be your message?
So, in patients where we suspect that patient is having diabetes and MASLD, then as highlighted by Dr. Jargar, SGLT2 and pioglitazone considered positively regarding the, you can say, fat accumulation in the liver will be significantly reduced. So these two drugs as an anti-diabetic, but also reducing, you can say, fat load in our liver is very, very useful. If patient can afford as GLP-1 receptor agonist, now we know that semaglutide is a drug which is considered for MASLD. So we can start that drug as an anti-diabetic drug, but also helping in MASLD.
Thank you, dear friends. Big round of applause for the first session. We have overstretched by 19 minutes, but I assure you we'll finish in time, dear friends. So big round of applause for all the four. And I really put on record our very sincere appreciation, Dr. Jargar, Dr. Surinder, Dr. Devmalyada, and Dr. Rishi, my dear friend, and also Dr. Sharma. All of you, my sincere thanks and gratitude. We'll pass on to the session 2. Please stay with us. Now, while I pass on to session 2, it is a very important session for the purpose that it is regarding the technological advances. So you just know how in the morning, Dr. Jyotidev's phenomenal lecture. Now this is the technological advances. I will not give any context setting because we have Manoj to do that. Manoj, I hand over the session to you. Please see that time is kept. We don't have to stop speakers. We are not speakers in the assembly, but at the same time, We also have to, Shishirda is there. Shishir is my very good friend, and both of you definitely will do the job. So over to you. Context setting can be very short, and you can invite the speakers. Over to you, sir.
Good afternoon, everyone, and
Your
it's a
face is
pleasure
dark, sir.
being.
Your face is dark.
चेहरा तो दिखाना यार.
Your face is dark.
Okay, so thank you. Afternoon, everyone.
Manoj,
Pleasure to be.
your face you were darkened knowingly.
Sorry.
Your face was dark in the beginning. Anyway, please continue. Please, I know I was in the West.
Is my face seen now, sir?
Now it is
perfect.
absolutely like a film star. Continue.
So, afternoon, everyone. Pleasure being a part of NUCD. Thanks to Professor Das, Dr. Kanungo, and the entire team. Well, hopefully soon we will meet in person, like in the yesteryears, for the
It will
full
be next year
meeting
positively.
at
Next year
beautiful
positively.
Bhubaneswar.
Next year positively.
Right. So, thank you for asking me and Dr. Mahapatra to chair this important session on technological advancements in diabetes. We do realize that today, if there are two aspects which are catching the attention of every clinician, wanting every clinician to update their skills in the field of metabolics, I would say these are zones of obesity and chronic weight management, and of course, technological advances. Well, this is where some would say the action lies. And what we have planned for you is 3 wonderful conversations on aspects of artificial intelligence. Well, AI, the word itself brings about immediate attention and interest in every clinician's mind. For that matter, every individual in different fields of life today, AI is making huge inroads. The larger purpose of course, artificial intelligence is how do you multiply the aspect of technology for betterment and better reach across the masses to use any of the devices or technology that is planned. So we'll have a wonderful conversation on artificial intelligence, followed by conversations on CGM and other technological advancements. Can I have the chair, the speaker's bio come up, please? And following which, then Professor Das shall moderate a panel discussion with questions pointed and aimed at all the experts in the session, and Dr. A.K. Das is going to be asking what the nation wants to know. So with that, if I can have the first speaker's introduction. Dr. Mahapatra, would you like to say a few words, sir? Yeah.
Thank you. I welcome everyone to this session, and after Dr. Manoj Chawla's your introductory speech, I would like to say that these technological advancements have definitely and significantly reshaped our approach for the care of the diabetic patients. So instead of attending clinics and making a physiological and a data, they can also use these technologies and these tools, and they can also control their glycemic control and lead a better day-to-day life. So with this, I just want to congratulate Dr. Kanungo and the 12th NUCD, and I salute our spiritual guru here, Professor Niranjan Tripathi, and my deep respect to Professor Dr. Ashok Kumar Das and Dr. Jayant Panda for their energetic moderation. How they are moderating with their updated academic knowledge. Really, I salute you, Professor Ashok Kumar Das. Now, with this, I hand over to Dr. Chawla, please, to kindly continue the session.
Thank you. Thank you. And my apologies for not mentioning Professor Jayant Panda,
please continue.
Dr. Panda, who is an integral part. And I think I'm wearing a shirt which he has given it to me at some point. This is one of the shirts that Dr.
This is
Jayant Panda has
Sambalpuri shirt. Sambalpuri. It is Sambalpuri architecture.
Sambalpuri print. Thank you. So this is Dr. Jayant Panda's thing, and pranams to Dr. Tripathi as well. So I do see that we have our first speaker joined in. May I have Dr. Amit De's bio come up, please?
Please put Amit De's bio, please.
So Dr. Amit Dev is a consultant physician, diabetologist at the Obesity and Metabolic Disorders Clinic, Kolkata. Experience of over 15 years, winner of Diabetes Awareness Award at Diabetes India 2020, winner of JPF 2023 award, winner of ACP India Chapter Governors Recognition Award, RSSDI Innovation Award in 2024 for AI, Fellow of American College of Physicians, founder of Doctors AI. I think the larger recognition today for Amit Dey's work comes from his initiative, which is Doctors AI, which is doing great work in enlightening people on the field of artificial intelligence, especially the medical community. He is the Joint Secretary for Diabetes Research Welfare Association, DRWA, Kolkata. He has made various papers and posters to his credit and is the chair for the International Diabetes Federation AI Technology Working Committee. With those few words of recognition, gives me great pleasure in welcoming Dr. Amit Kumar Dey for his deliberation today. Over to you, Amit.
Thank you so much, Dr. Chawla, for the kind introduction. It's great to meet you again virtually. We just met a couple of days back in your city. And a very good morning to Professor Das, a person who's very close to me, my mentor in the recent days, that has been a guiding light to our Doctors AI and the Indian College of AI in Medicine as our patron. Greetings to Professor Kanungo. Thank you so much, NUCD team, Professor Panda, and everybody for the kind invitation. So, sir, Ashok Das, sir, and Dr. Manoj Chawla, sir, if with your permission, I will share my screen and we will start the presentation. Just allow me a second.
Please, just reminding all the speakers, as Dr. Das said, we try and stick to the time. So there is, we stick to the whole sessions for the time on the day. Thanks.
Yeah, I have 20 minutes, right, sir? Or is it 15 minutes?
I think 20 minutes max. Yes, correct.
All right.
You can take
all right. Yeah. Sorry, I think I just got disconnected. Just allow me again. Sir, could you confirm that my slides are visible?
Yeah, now it is visible. Make it full screen.
Yes.
Yeah, just make it full screen, Amit.
Yeah. Just doing that. Is it good? Is it full screen?
Yeah, it's good to go. Yes.
Okay, perfect. Thank you so much for the kind introduction. A very good morning to everybody who has joined in today. The task that has been given to me is, of course, to introduce artificial intelligence in diabetes care in a balanced way. And I think over the last few months, Dr. Manoj, myself, in the IDF AI committee, we have been talking a lot about how AI and technology can come in the field of diabetes care in a responsible way. Professor Das and myself, we have discussed on this multiple times. So, dear friends, we will be giving you a very short and a brief overview of what we really understand by responsible artificial intelligence and how we can actually adopt and implement this technology in the diabetes care ecosystem safely in a trustworthy manner. So the first is, where is the need gap and why are we even talking about artificial intelligence? Well, this is the simple reason. If you have gone through the recent IDF Atlas, then we are looking at a huge burden of diabetes, not just in our country, but globally. And the good silver lining is the digital window, which we all have at hand, because each of us, of course, today, we are all connected through the help of technology in this virtual forum. And many of us may be even watching this with the help of your mobile phone. So that means the smartphone penetration is very, very high. And this is a window of opportunity for us to explore delivering diabetes care using this methodology and technology. So why artificial intelligence in diabetes care? This 5 blocks kind of summarizes that why we should talk about and explore in a scientific manner the application of AI in diabetes field. So one is personalized care. We know every diabetes patient is different. One size will not fit all, and there needs to be an individualized approach beyond the guidelines, what it's teaching us. So we need a more data-driven, personalized diabetes management, and that's where AI and technology and predictive analytics brings in. To enhance the care and the user experience, that is also very, very important, because technology will be helping us to drive that, and eventually the outcome should be towards better glycemic control and lesser complications for the individual. The other important reason, as we all know, that this is a subject and a domain that is driven by data and numbers, and most of the time beyond this care can be delivered remotely with the help of technology. And that's where AI and technology comes in. And by this, we will be able to optimize our resources. That is the right care to the right patient at the right point of time when they need the most. So these are some of the reasons why we do need to look at using and exploring this technology to its full potential in the field of diabetes care. Now, in diabetes management or non-communicable disease, we are looking at these four modalities where we see artificial intelligence come in. I'm sure today in the morning, Professor Jyoti Dev must have told you about the AIDs and how algorithms are actually going to improve the insulin pumps. We are also looking at AI algorithms come in the clinical decision support system, and diabetes self-management education get augmented with the help of chatbots, and then prediction of the complications, for example, the onset of retinopathy or nephropathy or microalbuminuria or neuropathy, these can be predicted with the help of algorithms much before the disease has occurred, more in terms of primordial prevention, and that's possible using artificial intelligence. At present, you are seeing the application of AI in continuous glucose monitoring, automated insulin delivery, retinopathy screening, risk prediction models, and also in the help of the mobile health apps. This evolution has happened over the years in quite significant way. We started with expert system of medicine in rule-based calculators. Then comes the era of machine learning and deep learning, while the algorithms keep on developing in the terms of the closed loop, the open loop, and then the closed loop artificial pancreas. And today we are talking about transformer models, and machine learning get integrated into these algorithms towards more predictive algorithms coming forward. So we are talking about AI give us more of a proactive diabetes care rather than a reactive diabetes care. The 2022 and 2023 saw the development of clinical decision support system. One such is the DriaMed Advisor Pro, which was approved by the FDA. And now today we are talking about generative artificial intelligence as another layer over what we have. So in the insulin pumps, this is a revolutionary technology. We are looking at the algorithms have a super added layer of machine learning to improve the predictive analytics. How does that work? It starts with collecting the data from the various inputs in terms of the sensors or the wearable devices. The algorithm will process in the backend, give a predictive modeling, and eventually give the right alert to the right patient when they need the most, all integrated through a single user interface network. So these are the algorithm which works in an insulin pump in terms of the PID algorithm or the model predictive algorithm. Now we are talking about adding a layer of machine learning to it, so which extracts the feature, processes it, and gives a prediction to certain events which happens even before it happens. The limitations would largely be variations individual to individual, troubleshooting when the device fails, malfunctioning detection, and iterative refinement of the algorithm, which the developer needs to keep on doing going forward. The other segment where you will see artificial intelligence really improve monitoring is the addition of AI powered CGMS. And this has already happened. This has already been done. And we had a predictive modeling called January AI, which is an AI powered CGMS, which kind of gives more of a personalized coaching to the individual as to how their blood sugars are going to fluctuate if they eat a certain number of calories. And it also forecasts hypoglycemia 10 to 60 minutes before the occurrence. So now we are also looking at Roche come up with the AccuCheck hypoglycemic predictor. And this is also an AI powered algorithm in its companion app. And as I speak, recently I learned that this has been already launched in Singapore as well as in some countries in the Middle East, which the continuous glucose monitoring app can actually give a prediction of hypoglycemia using artificial intelligence before it has even occurred. The other segment is in prediction of complications. Now, diabetes is a disease, progressive in nature, and it needs to be controlled by controlling the glycemic fluctuations to prevent the complications. What if these predictive algorithms can be used to predict the onset of microalbuminuria, or predict the onset of a neuropathy, retinopathy we are already using, and stratify the risk in terms of population health by early detection. And that's something that AI can bring in. In the field of diabetic retinopathy, this is a segment that we have already explored, and we have used AI deep learning algorithms for retinal screening over the last 5 to 7 years now. And these models seem to be very, very efficacious in picking up early onset non-proliferative diabetic retinopathy much before it can be picked up by routine conventional screening. This is one of the work that Dr. Chawla, myself, we had conducted a community screening across the country, and we came up with a sample size of 5,000 individuals where we picked up the prevalence of diabetic retinopathy, and we found that using AI-enabled cameras. Now, the other aspect of using AI would be in diabetes self-management education. Now, generative AI, as we all speak today, is something we are all using. And all of you must have recently read the news that ChatGPT has launched the ChatGPT Health, yet to be available in India. It's available in the US market, but as for what I've heard from my resources is that it's very soon going to be launched in India as well. So which means that an individual now can actually speak to a large language model and have a conversation for education. And that is something that has to be explored, and that will be 24/7 data-driven personalized support that can be provided. So how does it work? It works with a foundation model in the backend. There is an API integrated bots, but now of course these language models starts getting developed, so they can work on the language model itself. And there is a triaging and platform integration that can be done, which makes it more interoperable even with the electronic health record system which the clinician is using. And all these interfaces work in tandem, in parallel to each other. Now, there are some evidences that these DSME chatbots does improve user satisfaction, improves the confidence of the individual in approaching towards the disease, and maybe, I mean, it's too early to say, but it will have an impact in the A1C reduction if they understand the disease better as well. This was one of our early work. We looked at ChatGPT in diabetes care. It was published as early as the end of 2023, where ChatGPT was much very new. So you can just take a look at an overview of how this tool can work. We came up to build up a WhatsApp user interface based on a language model, Madhu AI, which we validated with about more than 100 doctors in the country to establish the point of proof that these AI bots should be used responsibly and validated by the healthcare professional in the loop. And a kind of work that we started about a year and a half back is now being recognized, and these kind of validation protocols are now being established across the country and globally to make sure that these tools are used in a responsible manner. This is some of the early results of the Madhu AI study which we had conducted in terms of its accuracy and relevance, neutrality to bias, and helpfulness and empathy, but most importantly, its score of doing any harm, because that's the first rule of medicine. We do no harm to the patient. So these chatbots must be evaluated when they're using generative AI before they're put into clinical practice. The limitations would be privacy and security concern, limited clinical validation, which I'm very happy is now being undertaken by some of our colleagues in the AI world. Misinformation risk is something important that needs to be looked at. Technology comfort and workflow integration has to be also looked at. Now, in lifestyle and daily support, there are a lot of user interfaces which can give in data, and that is the wearables. And these wearables can give activity tracking, and at the right time they can give behavioral nudges to the patient, because we believe in just-in-time adaptive intervention. So which means the right intervention with the right knowledge to the right patient will bring a behavioral change, and all it requires is interoperability and a good integration and a continuous iterative feedback mechanism for the device to work fine. The other aspect which I want to just bring to everybody's highlight is clinical decision support system. Now, today we will all be using digitalization of the health record with the ABDM coming in. We are adding a layer of decision-making capability to the electronic health record system, and that's CDSS. What it means is that it pulls in from the knowledge base, learns from the patient data. There is an inference engine where the algorithm works, and then it gives a recommendation and an output suggestion to the clinician in the loop to act on, which doesn't mean that it's giving the decision, but just acting as an assistant to the clinician to make a better decision. This has been explored by Professor Nimri et al. In Israel on the DRIA-MET, and they have done a fantastic work in terms of establishing the clinical efficacy of this clinician decision support system, which establishes. And it has shown that it was widely accepted across the spectrum by primary care, by endocrinologists, and by pediatrics in managing type 1 diabetes and as well as type 2 diabetes. And therefore, this particular product received an FDA approval as well. As we all head into 2026, dear friends, we are looking at agents coming in, and agentic AI core is going to come in, which means that these clinical decision support systems are going to be functioning also in an autonomous manner based on an agentic core, and it will also have integration with these patient chatbots and diabetes self-management education tools. How are these supposed to work? So imagine there is going to be an architecture of, in the center, the agentic AI that is going to get connected to the hospital. It's going to be driving in data from the CGM and the patient's wearables. It will have a LLM powered at the back end, which is going to be probably a diabetes specific language model. And it's going to also pull in data from the community and primary clinics. It can give continuous hub and spoke model recommendation through the clinical decision support system to the end user. Another application of agentic intelligence is going to be in delivery of care in terms of smart insulin pens, which can have bolus recommendation, autonomous dosings that can get connected to the agentic AI system. And at the other end, the continuous glucose monitoring with system will get connected. And that's how you will get, agents giving an autonomous recommendation. But again, at every point of time, we do require personalization and iterative learning, which makes sure that there is always a proactive motivation to the individual, and there's a feedback mechanism which is constantly updating the clinician and the doctor in the loop so that they take the right decision for the patient at the right point of time. Does all this have evidence? Well, this is one of a summary slide, and of course created with AI as well, which tells you that all that I have spoken about, the pumps seems to be having a maximum strong evidence, but in terms of the chatbot and everything else, AI in the CDSs, the evidences are already building up, and I'm sure in 2026 and 2027 we'll see a more balanced way of building up evidences on the applications of AI and technology in diabetes care. But when we talk about this autonomous technological advancement, it calls for responsible adoption of this AI in diabetes care with the clinician in the loop. And that's why the AI and Technology Committee of the IDF comes in, where we lay the foundation of how these technologies should be used in a balanced way. When you say balanced, what does it mean? It means it has to be ethical, transparent, accountable for the output, fair, safe, inclusive, and most importantly, preserving the privacy of the patient's intricate individual data. AI that benefits individuals with diabetes while minimizing harm. That's what responsible artificial intelligence is. At the moment, we do have a lot of issues like algorithmic bias, black box, data privacy breaches. Regulations are still not very well streamlined, although the work is happening fantastic in our country and across the globe, and limited accessibility excluding vulnerable populations or those ethnicities which can be missed out in the study data. So who gets left behind? The racial and the ethnic minorities, women and older adults, low resource settings, and non-English speakers, if these models are trained on a siloed, limited set of data. Because eventually you're talking about building predictive models out of a data, and those data has to be very, very important. The regulatory framework that is there, we do have the CDSCO and the DPDP Act in our country, and I will request everyone to please go through the DPDP Act. And we believe that in our country, these strategies are going to get more and more structured by the government of India in the upcoming year. The trust is very, very important for AI in healthcare. That's what it's going to bring us towards a balanced management, because without it, even the best AI technology in the world won't get adopted. We from the IDF, we are calling for a coordinated global response. It should be a multi-stakeholder collaboration. It should not be only the developers making it and we as end users using it. It should bring all stakeholders on the same side of the table, discussing it, co-building it, and also having a voice in the policy and the regulatory framework going forward. With this initiative, the Idea of AI Technology Committee has traveled around the globe, and you can see some of the pictures of our recent roundtables conducted in Mumbai. We started in Mumbai at the DRS held by Dr. Manoj Chawla, followed by ESD in Vienna. We had some meetings in Geneva, and of course, recently we conducted two roundtables in Singapore and Dubai on responsible artificial intelligence in diabetes care. So together we can achieve this, but with caution in a balanced manner. And it calls for an integration of healthcare systems, technology developers, and for policymakers to come on the same side of the table and make sure that we are taking these autonomous technologies, because it's very powerful, but in a responsible manner forward. Dear friends, the true essence of successful adoption of technology and AI solutions in digital diabetes care is when we make it available, accessible, and affordable for one and all. Just because it's technology doesn't mean it has to be expensive. The essence is when it's affordable, available, and there for all at the right point of time. Because 537 million people with diabetes in this country deserves nothing less than equitable, safe, and effective AI technology solutions. So together we can transform this with the help of this technology, but we have to be literate, we have to be aware, and use it safely in a trustworthy manner, in a responsible way. Thank you so much for the kind opportunity. Thank you for your kind listening.
Manoj and Shishir Babu, you'll agree it has been a veritably, absolutely fabulous lecture, flowing. I'm sorry, I'm just came from my heart. Manoj and Shishir Babu, please take over, call the next speaker. But I'm not able to contact Bansi. Bansi is not available. We'll ask Vijay to take over, and Bansi will come next.
Right. Calling him, but can't reach him,
So
nor on
we'll
the
take over
WhatsApp.
Vijay
So
first, and he will come next. He was
is
there
Dr.
on the screen some time back.
Right. Is Dr. Vijay Vishwanathan here?
Yeah,
We
Vijay
have
is there.
Sir's thing, right?
Vijay is there.
So gives me great pleasure to introduce Dr. Vijay Vishwanathan, the immediate past president of RSSDI, head and chief physician at and practicing diabetologist for over 33 years at the MV Diabetes and Professor M. Vishwanathan Diabetes Research Center, Chennai. So with that, let me invite Dr. Vijay Vishwanathan to take it from here. Dr. Vijay Vishwanathan sir is going to be speaking on a very interesting topic, which is about modern technologies in diabetic foot management. So over to Dr. Vishwanathan sir's lecture now.
I'd like to first of all thank Alok Kanogo, my good friend, for taking up this topic of diabetic foot management and including it as a part of the deliberation. Diabetic foot is a very serious problem. It's a major complication of diabetes, like retinopathy, nephropathy, more serious, and is associated with a higher risk of lower limb amputation and mortality. We have seen many people die of diabetic foot ulcer. So I think it's a very important problem. A severe chronic complication of diabetes resulting in wounds which don't heal faster and ulcers within the soft tissue due to a combination of neuropathy, peripheral arterial disease, peripheral vascular disease is not accepted now, peripheral arterial disease, and hyperglycemia. Neuropathic ulcer is the most common, but nowadays we are finding a lot of neuroischemic ulcers also. And we have to do the investigation for peripheral arterial disease. Maybe we are a referral hospital, that's why we are getting it like that, neuroischemic. But the most important thing is infection. Infection is to be treated properly, and the infection can be treated only by debridement, topical antimicrobial agents, systemic antibiotics are important, especially in bigger lesions. Bigger lesions, systemic antibiotics are very necessary. But debridement is removal of the biofilm is very important in debridement, and that is removal of dead tissue or the infected tissue wound. Offloading is also often forgotten in today's world. Appropriate offloading, the patient shouldn't walk to the bathroom and to everywhere to eat. He shouldn't walk once he gets home. So reducing pressure on the affected foot is very important to promote healing. And you have to take care of the diabetes part also. So educating patients about proper foot care and prevention is very important. Dressing materials, people are still using the saline dressing. It's got disadvantages. Negative pressure wound therapy is a modern technology which is often used and successfully, and skin substitutes are not picked up in India very much. And platelet growth factor, we have done a research some years ago along with Dr. Sharad Pense and late Sharad Pense and Shaker, plate on the epidermal growth factor. We have not studied the platelet-derived growth factor, but we have published in Wounds Journal about epidermal growth factor, which was very positive results we got. Platelet-derived growth factor, we did not try it out. Though Dr. Reddy's introduced it at 1/4 the cost of that available in the United States. There were no takers. Platelet-derived growth factor died, and the epidermal growth factor is still surviving. It's still being used. Surgical interventions for abscess compartment syndrome or necrotizing fasciitis, surgical intervention is definitely necessary. High amputation burden, late detection of risk, and need for precision prevention and limb salvage is the use of the modern technology in diabetic foot. Why should we talk about modern technology? Is because of these three factors. So managing foot complications with the right knowledge, systems and support is very important. The current strategies is you debride the wound and then you do a wound dressing. If there is neuroischemic problem, you revascularize and you remove the pressure, don't allow him to walk. Infection control is very important. Negative pressure, many surgeons use it in the theater, which is not very effective. It should be less of infection, and only then the negative pressure will work. It's contraindicated in PVD, PAD, and you have to first revascularize and then try the negative pressure wound therapy. Low-level laser is being used by some centers, and hyperbaric oxygen, if available, can also provide 100% oxygen to the limb. It's particularly useful in building collaterals after revascularization. Now, coming to the modern technologies and customized solutions, angioplasty is one field which is evolved in India very much by the interventional radiologist, and drug-coated balloons are available. Just the heart. Infrapopliteal revascularization is important. Negative pressure wound therapy, bioengineered skin substitutes, which is, I told you, not very much advanced in India, and collagen and advanced dressings. In wounds that are healing, collagen can be used. But in the era of AI-based ulcer detection is important, prediction of healing, and decision support. Telefoot clinics, and I'll talk about it in the next slides that are coming. I'll start with negative pressure wound therapy. Negative pressure wound therapy is otherwise called a VAC therapy. It is designed by KCI in the United States, and in India I was the first to use the KCI product, and it's a fantastic technology. There's one technology which has revolutionized the management of diabetic foot. It's a VAC therapy. It's a negative pressure wound therapy. It's contraindicated in infected foot, where the surgeon must use a scalpel, and it is contraindicated in PAD unless you have revascularized the limb. So this is how it works. a sponge is applied on the wound, and there's a negative pressure applied to the wound, and the wound is becoming granulating. It cuts down uh, the granulation time, the time to healing by half, by 50% if you use it properly. WAP definition, it's a non-invasive localized subatmospheric pressure to promote moist wound healing, and the wound is all the interstitial fluid is removed and the wound becomes red in color, which is very important. It promotes granulation tissue formation, which aids in wound healing. And it removes interstitial fluid, as you can see, and infectious material. So it's very useful, and we have used it in more than 1,000 cases. It works very well in diabetic foot wounds. It's useful in chronic wounds, acute wounds, traumatic wounds, subacute and dehiscence wounds, partial thickness burns, ulcers, flaps, and grafts. There is one company in India which has introduced a single use for one patient, a disposable NPWT, and that is Smith and Nephew, an innovation in wound care. It uses gentle suction to improve healing. Just as we said for negative pressure wound therapy, PICO is used for healing the wound in promoting granulation and reducing risk of infection. And finally, I would like to touch upon the ideal wound dressing features. The wound bed should be prepared so that you can put a skin graft, which we normally do in India. We have a team approach of a plastic surgeon, podiatric surgeon, and a interventional radiologist, a vascular surgeon. So the wound bed should be prepared just as you prepare the bed for sleeping. You should prepare the wound bed, and all exudate can be absorbed. The scalpel of the surgeon is most useful, and it reduces the gap and so the risk of infection. It retains exudate. It prevents retention of exudate, means less spread, reducing the risk of maceration. The ionic silver in the biotin AG is called Alpha Sen RC 2000. Alpha Sen RC 2000 is an ionic silver, is a patented silver complex. And we also have several products like the biotin silicon AG and biotin AG. And the last slide, so technology is very much applicable to diabetic foot. Technology enables early detection of neuropathy and peripheral artery disease and why the wound is not healing, and integrated care by the podiatrist, by the podiatric surgeon, vascular surgeon, plastic surgeon, orthopedic surgeon is very important. They will all use different technologies. I want to give you a bird's eye view of the technologies which we use in our hospital, and we are one happy family, and we should try to make the people go to the after death. They should retain the two footwear, two feet, and they should go. We should save limbs, lives, and livelihoods, and we should allow the people to go to the graveyard with two legs and not with one leg. Thank you very much for your attention.
Fabulous. I think, I cannot resist saying one word, fabulous, and very simple technology which you have shown. Can you call Bansi again?
Me?
Priyanka, can you call Bansi? Is he available now? Manoj, can you call him?
So can't get through to him, and unfortunately, we don't even have a
But he's also
recording.
in a meeting in Bombay with Shashank. Maybe
Right.
he in and out because he came on the screen sometime back. I saw him. Probably he was trying to present before Amit. I don't know. He did tell me that. But he's around. He will come. Is he taking up the phone? Just try once. Otherwise, he is in a panel discussion.
Dr. Vijay Vishwanathan sir has joined. Maybe if Banshi is not here currently and not reachable, if you want to initiate the discussion part, sir,
Yeah,
unless you want to take
I
another
think that's a
talk
good
or
suggestion.
whatever, I leave it
I'll
to
go
you.
by your advice. Vijay, can I
Yes,
see
sir.
you? Make you, Vijay, it has been super great talk, great talk. Vijay, I know, I remember the thing you told sometime back in Jipmer or in Pondicherry Martin. You said that Professor Brand, what is his name, who
Paul Brand.
transplanted.
Paul Brand.
Paul Brand was asked what is the greatest technology that has come to diabetic food management. You please tell the answer. It will be very effective for all the audience.
The most important thing
Speak a
is
little louder. I think can you increase the volume of this speech?
I'm in the maximum, sir.
Yes. What did Paul Brand say? Please tell everybody little
Paul
louder
Brand
voice.
said that you have to do offloading and you should look after the neuropathic feet. The sensation is very poor, and improve the you should look after neuropathic feet. He was talking about the hands mainly because the people used to take very hot food with the hands, insensate hands, and get burnt. So the feet is also having the same problem. So he said that you should protect the feet. You should protect the feet, and that's what he said.
Great. I think beyond this question, which is very well illustrates what we should do with the diabetic food every day. Out of all this you have described, which recent technological advance has had the greatest real world impact on the diabetic foot? Any particular
The,
thing that allude to?
the particular technology which is very useful for prevention of diabetic foot is the thermal imaging.
Double imaging?
Thermal imaging. Thermal imaging.
Thermal imaging.
Which is published by David Armstrong, and we have studied in collaboration with the Stanford University thermal imaging in neuropathic
Thermal
feet.
imaging. Yes, I get your point. I saw that paper of David. Yes, thermal imaging is one of the things. He also spoke about it earlier. Remember about the socks, customized socks and thermal imaging. Good. I think.
Thermal imaging is
But
very important technology.
yeah, I think now tell us how can the digital tools that we have at our disposal, digital tools that we have at disposal, how can they support a multidisciplinary diabetic food team?
Digital tools, I can only think of one. That is the Illuminate, which is working on the AI.
Yeah.
AI, and it's a camera, simple camera, which we focus on the wound, and it is useful for the surgeon and the diabetologist who's looking after the case, and it will show you the gram positive, gram negative bacteria by autofluorescence, and it is called Illuminate. It's a technology which is developed by a startup in Chennai, and it is very useful for the surgeon to know there's a residual infection.
Really?
And yeah, after the first debridement, whether he needs a second debridement is decided by the Illuminate, which is an autofluorescence. You just shoot the wound, and the wound will tell you whether there's bacteria in the wound, whether it's gram positive or gram negative.
Good. Vijay, I have got one last but one question is about now you are the author of the program called LEAP, Lower Extremity Preventing Amputation Program. You also our hero, Vijay, for the RSSDI screening of I don't know how many lakhs, 10 lakhs of diabetic foot, whatever. Now, how does, that is a remote model. You were not present for all the lakhs of people whose foot was monitored. Foot was monitored. So how can remote monitoring and remote way of giving care and remote imaging, those technology can reduce amputation and also hospitalization?
I can only think of COVID period.
Yes.
During COVID period, people were not allowed to move to the houses, and we still manage patients through through telecommunication, through WhatsApp.
Telecom. I seeing the image on the photograph, yes.
Yeah, and we gave them advice, and we prevented amputation, we prevented infection, we prevented hospitalization, which would have been necessary otherwise. So I think it's very important to communicate with the patients, because you can't keep the patient more than 3 days in the hospital, 3-4 days in the hospital. You discharge them. So they communicate through WhatsApp, and the surgeon says, come back to the clinic, and then he comes back to the podiatric clinic. And this is how I think the COVID is the best example which we can quote in the.
Correct. Correct. I fully agree with you when you said that the negative pressure is one of the latest advance. And Vijay, what people do in the tier 2, tier 3 cities, in the taluk headquarter hospitals, they have the suction machines, suction machines. They use the suction machines and they have shown good results. That's not the ideal. They do the suction machines aseptically and they produce a negative pressure. Are you getting my point, Vijay?
Yeah. But the problem is in KCI, you have a graded pressure.
Yeah, KCI have a graded pressure. You cannot achieve that much of pressure in suction machines.
And you can alter the pressure 110 or 220, 170. You can change the pressure.
Yeah.
So which is not possible in the.
In that, yes, absolutely correct.
You can
Maybe in the hospital which has that system of central suction, maybe there one of my plastic surgeon friend, you know him, he Ravi. Ravi is doing that type of because they have not multiple. The diabetic foot is a huge burden, so he has used that. Maybe that he will tell you. But you say we cannot achieve that much of pressure in doing that. Coming back to the last question, which you are heading in the research retreat, what technology every diabetic foot caring physicians should adopt to provide optimal result? Because we are discussing it in the research retreat, you are giving the knowledge to the young doctors, what technology they should adopt, minimal technology adopt, and how they can produce research papers and benefit the patient, changing his destiny.
I think the best technology is debridement.
Is
debridement.
Debridement technology.
Give the surgeons a chance to debride the wound. That's the best technology. It's recommended
You
by
said that, the scalpel. You remember, you said the scalpel. Yes, correct.
Using the scalpel. And we can use the Illuminate technology, AI technology, to refine the surgeon skills by knowing where the infection is, which infection is gram positive, gram negative. Use the AI technology and also prediction by thermal imaging. In neuropathic feet, which neuropathic feet is going to get a problem or not.
Good.
That also should be measured by thermal imaging. These three technologies would.
I think Vijay, please bring all the photographs because you will be leading it. I don't think Ashu or me will be having any photograph of the thing you are speaking.
We'll bring it.
Thank you, Vijay. Just stay on for 1 minute. After Amit, any other question comes up. Amit, as I told you, your talk was a flow for excellence and it was great talk. And today's program has been Vijay's talk. You see how simple. He's always soft spoken. How he was flowing, beautiful. Amit, I have one question, very important question. Where does AI, it's a superficial question you may consider, but I'm really asking from the core of my heart. Where does AI genuinely add value in today's diabetes care? If you have to pick up one or two, like Vijay picked up one or two, where it adds real value? before then
I
Manoj
think
will ask some questions.
yes, sir. I think at the moment, if you look at the scope of development of artificial intelligence, the hype has been in the use of generative AI and multimodal AI from the patient's side. So it opens up the whole new dimension that healthcare knowledge is not only confined from a doctor to a end user or to a patient. Knowledge is now everywhere, and every patient has a right to look up
Get the
on their
benefit.
disease and their treatment options and discuss with their healthcare provider, especially in the field of diabetes care and obesity management. I'm saying by having contextual knowledge, if not at par, but very much on the similar scientific grounds as much as a doctor. So as a doctor also, we have to be prepared, when when our patients are coming to us, that yes, they will come back with the knowledge. Because today, to get knowledge about your disease, you don't need to look up on textbooks and PubMed. You can search on a language model that has been trained on PubMed data, and it's going to beautifully give you the explanations in layman terms. So I think this is a big paradigm change. This is what I was saying, sir, that ChatGPT Health being launched on an open platform by OpenAI opens the whole new paradigm that healthcare knowledge or scientific knowledge is not only limited to the clinician fraternity or the healthcare provider fraternity, and it's rightly so. So in the field of diabetes care, diabetes education becomes much augmented if it is implemented with the help of these generative AI chatbots. But again, throughout my presentation, as I showed, that with all these technology powers, it comes a lot of responsibilities and a lot of guardrails will have to be placed so that it is not being used in a rogue and it is not being used in a misused manner.
Very good.
It
Very
has
good.
to be
And
used
very
in a
detailed answer.
responsible manner. So I
But
think
Amit, I
this
have
is the
one question
primary
to ask.
development. Yes.
I mean, just to save time, we saw yours and Manoj Chawla's paper of 1,582 patients where you have used this in the retinopathy assessment, and you have showed a beautiful result. So, will you say, in a practical term, what you said is correct? Knowledge, making it everybody aware of that, you will change the scenario. It is a must. We cannot deprive anybody. But in the most practical manner, do you feel that AI genuinely has helped in the field of retinopathy screening?
Yes, sir. In the field of retinopathy screening, I think this is a segment where
And your
it
and
has,
Chawla's paper.
yes, sir, it has matured. It has proven itself that predictive algorithm can save people from becoming blind. And I think this is a part of diabetes care that has not been explored today, but it was explored since 2015 because deep learning came into existence in 2012, 2011. So since then, machine learning and deep learning models have been explored, and ours is just one paper in the ocean. There are so many literatures that prove, and FDA has also approved AI-enabled cameras. So yes, in prediction of retinopathy, this is very strongly and well proven. Myself, in my clinical practice, I've been using these cameras for the last 8 years now, and I'm pretty much confident that yes, it has improved the way we treat
Thank
diabetic
you. I think
retinopathy and
great.
refer to our
I think also, Amit, in our medical institute, Manoj, our radiology professor and the department uses AI extensively for the reporting. And we also, all the difficult cases, we put in the MedSage AI or whatever AI available to us free to get the right answer. Great answer. But one word of caution, how do you avoid over-reliance on the AI? I mean, just tell in practical terms, one or two sentences. I mean, how do the clinicians retain clinical judgment? I know I don't think they're losing it, but I'm just asking it for the purpose of question. They can retain their clinical judgment at the same time, no over reliance on AI.
Sir, whenever we are using any technology that can function in an autonomous manner, and there's a lot of automation happening, then there is always a risk of de-skilling the professional skill of the expert. This is exactly where literacy comes in, and this is a fact of life, sir. We are all knowing what is good and what is wrong because we understand something by the virtue of our education. And it is the same AI education and AI literacy that will help a person decide that how much of AI is good for me and how much of AI is bad for me. It should be used in a judicious way. It should be used in a very individualized, judicious manner. It cannot be cut by one single barrier, but I'm sure humankind will learn to evolve using this in a responsible way.
Manoj,
Yes, sir. I
pick
wanted
up,
to
pick up
add to
one.
that.
Is a KBC 7 crore question. Pick up one out of many that has been discussed just now. One technologically enabled intervention that has most proven impact on the diabetes outcome.
So, sir, for me, the answer is very clear. I think after the advent of insulin, one aspect which has transformed or can contribute to improving lives of people with diabetes worldwide is the innovation of CGM. The technology of monitoring with CGM. Of course, today you have multiple aspects where it has progressed to, including the integrated CGM systems, the connected care, and so on. But to simply answer, so diabetes was always about enriching the individual to be able to see and do more and equipping that person living with diabetes. So the fact that today the individual has the means to be able to see their glucose movement and accordingly make changes in their lifestyle or therapy has been the best advancement that technology has offered in for improving the care for people with diabetes. So for that one answer amongst many,
I
it would be
100% agree with you. But Manoj, I have a complaint against you. Now, we were quite well off by paying less money, but because our patients are not that wealthy and doing it for 2 days. I'm just telling you jocular when you said no, it has to be done for X number of days and the price has increased. So many poor people are not able to get this 2 days. 2 days also was giving some idea about the CGM and we're modifying treatment. Your comment on that?
So, sir, when it was those 3 days when originally Medtronic launched the CGM Gold, it was still costing us about 3,500, 4,000 rupees. Today, when the professional came, and that's why we argue that for countries and self-pay markets like India, the Libre Pro was fine. Even though patient couldn't see it real time, it was allowing the physicians to look at the trends. A lot of clinics in India would call the patient every 5 days, download the data, help them, and within the cost of one CGM, help them at least 3 times. I think that was important. Unfortunately, the professional model has been removed largely because globally it was seen that without actually seeing the data real time, the patients were not able to make changes, and the retrospective changes that we would do had limited benefits. Though we can argue on that front that no, for our population, it was still helpful. And which is where only with the real-time CGMs now, the cost lies anywhere between 4,000 to 6,000 rupees based on different clinics and aspects. But I think for every technology, sir, the price goes down, or with time, the affordability improves so the more and more patients are able to use that. And which is why we have that one paper in India that many of us, along with Dr. V. Mohan and others, have pushed the aspect of intermittent use of CGM. So though we may love to see the use of continuous use, as physicians also, we need to be practical what we advise the patient based on their needs. Sometimes the intermittent use is also good enough for patients' direct benefits, and then indirect ability of the clinician to see the trend and help them with therapeutic changes.
Thank you. Great answer. Only 3 questions. Last question, rapid fire. I want single sentence answer, starting with you, Manoj. Now, how should physicians individualize technology which can be adopted based on the patient's capability, affordability, and disease type?
So a great question, and I think that is what is important today. Yes, sir. When we're trying to talk about the adaptation and use of technology, I think it's also important for every clinician to understand which technology is going to be useful for that particular individual in front of you. Now, I may believe a lot in CGM, but it may not be the best one for every individual. So whether it is to offer SMBG, which today also is available as connected care, the use of CGM, the use of insulin pumps for some, and then probably wherever AI can augment that benefit, where do we want to use AI in our practice or patients' benefit? It will have to be individualized. I don't have a wide
ready-made
array
one
of
answer.
examples to give that one
Single
answer.
answer.
But yes, I think all of us, as we are getting little more literate in the digital health segment, we are identifying those aspects where we can try and help an individual patient based on their needs, their comorbidities, their affordability, and their technical ability. There are a lot of people there who can afford use of CGMs but would never scan, and hence we would have loss of data. So for those individuals, just to keep doing in the CGM where they're not scanning and losing data would not be very, very appropriate. So hence we tend to identify where what can help and then offer that benefit to them.
Thank you. I think, Vijay, the last question, single sentence question, is a naughty question. The naughty question is, Vijay, there are people who are just watering down the hyperbaric oxygen therapy, and one of them is our common friend Andrew Bolton. What is your independent, frank, honest opinion about use of hyperbaric oxygen in diabetic foot? Nobody listening except you and me, Vijay.
I wrote the IWGDF guideline, and I was asked to particularly look at hyperbaric oxygen. Hyperbaric oxygen. It is not useful.
No.
It is not useful.
That's all. That's all. Single answer. We'll not discuss it. It's not useful. Not useful. Good. Last question to Amit. Amit, what safeguards must be used to maintain data quality, bias reduction, and patient safety when using AI-driven tools? It is a loaded question, Amit. I know the answer will be extensive, but I just want, for the brevity purpose of time, very, very brief answer, maybe one or two sentences.
Okay, sir, I will try my very best. It's a big domain that you
A big
opened
topic,
up when you asked this question.
Yeah.
But okay, I think the primary safeguard at the moment is having good quality data on which these models are being trained on. And for that, we need more and more of data. No matter what much of AI technology we talk of, if we can't build homegrown Indian models, it's not going to work on Indian patients. The first step is to get our data structured and digitalized. And the second step is to contribute with the data towards AI research. So that is the first step. Going forward, what is going to augment the whole thing is interoperability. That is safe and secure data sharing, maintaining the privacy and integrity of the patient's data. That is going to be the most important thing. And third is also, which I'm very happy that the government of India is very proactive about this, is strong safeguarding guardrails and regulations by the lawmakers of the land and quick adoption and implementation and changes to these, as the technology evolves. And this is important because the DPDP Act is now in place. The CDSCO, who gives software as a medical device licensing, they have evolved with some newer guidelines. And very soon you will see the government of India is coming up with a health AI strategy for the country. So I think on these lines, I think we are heading in the right direction.
Thank you. Dear friends, big round of applause for both the speakers, Amit and Vijay. And big round of applause for Manoj, who contributed quite a bit and made this session very interesting. And thank you very much for joining us and enlightening us. We are passing on to the next session, and I will invite
Thank you,
Dr.
sir.
Thank you, sir.
Yes.
Thank you so
Manoj.
much.
You moderated so well.
And
Thank you so
Vijay,
much.
I must tell you that Vijay has been he has been one of my most important brother, and who has contributed maximum. Diabetic foot is we want to stop amputation. He is the leader in that, and what he said was simple, not very expensive, and those technologies can be applied tomorrow in our day-to-day practice. Vijay, thank you very much. My sincere apologies, but Vijay, I think this also will drive home in the February end. Thank you very much, Vijay, for a very nice lecture, and it was great.
Your moderation is extremely useful to clinicians, those who are present and listening.
It has been, Vijay, it was great. I mean, you
Thank you,
did
sir.
not go into this hyperbaric oxygen, did not go into this very sophisticated gate analysis, gate lab. Vijay, you, as usual, not today. Vijay always is brief, always sticks to the time, and always gives things which is very simple. Thank you, Vijay. Thank you. Thank you so much.
Thank you, sir.
Thank you. We'll pass on to the next session, and it's a very interesting session. Can I invite Dr. Srikant Dhar? Dr. Sikandar, are you here? He is the professor and head of medicine at the Som Medical College. Yes, Shrikant is here. Shrikant, kindly take over, and the session will start right now. And and we have loaded speakers. Unlike Vijay, we have now Sanmugavellu. We have a discussion. We have an interview with Sunil Gupta. Following the sitting president, Dr. Vijay Viswanathan, we have Sunil Gupta, the incoming president, and we have Deepak Jumani, and we have Rakesh Shah. And maybe I will now request Dr. Sikandar to take over. Sikand? Sikand, are you there?
Sir, Dr.
Shrikant, are you
Shrikant is
there?
not here right now. Dr. Shrikant is not here right now.
If he's not here, it's my great pleasure. Is Dr. Sanmugavellu here? Sanmugavellu? Sanmugavellu? Sanmugavellu of Trichy fame, the walking encyclopedia of diabetes. Sanmugavellu, are you here? Yeah, he's here. It's too short a biodata for a too big a person. Dr. M. Sanmugavellu is from Tamil Nadu, from Trichy, and he has left his footprint in the diabetic academics, which is one of the highest order. We call it walking, talking encyclopedia in diabetes. For the patient care, he works in a center in Trichy, which is fabulous. Also organization, he has been very well in the organizing the RSDA annual conference in Chennai with his team, and he has also in the central committee contributed immensely. Now, Sanmugavellu is going to speak to us on very key subject. Key subject is impact of cardiovascular kidney metabolic syndrome. That same thing, CKM. That is the most important contemporary problem we are discussing. So what is the impact of this cardiovascular kidney metabolic syndrome, the CKM syndrome, on diabetes morbidity? Over to Professor Sanmugavellu.
Respected chairpersons, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on impact of cardiovascular kidney metabolic syndrome on diabetic morbidity, with a particular focus on evidence-based findings. I thank Professor A.K. Das and Professor Dr. Alok Kanungo for their kind invitations. Duality of my disclosures, what I'm going to do for another 15 minutes. The contents of my talk plan includes introduction, cardiovascular renal metabolic disease, stages of CKM syndrome, algorithm for the management of patients with the CKM syndrome, conclusions. So cardiovascular kidney metabolic disease health is a clinical presentation of pathophysiological interactions among metabolic risk factors such as obesity, diabetes, chronic kidney disease, and cardiovascular system. The clinical implications of poor CKM health are significant, with the potential for premature mortality, excess morbidity, multi-organ disease, and high health care expenditures driven largely by the burden of cardiovascular disease. The high prevalence of poor CKM health, that is the population, is a public health emergency, but it is accompanied by a period of great opportunity. To improve CKM health related outcomes, guidance is needed regarding CKM staging approach, which can reduce the syndromic progression, risk prediction approach that reflects the outcomes, and the optimal strategies for prevention and management of CKM related adverse outcomes. Cardiovascular renal metabolic disease. What is the definition of cardiovascular renal metabolic disease? It's a syndrome, systemic disorder, characterized by pathophysiological interactions among metabolic risk factors, CKD, and cardiovascular systems. These overlapping etiologies lead to multi-organ dysfunction and a high rate of adverse cardiovascular outcomes. Includes individuals at risk for CVD due to the presence of metabolic risk factors, CKD, or both, and individuals with existing CVD that is potentially related to or complicates metabolic risk factor or CKD. the interconnectivity between CRM disease that is increasingly well recognized, and the approach to treatment is becoming more holistic. So we have the metabolic components like type 2 diabetes, obesity, which may increase the risk for cardiovascular disease. Equally important, it can increase the risk for CKD, which in turn increase the incidence of heart failure and hospitalization for heart failure and cardiovascular death. So we have lifestyle modifications, classical treatments, and new treatments. So before 2016, treatment focused on reducing the cardiovascular risk factors, hyperglycemia, blood pressure, and RAS inhibition. After 2016, SGLT2 inhibitors and GLP-1 receptor analogs demonstrated risk reduction for CV and renal outcomes. So early coordinated treatment is crucial to improve patient outcomes and quality of life. Major guidelines and scientific statements used in the CKM Health Crosswalk, or we have the ADA position statement. Next is we have the American College of Cardiology consensus decision pathway, and we have the KDIGO guidelines. Again, DCRM multi-specialty practice recommendation, ADA standard of care, European Society of Cardiology guidelines, as well as AHA presidential advisory on cardiovascular kidney metabolic health. So the pathophysiological triad, CRM diseases, coexist or amplify each other and progress. Coexistent, having more than one common condition increases the risk of developing another. Amplification, risk and costs are higher for patients with multiple CRM diseases. Progression, by that we mean natural progression of CRM conditions resulting in complications over time. So CRM diseases are highly prevalent globally. We have several million people living with obesity, overweight, type 2 diabetes, chronic kidney disease, metabolic dysfunction associated steatotic liver disease, heart failure, as well as cardiovascular disease. So CRM diseases overlap. That is, patient with the CKD, they have cardiovascular disease, and several patients of the heart failure have CKD. And patient with the type 2, they have CKD, and patient with the type 2 and hypertension, they are independent risk factor for end-stage kidney disease, and 16% of patients with the heart failure, they have comorbid type 2 diabetes and CKD, and 33% of patients with the type 2 have cardiovascular disease. Nearly 20 to 40% of patients with the heart failure have type 2 diabetes. They have bidirectional relationship. The coexistence CRM disease is driven by a constellation of shared risk factors and pathogenic mechanisms. So we have chronic inflammatory conditions, high burden of adverse social determinants of health, gender-specific risk enhancers, family history of diabetes, kidney failure, and cardiovascular. Ultimately, this can lead to imbalance in energy, hepatic steatosis, inflammation, fibrosis, insulin-resistant hyperinsulinemia, dyslipidemia, ultimately resulting in obesity, NASH, type 2 diabetes, chronic kidney disease, acute coronary syndrome, and stroke, heart failure with preserved ejection and reduced ejection factor, reduced ejection phenotype. Dysfunction of one of the cardiovascular, renal, or metabolic systems can set off a cascade of multi-system dysfunction. So patients with metabolic abnormalities, they present with insulin resistance, inflammation, and patients with renal disease, they have hypertension, fluid retention, and patients with cardiovascular problem, they have ventricular hypertrophy and cardiac failure. So the interconnected nature of cardiovascular, renal, and metabolic diseases amplifies the mortality risk. So a patient diagnosed with a cardiovascular or renal or metabolic condition and ultimately lead to development of additional CV, renal, or metabolic risk factors, and patient can progress to 2 or more CV, renal, or metabolic conditions with coexistence of 2 or all the 3 CV, renal, or metabolic conditions together is associated with increased mortality over time. So CRM diseases evolve through a time continuum. So we have the risk factors: diabetes, hypertension, dyslipidemia, obesity can give rise to endothelial dysfunction, left ventricular remodeling, heart failure, cardiovascular death, or associated with increased urinary albumin excretion resulting in CKD and end-stage kidney disease. So early intervention is the best way to help protect patients by reducing the risk associated with these interrelated conditions. So summary of interconnectivity and pathophysiology of CRM diseases. CRM diseases have a high global prevalence with the shared risk factors and pathogenic mechanisms. Coexistence of cardiovascular, renal, and metabolic diseases amplifies the risk of complications, and CRM disease progresses and evolve over time. So early intervention is key in reducing the risk of morbidity and mortality. There are many different ways we can support the implementation of CRM guidance to optimize patient care, what we call it, focusing on patient-centric care with contemporary obesity management, supporting healthy lifestyles in communities, interdisciplinary care, and access to therapies, CRM education, and health literacy. So outcome-based guidelines and initiatives for CRM care models are available. So we have the ADA. Next is we have the CARE-Me UK guidelines. We have the Medscape UK guidelines, as well as the Journal of Diabetes and Complication, DCRM multi-speciality, as well as AHA scientific statement. So comprehensive care models, they provide a framework for the management of CRM diseases. So we have the cardiometabolic clinic model, behavioral psychologist, dietitian, nutritionist, cardiometabolic specialist, diabetes educator, rehabilitation physician. So we have the outpatient clinic model aim to facilitate interdisciplinary collaboration between specialists to deliver prevention, focused treatment to people at risk of or other with established cardiometabolic disease. So we have the stages of CKM syndrome. Stages of CKM syndrome include stage 0, no risk factors. So with a particular focus on primordial prevention and preserving the cardiovascular health. So stage 1, excess or dysfunctional adipose tissue. Stage 2, metabolic risk factors and CKD. Stage 3, subclinical CVD in CKM syndrome. Stage 4, clinical CVD in CKM syndrome. So the CKM syndrome most commonly originates from excess adipose tissue, dysfunctional adipose tissue, or both. So multiple pathophysiological processes related to dysfunctional adipose tissue result in insulin resistance, eventual hyperglycemia, and inflammation, oxidative stress, insulin resistance, vascular dysfunction are highlighted as central process leading to the development of metabolic risk factors, progression of CKD, heart-kidney interactions, and to the development of CVD. So metabolic risk factors and CKD further predisposed to cardiovascular disease through multiple direct and indirect pathways. Next is what is adiposopathy. It is anatomically manifested by adipocyte hypertrophy, visceral adiposity, or ectopic fat deposition that results in adverse endocrine and immune consequences. And white adipose tissue is essential to human health, but its unhealthy expansion is thought to be the key mechanism behind adiposity-related pathologies. So pro-inflammatory changes that includes we have the fat expansion through adipocyte hypertrophy that changes a shift to an adverse adipokine secretory profile. There's an imbalance between pro-inflammatory factors like tumor necrosis factor alpha, interleukin 1 beta, R6 or 8, and anti-inflammatory factors like interleukin 10 or adiponectin. So the conceptual diagram for CKM syndrome, excess or dysfunctional adipose tissue associated with metabolic components like hypertension, dyslipidemia, or metabolic syndrome, diabetes, that results in inflammation, oxidative stress, insulin resistance, vascular dysfunction, resulting in metabolic dysfunction, associated steatotic liver disease, increased glomerular hyperfiltration, resulting in cardiovascular chronic kidney disease, and that in turn results in neurohormonal activation as well as increased plasma volume expansion, albuminuria, and together with changes with reference to myocardial remodeling, fibrosis, and cardiac dysfunction, resulting in increased incidence of cardiovascular disease. So the screening approaches for CKM syndrome. Screening for overweight and obesity, blood pressure assessment, started at the age of 3 years and annually thereafter, mental and behavioral health, and next is fasting lipid panel recommended once between 3 and 11 years, and again between 17 and 21 years. Additionally, check fasting plasma glucose or oral glucose tolerance test and the liver enzymes. And we have next is the screening for social determinant of health, measurement of BMI and waist circumference, screening for metabolic syndrome components, and screening for advanced liver fibrosis related to MAS LD, and assessment of urinary albumin creatinine, CXC calcification, subclinical heart failure screening, and these are all the things we need to screen. And risk enhancing factors include chronic inflammatory conditions, high risk demographic groups, especially South Asians, high burden of adverse SDOH, and mental health, sleep related disorders, gender specific risk enhancers, namely the premature menopause, adverse pregnancy outcomes, polycystic ovarian syndrome, erectile dysfunction, and so on. So we have the algorithm for the management of patient with CKM syndrome. So algorithm for the management, or patient with the CKM syndrome, stages 1 to 3. So stages 1 to 3, we have the promotion of cardiovascular health with an emphasis on life's essential 8 factors. Eat better, be more active, quit tobacco, get healthy sleep, manage weight, control cholesterol, manage blood sugar, manage blood pressure. Next is stage 1, excess or dysfunctional adiposity. So we have the intensive lifestyle intervention, pharmacotherapies and bariatric surgeries. Next is stage 2, metabolic risk factors and CKD. So established cardiovascular CKM risk factors, presence of Met syndrome triggers intensive lifestyle intervention, targeting the multifactorial risk factor management, namely the management of hypertriglyceridemia, hypertension, moderate to high risk chronic kidney disease, as well as management of hyperglycemia. Next is we have the stage 2 subclinical cardiovascular, stage 3 subclinical cardiovascular disease in CKM syndrome. That includes subclinical atherosclerosis, CAC, that is coronary artery calcification, more than 0, less than 0 or more than 100. We need to put the patient on aspirin, primary prophylaxis, and subclinical heart failure based on the echocardiographic finding. And we get the CVD risk equivalent for stage 3 CKM, namely very high risk EKD or high predicted CVD risk type. Next is stage 4, management. Patient with the CKM stage 4 with existing cardiovascular disease, so promotion of cardiovascular health, systemic screening for SDOH, interdisciplinary care, and of course, management of excess or dysfunctional adiposity, management of hypertriglyceridemia, hypertension, CKD, as well as dysglycemia. And patient with atherosclerotic cardiovascular disease, we need to put the patient on ACLT2 inhibitors or GLP-1 receptor analog. So if you see one, look for the others, prevent and treat. So components of CKM syndrome, call to action, supporting healthy lifestyle, implementation within and across health centers, enhance obesity management, CKM education, interdisciplinary care, addressing research gaps, and access to pharmacotherapies and consideration of social determinants of health. So it is all our responsibility. Socio-ecological framework for the CKM syndrome. We have the societal factors, community, relationship, behavior, as well as individual predisposition on the background of genetic and epigenetic factors. In short, CKM health reflects the intricate interrelationships among metabolic risk factors, CKD, and the cardiovascular system. Poor CKM health has a significant implications for adverse clinical outcomes, most notably cardiovascular morbidity and premature mortality. However, there is a growing array of therapies and healthcare strategies that have a great potential to improve outcomes for the patient with the CKM syndrome. Thank you very much for your kind listening.
Shanmugavelu, it had been absolutely great understanding, great detail, and it is great. So I know words to express. I will now invite, we'll be having the question answer, I will be having the discussion. May I now invite Professor Dr. Rakesh Shahai to kindly join us. Rakesh? Rakesh is the professor and head Department of Endocrinology at Osmania Medical College and Hospital, Hyderabad. He is the president of RSSDI in 2024, past president of ESI 2022, president SAFIS, South Asian Federation of Endocrine Societies 24 and 25, section editor for tropical endocrinology is Endotext, editorial board member of the IJEM. He has many awards, including the Fellowship of the National Academy, FAMS, Fellowship of the American College of Endocrinology, Fellowship of the RSGI, and fellowships of all the 3 colleges of physicians, and Fellowship of the Indian Academy of Clinical Medicine. Dear friends, I will stop here and let us listen to him on a very important topic, the prevention and therapeutics in the MASL. People call it NASH, used to call it NASH, but now it is called MASL. And it is very appropriate we put it here because Sarnukvelu has declared about the CKM, cardio protection, kidney protection, metabolic protection. And Rakesh is going to supplement it with the most important one, that is the liver protection, the MASL. The liver is also one of the things that must be taken care of because 60% people have MASL. So over to Rakesh, all is yours.
Sir, can I just
do it after the next one. I have a problem in diagnostic. Yes, I have a problem in sharing my slides right now. Can I just do it after the next one, sir?
I couldn't follow, Rakesh. Tell me again.
No, can I just do it after 10 15 minutes after the next talk? Then I can.
Yeah, we can wait. We can wait. I think we have a beautiful interview with Deepak Jumani. So shall we have it first, Rakesh? It's
Yes,
good.
yes,
It will give you 15 minutes, 20 minutes of time. 17
Yes,
minutes
yes.
actually. So I have interviewed one of the very famous doctors of our country, Deepak Jumani, who is the one of the most. If you pick up one person who has maximally contributed to the benefit of our understanding of diabetes and sex, is Professor Deepak Jumani. Can I have his biodata, please? Can I have the biodata, please? Shruti, can you put his biodata? He is a professor at the JJ School of Hospital. No, Dr. Deepak Jumani at the very famous JJ Group of Hospitals, the Grand Medical College. He is a fellow of the Society for Sexology of the United States, Global Societies, and he also teaches at the SAR JJ Group of Hospital, Grand Medical College. He is also attached to the Mumbai Police Hospital. He has introduced diploma courses in the sexual medicine, very successful course, and has published extensively. I had the good fortune of interviewing him, and here is before you to listen to that. Please play it. We'll have the interview played first for 15 minutes, then Rakesh will talk. Yes, it is the clear cut. I would like
My dear friends, and the large number of doctors who have joined to listen to this very interesting session, the interview of Professor
Increase the voice, please.
Dr.
Increase the volume.
Deepak Jumani. Dear friends, to introduce Professor Jumani in few words, to describe him as a senior sexual health physician in our country. He is the honorary assistant professor at the SAR JJ Group of Hospitals and the Grand Medical College, also in the Mumbai Police Hospital, fellow of the Regenerative Clinical Medicine. He is a Dr. Bishiroy Awardee and diplomat of the American Board of Certified Clinical Sexologist, fellow of American College of Sexology, and he's the course director and mentor of fellowship in clinical sexology of the Maharashtra University of Health Sciences and co-chairman of the IMA's initiative for sexual health in our country. He is also an expert in the cyber crime intervention and is the officer for that, appointed with the Government of India, and is author of the bestseller, Sex Has No Expiry Date. Quote, Sex has no expiry date, unquote. Dear friends, let us welcome Professor Jumani with a big round of applause. Thank you, Deepak, for joining. Now,
my pleasure, sir. Bless me.
Thank you. Dear friends, we are here to discuss something regarding a very important complication. My professor Moses used to call it secretive complication. It is really very important to know about it. You know, Professor Deepak, today we know that the prevalence of male sexual dysfunction is more in type 2 than type 1, almost 66% in males, and also about 59% females, overall 61%. 61% of the diabetics have sexual dysfunction. So let us begin, Deepak, by listening few words from you about diabetes and sex.
Thank you, Professor Dr. Das, my mentor, my teacher. Bless me. I also thank Dr. Alok Kanuo for this particular interview, because unless and until we talk about something, there is no solution to that. So sure. I really appreciate Dr. Kanugo for arranging this interview and spreading it to the masses for the benefit of all.
Yeah.
Now let's talk about sex. Sir, sex is not secret. Even a small child knows what is sex.
Absolutely.
But we must understand that sex is not secret but sacred. It's a sacred song of our soul. We are all born out of it. And today, when we talk about diabetes, sir, diabetes today, according to me, is a manageable metabolic malignancy.
Absolutely.
And it's a sexual health tsunami of our century. Sexual problems or dysfunctions in diabetes are very common, medically manageable, and of course preventable and treatable also. Today we talk freely about controlling sugars, blood pressure, cholesterol, but when diabetes affects sex, we fail, we become silent. Sexual dysfunctions in diabetes, sir, is not a taboo. Please understand, it's not a taboo, it's a tool. It's a tool that helps detect vascular disease early and helps prevent critical events like myocardial infarction or stroke, and also preserve relationship and improves lives. Sexual dysfunctions and diabetes aren't shameful thing. It's biological, and ignoring it can cost more than intimacy. Today, let's break silence around this taboo and talk about it, what the body has to tell about it. In diabetes, sexuality is not a luxury, but it's a biological vital science. When I say that first warning sign of diabetes complications isn't your blood test, no, HbA1c, no, not at all. But in your bedroom, what happens in your bedroom, that is the first sign. So sexual dysfunction, according to me, are one of the most earliest and most ignored signals of vascular damage. It's not about quality of life, but it's about how you diagnose it as early as possible, and it's an opportunity for us for giving a chance to our patients to prevent critical events. It's a body's whisper or signal much before the heart screams. So when intimacy fails in diabetes, the heart is already at risk. So we must try to find out these symptoms much before then. So when you treat intimacy issues, you are treating the coronary arteries much earlier. This is what I wanted to say about diabetes and sex.
I think
it is a manageable problem. My laboratory is not the pathological laboratory where patients go and do FBS and postprandial and HbA1c and lipid profile and ECG and all. My laboratory is the bedroom. What the patient tells me as early as possible, that's my laboratory.
I think, Deepak, this introduction has been fabulous, and it has set the ball for our interview, and it has made many points clear. It has given us to understand that sex is sacred. What happens in the bedroom can be the initiator of diabetes' first complication. It also says that the entire life, the cardiac dysfunction, the various other dysfunctions centered around the sexual dysfunction, both in males and females, and it is very, very widely prevalent. Thank you, Deepak, for setting this scene for our interview. The first question I'll ask you, Deepak, is a very simple one, but the listener wants to know from you why the sexual dysfunction, Deepak, is so common in diabetes.
Sir, what happens in diabetes? There is definitely a damage to the blood vessels, nerves, and of course hormones. All these are hijacked. And these three things are very important for a normal sexual functions. Glucotoxicity due to chronic hyperglycemia leads to not only the endothelial dysfunction. Now, endothelium, we all know, is a life jacket and the guardian of our entire vascular system.
Correct.
Okay, it manufactures the main miracle molecule, which is nitric oxide. So that gets dysfunctional. Not only endothelium gets dysfunctional, but even the mitochondria get dysfunctional. There is neuropathy. There is reduced nitric oxide availability. And diabetes, we know, is an inflammaging disease. And there is definitely hormonal imbalance. All of these directly impair the desire, the arousal, and the performance, both in diabetic men and diabetic women.
Great. I think you have said it all beautifully, how diabetes affects the endothelium, which is taken today, as you rightly said, the largest organ of the body. And endothelial dysfunction is one of the most important issues in the diabetic sexual function and of course for our life. The second question I like to have is what you said just now, a few minutes back. Is sexual dysfunction an early sign of setting in of diabetic complications, Deepak.
Absolutely true, sir. Sexual dysfunction, especially in men, the erectile dysfunction in men, and of course the arousal disorders in women, if you take a detailed history, these two symptoms appear at least 5 to 10 years before any major cardiovascular events occur. So now it is erectile dysfunction or arousal disorders in women are considered to be the subclinical cardiovascular disease, and these are the early clinical markers of systemic vascular disease, particularly in diabetics.
Yeah, I think, Deepak, I read somewhere, as you rightly said, the erectile dysfunction can be as high as 85%, or
Yes.
maybe at least 20%. It's a very widely prevalent thing. And as you rightly said, that this is a marker. I can call it a biomarker. It's a biomarker of the beginning of diabetic dysfunction. And today's world, more than any other time, we want to diagnose diabetic complications early. The slogan is catch them young, catch them early, so you can reverse it. And sexual dysfunction gives us the key to diagnose it early. Very, 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 very beautifully said. Very beautifully said. Now, I just wanted to know that, between the type 2 diabetes and type 1 diabetes, is there a differential in the sexual dysfunction?
In type 1 diabetes, it is more prevalent than in type 2 diabetes.
Exactly.
That's one, because diabetes sets in as early as, childhood and all that. So they are on insulin, so they have more glucotoxicity. In diabetes, not only both type 1, type 2 diabetes have issues with the sexual functions, but even both male and female also have the same issues. In diabetes, in men, commonly we see is erectile dysfunction, reduced drive or libido, ejaculation issues, and of course, because of less testosterone, hypogonadism. In women also, we see less desire. We call it hypoactive sexual desire disorder, poor arousals, there is dryness, there is painful intercourse, and there is reduced orgasm, and of course, distress. And there are a lot of infections which happen, candidal infection, vaginal infections, which are very common. So here what happens is the biology overlaps, in both male and female. But because of the cultural inhibition and this social silence, females don't come out with all these issues and they go undiagnosed. This is the main issue, sir.
Yeah, I think the term you have used, social silence, has to be underlined. And if you can make the women free from the social silence and come out of this taboo, it will be definitely diagnosed very early in them also. As you rightly said, that today, the government was looking for, like for the female dysfunction, female health, we have the bone density, etc., of the pelvic bones, all that, osteoporosis and all that. But for the male dysfunction, I have read recently, Deepak, that the male sexual function is taken as a marker, because male sexual dysfunction, as you rightly said in the beginning, is related to the coronary disease. So therefore, as you rightly said, is a great marker of sexual dysfunction. Now, can you tell us, Deepak, how does diabetes affect the male sexual health differently?
According to Masters and Johnson, the male sexual response begins with the desire, leads to arousal, orgasm and ejaculation, then there is a resolution. So diabetes affects every phase of these male sexual response. It affects the desire by hijacking testosterone. Patients become hypogonad. Mostly every diabetic is hypogonad. Yes. It affects erection because we all know endothelial dysfunction. And of course, there is ejaculatory disorders. People who have ED, they are very anxious. So whenever they get an erection, they want to do the sex as fast as they are committing some crime or something. So they get early ejaculation. And of course, there is issues with the satisfaction and and distress success. So this is what happens in men in diabetics much earlier than any other symptoms occur.
Correct. But Deepak, I have always wondered why this erectile dysfunction is so prevalent in diabetic men. Having about 60-65% of the type 2 diabetic men having sexual dysfunction is paramount, is a huge burden in type 2 diabetes. Why men have it?
We all know, sir, that diabetes is not only an inflammatory disease, but also a vascular disease. An erection is nothing but blood flow and a proper vascular event. Now, what happens? The endothelium, which is the life jacket or the guardian, which is throughout the cardiovascular system or throughout the vascular system, gets affected. So we know that nitric oxide, which is the main initiator of the whole erectogenic process, the production of nitric oxide reduces, one, because of advanced glycated end products, oxidative stress, and the endothelial dysfunctions. The penile arteries do not respond very well. They do not contract or relax well. And the cavernous nerve, because of autonomic neuropathy, prevent the adequate blood flow and the smooth muscle relaxation. This makes erectile dysfunction much apparent and earlier and more severe in diabetic men than in non-diabetic people.
I think it's very important what you said to remember. The diabetes is not only a metabolic disease, it is primarily is a vascular disease. I think that is the point in which we say that that's why the vascular system gets involved, and that is the beginning of the male sexual dysfunction. Very, very important to remember. Now, the female sexual dysfunction in diabetes is rarely discussed. As you rightly said, social silence or whatever the taboo. But why it is so important?
It's very important. See, we are all born out of her, we need to respect feminism. We always consider women to be, okay, it's normal, it's maybe psychological. So it's always misdiagnosed and there is a neglect. And there is definitely, these women are suffering emotionally, physically also, but they don't talk about it. Many women are told that these symptoms are psychological, age related. So the real causes of these are ignored. But we all know the microvascular disease, the neuropathy, the estrogen imbalance, and the insulin resistance, all these are equal in men and women both, so they also suffer, they also have it, but it's less spoken about, and that's why this remains inhibited. There is cultural taboo, there is social silence, women don't talk about it, what will my husband think, this, that, and all, so many things. They fear judgment, being judgmental about it, and this goes into silence, and it becomes more. Most of the diabetic women, sir, in my last 40 years of practice, I have found that they are depressed. And they go to they're sent to psychiatrists, and psychiatrists add antidepressants to them. They don't need antidepressants. They need emotional closeness. They need physical intimacy, which is lacking in them. And that's the treatment for them, not antidepressants or any other thing. So this is what we need to understand in women. Women develop low desire. That is the first thing because of the hormonal imbalance. And second thing, depression, which is very common in diabetic women. And they are mistreated, misdiagnosed, or underdiagnosed or not diagnosed at all, and considered it to be okay, chalta hai, that's what it happens, now you are aged and things like that. So this is what is making it more worst.
I think Deepak, I cannot thank you more, because you have very beautifully discussed how female sexual dysfunction occur, why it is very rarely discussed, and as you rightly said, because of the silence, social silence, it delays diagnosis and care. Am I correct, Deepak? So it is very important to diagnose early, which we miss. Deepak, I have a very important question to ask. Diabetes management is centered around establishing good glycemic control. Am I correct? Our endeavor today, of course, is a total management, but one of the most important facets of diabetes management today is a good metabolic control. I want to ask you a very important question. The nation wants to know, because they can do it. Does good glycemic control provide benefit for the sexual dysfunction? Can it?
Very true, sir. Every sexual dysfunction in diabetes, the mandate is that you must have a good control on glucose. That is for sure. But by the time it is diagnosed, by the time he is taking medications and trying to control his blood sugar with medications or with insulin and lifestyle measures, it's little late, So controlling glycemia will not only help in progression of the disease, but it will partially reverse, especially if it is addressed as early as possible. But long-standing diabetes, what happens? There are not only functional changes, but also structural changes which happen in the penile architecture, which cannot be reversed. This is why early screening and intervention is very important. Whenever any diabetic comes, endocrinologist or diabetologist tell, oh, you take tadalafil, you take sildenafil, it's okay. They don't try to give them counseling on lifestyle measures and also how to control their sugars forever. Their aim should be to make diabetes reverse. That should be the aim of every doctor. And that can be possible with strict lifestyle modification and of course medications for some time. And if they do that, these sexual dysfunctions can be improved. But yes, we need to be proactive. Patients will not do it. We have to counsel them more. We have to give them time. We have to hear them properly, not just prescribe them SGLT2 inhibitors or insulin or whatever you give. That's going to help to some extent, but what is going to help them is your counseling and making them realize that your lifestyle intervention or lifestyle modification, which will definitely assist or which will be the backbone of you becoming normal sexually in the bedroom.
I think you have said a very, very important point, Deepak, for which I'm very thankful. You have said, echoing the current practice when we say that the early control matters, faster control matters. If you control the sexual dysfunction early, by diagnosing early, by intervening early, by counseling early, the trajectory of the sexual dysfunction will change. So the beautiful message. Am I correct, Deepak?
This yes, very true, sir.
Drive deep into the minds of everybody that early diagnosis by proper screening and early treatment can prevent and change the trajectory of type 2 diabetes as regards the sexual dysfunction is concerned. This is a very important message. Now, the next question I want to ask you is a very, very fundamental question. Is it all in the body or is it all in the mind? Is sexual dysfunction in diabetes, males and females, is a purely physical phenomenon or it has a psychological counterpart?
Very true, sir. It is both biopsychosocial. It's both. What happens is a man is very particular about his potency. If on a day he is not able to get erection, it hits his brain like a brick on his head, So he feels that his manhood is attacked. So he's very desperate about it. And this sets in the psychological distress, anxiety, etc., and maybe depression also. So not only diabetes, which causes physical damage or the structural damage to the penile corpora cavernosa and the architecture, but this anxiety which he got, maybe because of psychological ED, adds anxiety, depression to it, and he develops some sort of stress which increases because of the fear of failure. He not able to perform again, and all these things perpetuate the whole problem. So we need to treat both psychologically, both the mind as well as his body. We need to correct his sugars. We need to counsel him, tell him this happens to all, but it's manageable. Nothing to worry about it. It's your body which is signaling that it needs certain help. It's not about your masculinity which is gone for a toss. It's your body which is giving you which is whispering you or telling you, yes, I need little help. So understand, it's like getting fever with any infection. We get warned about it. It's a signal. Similarly, we should consider these symptoms to be as a signal, as a body which is telling you, please correct yourself now. This is a problem. So that is what we need to try and tell our patients. and so that they don't feel that they are the only victims or they are the only person having it. We must make a general statement that most of the diabetics have these issues, but these are all manageable issues. These are transient and this can be treatable or manageable as very soon.
I think, Deepak, you have really discussed the vicious cycle, the anxiety, the fear that I am not going to perform well, the fear of failure, and it definitely affects the psyche and is a vicious circle. Am I correct? It's a vicious circle, very important vicious circle which drives the sexual dysfunction. Now, I just want to ask you that in today's parlance, we talk about mind-body medicine in diabetes. I think from that point of view, it is very important to remember that the sexual dysfunction has to be addressed both physically and also psychologically and also socially. What's your comment about that?
Yeah, the thing is, it definitely affects because he starts feeling his esteem is low, his confidence is low.
Absolutely.
And he feels very inferior. When he tries to avoid having sex, he starts giving excuses. He develops an avoidant behavior, and this makes the partner feel that perhaps I'm not so attractive now. That's why he's avoiding me. So it's both, it's the stress on the partner as well as in him. So it's definitely creates a dent in the relationship, and there is distress. And this distress, if it is not corrected by taking help or going to doctor or seeing a good specialist, it increases further and further and worsens the whole situation. So the most important thing, my take home for all will be, please ask your patients when you are taking a history in diabetics as to what are the symptoms, etc. But please ask one simple question, that do you have problems in making love? Please ask. This is not a vulgar question. It will open up a different angle completely. And if you are able to resolve this issue, intimacy issues, you will not only give him longevity, but retard the critical events like myocardial infarction or stroke in his life, because you will have an opportunity to create opportunity to treat the other issues like, lives like exercise, diet, etc., and reduce his burden, metabolic burden, and repair the metabolic syndrome which he has.
I think Deepak, it is so true, and I'm so grateful that we have brought this to the forefront. As he rightly said, as Deepak has been saying from the very beginning, the erectile dysfunction is a vascular dysfunction, and it's an indicator of the impending coronary disease in the males, and it has been taken as the marker of the male dysfunction. The type of male health, not only sexual health, the overall male health is also reflected in the sexual dysfunction because it's vascular. And therefore, diagnosing it early is paramount importance, and that must be part of our counseling. Deepak, it has been said, and I have also seen instances where some of the anti-diabetic drugs, some of the anti-hypertensive drugs, they also promote sexual dysfunction or even erectile dysfunction. What's your comment on that?
In my 4 decades of practice, have come across 4 quadrants of patients: one diabetics, hypertensive, dyslipidemics, obese patients. These 4 patients, when they walk in my clinic, I get my antennas on and I feel these patients could be having or should be having erectile dysfunction. Now, I have yet to come across a family in which there is somebody who's having hypertension. Every family, there is 1 or 2 person who has hypertension. Now, hypertension, we know, is vasoconstriction, definitely reduction in blood flow in the penile architecture, and they do get erectile dysfunctions. So they take antihypertensive. Now, the commonest antihypertensives are either beta blockers, calcium channel blockers, ARBs, or centrally acting, whatever antihypertensives they take, or diuretics. So some of the antihypertensives, even in patients who are having hypertension, we should be aware, we should avoid particularly beta blockers, diuretics, and centrally acting antihypertensive drugs. These three drugs are very dangerous. They will worsen the erectile dysfunction which the patients already have because of hypertension. So it's like adding salt to the wounds already existing. So according to me, in patients who are diabetics also having hypertension, we should take a history of what medicines he is taking for hypertension and try to change the medicine if he is on diuretics. And if diuretics is a must, he must take indapamide, which is less toxic for sexual dysfunction. If at all beta blocker has to be given, we must give nebivolol, which is very good, can be given. So, and the other, according to me, ARBs, calcium, all are okay. But these two drugs are very notorious to increase or worsen the whole situations. Not only antihypertensives, but even antidepressants, even tablets like diazepam, alprazolam, all antidepressants, SSRI, every drug can also lead, if they are taken for a long time, can result in erectile dysfunction. And certain lipid lowering drugs like fenofibrate, we know it's going to cause erectile dysfunction. Certain other drugs, like youngsters today are more bothered about their hair, so they take finasteride, they take minoxidil, so that also is harmful. Certain other youngsters who go to the gym instructors give them certain hormones, certain powders, etc. Those are anti-androgens, or whatever androgens also if they take, they also harm them. So basically, we have to take a history of what medications our patients are on when they come to us. Maybe that can be the cause of the issue which he has. So if we correct those drugs, if we change those drugs and give them a good talk and tell them that this was the medication which you should avoid, which can worsen, and then he will feel better. And he will also tell, case doctor, since I've started propranolol, I have got this issue. Since I've started this, I started atenolol, I got this issue. So I was thinking, why the hell this is, but my doctor said I have to take because my pressure will rise. So we need to counsel them and tell them that these are the medications, or we ourselves should have wisdom. When we see diabetics having the hypertension, we should avoid giving these drugs and be safe.
I think it's a very important piece of knowledge which we should drive home every physician's mind. I think you have given the secret, which is very important, what drug to use and what drug not to use. Now, do you think that the hormones are important in the diabetic sexual dysfunction? If you can highlight on that point a little bit, Deepak. Are the hormones important, and how?
Very important. Very, very important, sir. Every diabetic, every obese, we see that visceral fat will not only convert his testosterone, which may be normal, due to aromatase into estradiol. And that is the main reason. And even in patients who are diabetic, we have found these patients to be having low testosterone. So testosterone in males is very important. Why? Because testosterone not only produces sperms, etc., all those things are there, but it is also important for maintaining the architecture of the penis, the tunica albuginea, the vascular system, the sinusoids, the muscles, everything, the function of all these are dependent on testosterone. And what we have studied, my friend Dr. Paresh Dandona from US, he did a beautiful study for 2 years. He said that these patients don't respond to PDE5 inhibitors which they are taking unless their testosterone level becomes normal. So we need to have a normal testosterone for the PDE5 to act. And hence it is important for us to understand that because of diabetes, his testosterone is low. Because of obesity, his testosterone is low. So we need to correct the testosterone. Of course, with caution, we have to do his PSA and see that he does not have any prostatic issues. And guarding all those things, if he has got no PSA issues, no prostatic issues, we can surely give them testosterone and make the testosterone level normal so the PDE5 inhibitors can act and he can have a good quality of life. And same is it in women. Estrogen imbalance occurs in diabetics, which is proven beyond doubt. And these functions reduce the desire, basically, not only in men, in women also, reduce the orgasms, increase the pain, irritability, itching, etc. Everything what happens is maybe because of less estrogen in men, in women, which is being hijacked because of diabetes and of course aging.
I think it's a beautiful thing that we have pointed out, how the hormones are important both in males and females. Now we come to the most important part of this interview, Deepak. It is regarding treatment. Just wanted to ask you, are PDE5 inhibitors enough to treat diabetic erectile dysfunction?
No, sir, not at all. See, PD5 inhibitors, if I give PD5 inhibitors to a diabetic whose sugars are not under control, whose pressures are not under control, whose lipids are not under control, who's got low vitamin D, low B12, he's a smoker, he's an alcoholic, it will not benefit him. It's like giving paracetamol to a patient who's got typhoid. I'm not treating his typhoid. I'm just reducing his fever. He may get improved blood flow. He may be able to get erection, but then again after that he'll be square one. That's not the way. That's not the way to treat. We have been taught primum non nocere as we took our oath. So what we must understand, diabetic patients of course are less responsive to PD5 inhibitors unless and until you have a metabolic repair completely. We see that their endothelium is restored. We have a lot of strategies to improve endothelium. Also, mitochondrial dysfunction, which is very common in diabetics, has to be made functional. And a lot of other strategies like even hormone replacement can be given. Then these PD5 inhibitors work. Otherwise, they don't work.
Very important, very important. I think, Deepak, while you were on this subject, a common practitioner will definitely pay heed to what you have said, that the lifestyle comes first. Those repairs of the lifestyle, etc., comes first. They have a very important impact on the sexual dysfunction. Then comes the drugs. Having said that, sildenafil, what the maximal dose you use? Tadalafil, what the maximal dose you use? And when they do not work, what are the other drugs you use in your clinical practice? Because Nelson wants to know, because you are the person in the country who has maximum experience, Deepak.
I have used all the PD5 inhibitors in my practice. When it comes to sildenafil, there are a lot of patients who come and tell me, doctor, I bought Viagra from the chemist and it didn't work. So we need to counsel a patient as to how do we take these drugs.
Correct.
They are very effective drugs. I don't say that they are not effective. They are wonderful drugs. They are definitely erectogenic drugs. They don't increase the desire, but they are erectogenic drugs. Now, if at all I have to give a diabetic or a non-diabetic sildenafil, I must look at four things. One, what is his weight? And accordingly, I need to give him the dose, maybe 50 milligram, maybe 100 milligram. He's little bit above 60, 70. I need to give him 100 mg. I don't have to give him 50 mg. Number two, I need to tell him to take it at least an hour and a half before or maybe 2 hours prior to dinner if he's planning to have sex after dinner. This is the second thing I need to say, because it is better absorbed on empty stomach. The third thing I need to say, which is very, very important, to eat less. Eat less dinner, because post heavy dinners, most of our body's blood gets collected on the stomach and the intestine to digest the food which we have eaten, which is a must. And in doing so, your private parts are deprived of the optimum blood which you need to get a desired erection. So, and the last most important thing is we need to ask them that after you take this tablet and follow these three things, please think erotic. Don't read Bhagavad Gita or Hanuman Chalisa or watch Astha channel or pray to God. No, you need to stimulate yourself. You need to think erotic. And if he has not had sex for 3 to 6 months in the past, or maybe a year, he need not jump on day one after taking sildenafil to have sex. He need to sleep with the partner, do everything possible, maximum foreplay, but he should avoid penetration for day 1, day 2, day 3. This is a must because in day 1, day 2, day 3, he will feel the difference, but he has no agenda of penetration. He will feel the difference and experience the change in him. This feeling of difference and experiencing the change in him will give him confidence which he was lacking. So on the 4th day, he can plunge into it. And that's how this part of counseling has to be done to a patient whom we give sildenafil. Now, tadalafil is a long acting drug. The action lasts for 17 and a half to more than 18 hours. So we need to think, should we give him this medication if he's planning to have sex in next few hours? Yes, you can give him, but the effect will last long. So this can be given during weekends. Second thing about tadalafil, which is very important and studied deep, it is studied extensively. This can be given for a longer time. But tadalafil is known to be 80% present restored in the cells. 20% of it is excreted out. So we are scared of the side effects of these PD5 inhibitors, which is headache, backache, bluish discoloration, dyspepsia, and so many other things. So we need to give them, if we give them the full dose, say tadalafil 20 mg, and if he is prone to getting side effects, he will get severe backache or severe headache or anything like that. So to avoid that, we need to give them a very small dose, maybe 2.5 mg or 5 mg. Now, out of this 5 mg, 80% of it will remain in his cells and 20% will get excreted. But if we give them over a period of 6 to 7 days, at the end of 6 to 7 days, he'll have at least 10 to 12 milligram of tadalafil already there in his body. And on the next day, when he takes another pill, he will get better erection and no side effects. And tadalafil can be taken even after meals or before meals, but we must keep a gap of 2 hours before the act. So these two drugs have to be given to a patient, but before giving them, we need to counsel them. We need to tell them like that. Most of the patients who come to us do not respond because they took it 5 to 10 minutes before the act. They didn't stimulate themselves. They took it with alcohol and so many other things. They took it on heavy meals. So this does not work. So we need to tell all these things to our patients when they come to us. And when they ask for when we have to give PD5 inhibitors, we need to counsel them and give them this piece of advice so the drugs act effectively.
I think very important clinical practical tip you have given, Deepak. I think it is great to listen to you on this particular aspect because the drugs are available. We must know how to use it, when to use it, and you have given a clear practical clinical algorithm how to use it. Thank you very much. I have got 2 minutes left, Deepak. I have to ask you quick fire questions. You have to just tell me 1, 2, 3, 4. What are the lifestyle interventions that have the strongest impact on the sexual function?
Most important, try to reduce your weight as much as possible. Correct. Weight loss. That's the biggest culprit. Increase your physical activity, at least 30 minutes. Out of the 30 minutes, 10 minutes should be brisk walk and 20 minutes can be lazy. And of course, plain vegetarian diet. Correct. That has to be must. And of course, sleep, 6 to 8 hours sleep. Don't have to have stress of any sort because whatever is going to happen will happen. You and I can do nothing about it. We need to accept everything what happens in our life and adapt to the new situation. Reduce smoking or stop smoking, stop alcohol, stop beer. If at all any hard drink has to be taken, they can take red wine, which is much better. So these changes in the diet, my 3 friends, one is Dean Ornish, very close to me. His beautiful study that intensive lifestyle reverse the coronary artery diseases. Correct. Even 98% blocks have been removed completely for the next 5 years. Another friend, Caldwell Iseltisin, he's from Cleveland Clinic. He also has proven that nutritional intervention not only halts but even reverses the coronary artery disease. And lastly, my friend Linus Pauling, who got 2 Nobel Prizes. Now, when he received the 2, who gets Nobel Prize, sir, such a brilliant scientist, when he received the 2nd Nobel Prize, he announced to the world that every disease is because of nutritional deficiencies.
Correct.
What else we want? We need to check our nutrition.
Yes.
I feel we fall sick only because what we put in our body and what we do for our body. These are the two things proven. So this is what lifestyle we need to follow completely, and you will not need medicines.
Correct. I think great. I think this interview, Deepak, I'm absolutely delighted, has been practical, has been clinical, with beautiful tips. My last question to you before we close, last 1.5 minutes. Deepak, please give your heartfelt message to all diabetic who have sexual dysfunction. And also add to it, what is the single most important message for the listeners about diabetes and sexuality?
In diabetics, let me boldly say that sexual dysfunction is not a shameful complication.
Absolutely.
It's a vital sign that your vascular system is being affected. So please talk to your patients and ask a history that do you have problems in making love. You will do lot of benefit to him by asking this simple question. It's a meaningful signal which your patients will give you. Correct. If you listen to it early, you can protect not only his intimacy issues, but not only his relationship issues, but his life. You will save his life. You will have enough window period of curability where you can counsel him, change his lifestyle, control his sugars, lipids, etc., and improve his metabolic health, cardiovascular health, and of course, give him a good quality of life.
Deepak, I cannot thank you more. It has been an evening which has been so great, and it has been a knowledge explosion which all of us wanted to know, to listen from the horse's mouth. Deepak, I have watched, as you rightly said, your growth in this area, and you have gone to the pinnacles of wonder. It is God's grace that you have achieved so much of expertise. You have said simple things which can definitely change the life of our patients. Those simple things, coupled with medications whenever required and given properly as you outlined, will greatly impact the life of our type 2 diabetics, type 1 diabetics, and change their destiny. On behalf of all of us, a very sincere, loving gratitude and thanks to Deepak. Please
bless me, sir. Thank you very much, and bless me.
Thank you. Thank you. Great. It has been a veritable interview, which is absolutely fabulous. Thank you. Thank you, Deepak. Thank you.
May I now invite Dr. Srikant Dhar, who has joined us. Can I have this Dr. Srikant Dhar's introduction slide, please? Srikant Dhar is the professor and head of medicine at the Som Medical College and Hospital. Can I have his introduction slide? And while it is coming, may I have the introduction slide of Dr. Rakesh Shah. I've already introduced him. Now, Srikant, are you there? Srikant? 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 Can you call him?
I think he's muted, sir.
Yeah, we'll start the session. He will start. Srikant is there, no? But I would like to say, no, Srikant? Acha. Professor Srikant? Professor Srikant? Professor Srikant? Huh? We'll continue. You will call him? Dear friends, I have introduced Professor Rakesh Sai as one of the most knowledgeable clinical practical endocrinologists of the country, head of the department at the famous Osmania Medical College and Hospital. And I have given his affiliations and his great organizational ability and memberships and the chairpersonship at organizations. Now, today, Rakesh is going to speak to us prevention and therapeutics in NASH and NA-MASL, and it will be a good complement to what Shanmugavelu had just now said. Over to Professor Rakesh Sahai.
Thank you, sir. Thank you for the kind words of introduction. I would discuss about this topic, sir. I'll just share my slides. 1 second, sir. So as as Professor Das has just highlighted the need, he spoke about the need for liver protection in people with diabetes, following what Dr. Shanmugam has already brought in the concept of cardio, kidney, and liver and metabolism being all coming together, and we need to address these issues together in a patient with diabetes. When you're treating people with diabetes, we are looking at not just looking at the numbers of glucose levels or the lipid numbers or the BP numbers, but we are looking at providing a wholesome cardio, kidney, and liver protection in people with diabetes. So I'll just highlight the need for this and the importance of this, because what we have realized is that this epidemic of what used to be called as non-alcoholic fatty liver disease, or now as we call it as MASLD, is like an elephant in the room. Although it is present in so many people, we fail to recognize this, and we do not give it the importance that is required in terms of preventing not only the progression of the liver disease, but also looking at the cardiovascular and protection in people with diabetes, and renal protection in diabetes, which is again intertwined with this issue. So if you look at the prevalence of this problem, it is huge. As you can see here, the numbers are quite evident. And when you look at the association of this condition along with the metabolic problems, you see that 90% of obese people have NAFLD or MASLD, as we today will call it. Type 2 diabetes, 70% have this. Those with high triglycerides, 83% of them have this problem, and hypertension. When you look at hypertensives, almost again close to 70%. So this is a problem which is closely intertwined with the metabolic conditions. Even in women with PCOS, this is a very common occurrence. And that is the reason why we have this change in nomenclature, as I'll be discussing in the next slide. But what I would like to highlight here is that there is a significant increase in the prevalence in the last few decades. We have been recognizing it more often, and what we have seen is that as you can see here, we have a huge burden of this problem of prevalence of MASLD and type 2 diabetes in amongst our population, and we need to address it effectively. We looked at a prevalence of this in a countrywide study, and what we found was that the prevalence was close to 60%. To be precise, 56.5%, and amongst the females it was 60%, and males it was 54.3%. Again, as we've just as I just spoke, that from the earlier nomenclature, non-alcoholic fatty liver disease, which did not really convey the link between this problem and the metabolic parameters or the metabolic syndrome. This rechristening of this term of this condition has happened, and it is now called as the MASLD, metabolic dysfunction associated steatotic liver disease, which means that in the presence of steatosis in the liver, more than 5% fat in the liver, if there is additional metabolic risk factor like either elevated triglyceride, low HDL, type 2 diabetes or pre-diabetes, obesity, or high blood pressure. These are all the components of the metabolic syndrome. If any one of these components is present along with the presence of fat in the liver, then it qualifies for the terminology of metabolic dysfunction associated steatotic liver disease, or MASLD in short. And we all know that insulin resistance is the root cause of not only diabetes but also for MASLD. And in this figure, we can understand how insulin resistance is contributing towards the development of diabetes, and in the process, in those who do not develop diabetes, they manifest with either MASLD, or they present with predominant complications of atherosclerosis,
and all the other conditions that we are aware of in terms of the metabolic syndrome. And if you look at the impact of this, impact of diabetes on NAFLD, MASLD, or MASLD on diabetes, you see that there's a bidirectional relationship. What we see is that those with diabetes tend to, as compared to non-diabetics, they tend to have a higher risk of progressing to fibrotic liver disease and going on to developing cirrhosis and hepatocellular carcinoma. So there are a lot of studies which have looked at this, and clearly this is shown not only in small studies but also in large population database also. As you can see in the US population database also, you have seen that those with diabetes tend to have a very high risk of progression to cirrhosis, HCC, and the going on to requiring liver transplant. And today the major cause for liver transplant has become the NAFLD, causing cirrhosis caused because of NAFLD. Now, and NAFLD, and also the other way, if you look at the other way around, NAFLD has a significant impact on the development of diabetes also in those with pre-diabetes. Those there is a very high risk of progression to diabetes with the presence of NAFLD, and similarly in those who already have diabetes, there is a high risk of cardiovascular disease and all the other complications associated with diabetes. So in fact, what has become important now is that NAFLD or MASLD is more useful in predicting incident diabetes, diabetes onset, than BMI. So if you have people with the same degree of same BMI, you'll see that those who have got NAFLD have a higher risk of progressing to diabetes than those who do not have NAFLD with that degree of BMI. And as we can see, the prevalence of cardiovascular events, whether you look at CV events or fatal CV events, or whether you look at all-cause mortality, is much higher in individuals with diabetes who have MASLD as compared to those who do not have MASLD. And this is again another set of data which is again showing that not only the liver-related complications but also the cardiovascular complications and all other complications of diabetes are much higher in those who have MASLD, and particularly even when you stratify them between those who have got isolated steatosis versus those who have got NASH, you see that it is much more in those who have NASH. And we know that this problem progresses from the initial accumulation, just the deposition of fat in the liver, excess fat, going on to inflammation, lobular inflammation, and then going on to ballooning degeneration, and then fibrosis sets in, and then it progresses towards the development of full-fledged cirrhosis and hepatocellular carcinoma. And we are seeing that this is more common in individuals who are having all the other metabolic risk factors. And as you can see, most patients are now, because of the fact that we are not including this as a non-communicable disease. It's important. There's urgent need to include this condition as a non-communicable disease. And because of this non-inclusion, we are seeing that many patients are being allowed to develop cirrhosis, and they are going towards more fatal outcomes, as you can see the data which is shown in this slide. So if you look at the fibrosis also, I mean, if you look at every stage of fibrosis, you can see that it is much more prevalent in people with diabetes as compared to those without diabetes. And you look at F2 or F3 fibrosis, you can see that it is much more common in people who have diabetes. Even and alcohol use also. I mean, the earlier terminology that NAFLD had a misleading connotation, but now we see that we have other conditions like MET ALD and ALD also happening in people who have got metabolic syndrome associated liver disease, and also in them also addition of alcohol worsens the prognosis and adds to the problem. And as you can see here, the addition of metabolic syndrome factors, that is, you have one metabolic trait versus those with two metabolic traits versus those with three metabolic traits, they tend to have a higher and higher risk of progressing towards major adverse liver outcomes. So they are all now put together as MALD. As we said, major adverse cardiovascular events. You have major adverse liver events, liver outcomes. So all those are predicted by the number of metabolic traits that are present, metabolic syndrome traits that are present in that individual. So this is something which has become very clear in the recent past. We have got data to show that the accumulation of these metabolic syndrome traits adds on to the worsening liver outcomes. And we have rising the rising a burden of advanced liver problems increases to the financial burden, which is quite obvious. So what does the American Diabetes Association, the nomenclature, we already discussed this, so I'll not spend time on that. But what I would like to highlight is that what has been suggested not only by the ADA, but also by many other organizations, scientific organizations across the world, have been suggesting that, and this is the ADA 2026 algorithm, which says that in all people with type 2 diabetes, those with pre-diabetes, and those with obesity with at least one CV risk factor, adverse CV risk factor, they should be screened for MASLD. And how do we do the screening? The first step is to do a FIB-4 score, and that FIB-4 score is a very simple parameter which can be calculated from the CBP and the LFT. Based on those parameters, you can calculate the FIB score, and once you have the FIB score, if it is more than 1.3, then this is the person who is at risk for MASLD, and he needs a better evaluation. He needs further evaluation, and the further evaluation can be done with the ultrasound initially, but later on by doing a fibroscan, and you're looking at the LSM, the score, that is the stiffness index, and if it's more than 8 kilopascals, this is a person who further requires more advanced liver management. While if there is only steatosis, then they need to be appropriately managed, and need to be appropriately treated with medications that are going to be favorable for the liver related outcomes. And also, these are the individuals who need to be addressed towards prevention of CAD, prevention of CVD, and other complications of diabetes. So, if you look at the approved medications available and the treatment algorithm for such individuals who are having MASLD with and in different stages of liver involvement, what we would say is that in the initial period, it's more of obesity pharmacotherapy where we are, and whether you look at the obesity pharmacotherapy, you can classify these three into three. That is obesity pharmacotherapy, then diabetes related pharmacotherapy, and the MASH related pharmacotherapy. So in the stages of early stages of MASH, that is F0 or F1, the therapy predominantly needs to be addressed towards the obesity and diabetes. And here again, the use of the preferable use of GLP-1 RA and or the dual GLP-1 GIP RA therapy, or pioglitazone and SGLT2 inhibitors are the preferred agents for diabetes management. For obesity management, it's mainly the GLP-1 RAs. Now, again, when you progress towards F2 to F3 MASLD, there is a role for MASH therapy with resmetirom, and also plus or minus GLP-1 RA therapy. For the diabetes and obesity pharmacotherapy, again, the same agents as we spoke of in F0 or F1 hold good. That is the GLP-1 RAs particularly, and the dual agonists, and pioglitazone in case when there is diabetes is additionally present in that individual. For compensated cirrhosis, as we said, that we need to look at avoiding MASH pharmacotherapy, but looking at particularly obesity and diabetes pharmacotherapy with caution, particularly when you're looking at declining liver parameters. And again, when you go towards decompensated cirrhosis, then we need to be using only insulin for diabetes management and avoiding the use of other pharmacotherapies. Now, if you look at the pyramid approach of the management of this condition, we know that in the low risk setting, it is a scenario where we know we need to look at a bottom up approach treatment of the underlying obesity and type 2 diabetes, and the cardiovascular risk is very important in that scenario for all individuals with diabetes and risk for MASLD. And when looking at those with moderately increased risk, particularly the risks there are the cardiometabolic risk, cancer, and liver fibrosis. And in such individuals, we have in addition to the GLP-1 based therapies that are particularly useful for the diabetes and for obesity, we have vitamin E, pioglitazone, and then resmetirom, which has been a recently approved drug for which is a thyroxine beta receptor agonist, which has a role particularly in those with F1 to F3 fibrosis, is the scenario where you can have a role for this agent. Lifestyle interventions are required for all, and care of the comorbidities, particularly type 2 diabetes, obesity, heart disease, vascular disease, and cancer screening should always be done. Now, let me just tell you about resmetirom and just show you some of the features of resmetirom. This was a phase 3 study with resmetirom 80 and 100 milligrams or placebo versus placebo. What we see is that there was a clear resolution of MASH resolution, fibrosis reduction with higher doses of resmetirom, and changes in the LDL, favorable changes in the LDL cholesterol. The major side effects with this molecule was diarrhea, which was seen initially in about 30%, nausea seen in about 20%, decrease in the FT4 levels and TSH normal while having normal T3 levels, increase in SHBG levels, estradiol, and total testosterone levels. However, there's no effect on heart rate, body weight, or glycemia or bone density. When you come to the GLP-1 RAs and MSLD, we have very good data from the Essence trial, which has clearly shown a resolution in the MASH histology, which has clearly shown 1 point resolution, that is from F3 to F2. There was a good resolution in the histology. There's an improvement in the body weight, resolution of the steatohepatitis also, and improvement in the overall quality of life was seen in patients who were using semaglutide, the 2.4 mg semaglutide in the Essence trial. Then we have data from the Synergy trial with tirzepatide, where there was improvement in fibrosis regression, and MASH resolution also was shown in these two trials. So GLP-1 receptor agonists are therefore very potent agents that promote weight loss and can improve both steatohepatitis and fibrosis, although they have not yet been shown to be beneficial for cirrhosis. And GLP-1 anchored dual and triple agonists are promising classes of molecules with encouraging data from the phase 2 trials. And while weight loss independent effects may exist, a substantial proportion of the benefit of GLP-1 agonists is related to the weight loss. However, while we know that there are additional benefits, but predominantly what we see is the benefit are related to the weight reduction. SGLT2 inhibitors again have been shown in data. Data show that they have reduced the steatosis, and they have also, to some extent, reduced the stiffness progression has also been shown in some of the studies, like this study from Arun Sanyal, where he looked at almost close to 8,000 individuals with type 2 diabetes and MAS, and out of which 3,000 of them received SGLT2 inhibitors. SGLT2 inhibitors significantly reduce the liver fat content independent of diabetes. Only few studies demonstrated improved liver histology in patients with MASLD, and long-term treatment is associated with improved liver outcomes, especially the hemodynamic outcomes. And there could be multiple mechanisms which are contributing to the decrease in liver fat content produced by SGLT2 inhibitors. Coming to pioglitazone, pioglitazone is one molecule which has been studied quite extensively for liver disease, and what we have seen is that it can work it has also been shown to have beneficial effects in not only in terms of fat reduction, but also in the improvement in the steatosis and hepatitis, and histological improvement has also been shown in studies. And combination therapy is therefore being proposed today with a triple therapy with metformin, exenatide, and pioglitazone, which was popularized by DiFronzo, and he has shown in a very good study, elegant study, that there are improvements in liver fibrosis measurements, fibroscan measurements with the use of this triple combination therapy as against stepwise conventional therapy. And so I think this is something which is very interesting. And now, when you look at the pharmacotherapy, this just summarizes what I've just spoken, that how we need to decide on the pharmacotherapy which should be directed towards the obesity, or towards diabetes, and the MASH-related therapy in different stages of liver involvement, as discussed a little earlier. So finally, I would like to end with the key message that MASLD is a common and critical problem which affects most people with type 2 diabetes. Hence, it is important to screen early and stage it effectively, by using fibroscan, which can help in detecting fibrosis before it's too late, and treat by organ, that is match therapy to the ASCVD, CKD, or liver priority. Combine the benefits of different agents, that is the GLP-1 RA, SGLT2 inhibitors, which are going to provide not only protection for the liver but also for the heart and renal outcomes, and monitor to prevent the later problems that can occur if you are going to leave them unchecked. Thank you all for the patient hearing. I would conclude with this and would be happy to come back for the discussion.
Rakesh, it was absolutely great, and me and Professor Srikant Dhar, the head of the Department of Medicine, who has joined us, we congratulate you. Srikant, are you there? Srikant?
Come, sir.
He's not there? Srikant is not there?
I'm there. I'm there, sir.
No,
Jayant
Srikant
is here, sir.
Sikandar is
I'm
there?
here, sir. Also, Professor Panda
Sorry,
is there.
sir. So you have to now moderate the next talk by Dr. Sunil Gupta. Please invite Sunil Gupta, sir. Next talk is by Dr. Sunil Gupta. So kindly put the now yes, talk. Now Sunil Gupta's can be focused. Sunil Gupta's yeah, you can just introduce himself, then the talk will start. Sikanji, you can introduce.
I'm honored, Dr. Das, because I'm being part of this scientific agenda.
Sir, you are there. We have been calling you. Maybe your switch was zero noise. You could not
No,
listen.
sir.
I'm so grateful, but the talk
since last
that you
1.5
listened is
year
very
hour,
great, sir.
I'm with you. Thank you, sir. Again, thank you, Kanungo sir, for giving me opportunity to have, be part of this scientific agenda. I am very much thankful that such a scientific agenda is there where everything is covered, and I'm also honored to invite Dr. Sunil Gupta for the next talk. Let me introduce. He's a president now, and everybody knows that he's a CEO and MD of Sunil Diabetic Care. National President-elect 2026, National President Diabetics in Pregnancy Study Group India, DIPSI 21 to 22. Multiple orations, multiple awards to his credit, and there is nothing to introduce him. Everybody knows as a President and Chief of RSSTI. Now I'll invite him for the next talk. Sir, Dr. Gupta is available, sir?
Yes.
He is going to speak on
You
very
continue.
important topics, sir.
Play it.
Yeah, he is GDM, a scholarly update. Gestational diabetes, a scholarly update.
Sir, we'll invite Dr. Gupta for the next talk on GDM, scholarly update. It's an important topic, as you know. GDM is the burning topic in diabetic and pregnancy, and the part and parcel of the early detection, management, everything is crucial. And no other than Dr. Gupta is the best man to, because of the DIPSI president, the best man to deliver this talk. Over to you, sir.
Over to Sunil. Yeah, start. No. This Deepak Jumani.
My dear friends, and large number.
The interview is already, sir.
Sunil Gupta. Rakesh wanted some time. That's why we have finished this one in between. So now Sunil Gupta. GDM. Yeah, correct. Sir, you can.
Good morning, everyone. And at the outset, let me convey my profuse thanks to Dr. Alok Kanungo and his team for this invitation. My today's talk is on pregnancy diabetes or gestational diabetes, scholarly update. I'm not sure whether I'll be able to deliver to the expectations of the group, but then I'll try to do justice to the topic. And thank you once again, Dr. Alok, And before I forget, I also invite you to the Hello Diabetes Academia on 19, 20, and 21st of June 2026 at Nagpur, as well as RSSDI National Program on 19, 20, and 19 to 22nd at Bangalore, November. So November third week, you are expected to be joining us for the RSSDI, National RSSDI at Bangalore. I don't have any conflict of interest for this particular session. We'll have epidemiology, something newer coming up in screening and diagnosis and newer classification. Oral drugs versus insulin, some Indian data and some carry-on messages that how should we treat, and then challenges, strategies if possible, and then the final messages. So I feel this is just a basic slide that that hyperglycemia in pregnancy now is an umbrella term, which has been, so you have a big group of people. Some of them are gestational diabetes, typically appearing and disappearing after delivery. Diabetes in pregnancy or DIP is a group of people who are being either having pre-existing type 1 or type 2 diabetes becoming pregnant, or those who are diagnosed for the first time during pregnancy but clinically have pre-existing usually type 2, rarely type 1 diabetes, and they are called a DIP or diabetes in pregnancy. Now this group requires very aggressive treatment because of the issue of organogenesis in the early 6 to 8 weeks of pregnancy, while this group usually appears after 20 weeks of pregnancy. But now recent data says that there are good chunk of group of people or women who are diagnosed before 20 weeks of pregnancy. That's another new thing which we need to understand. So we have the typical diabetes called as conventional diabetes, GDM or CGDM, which is a typical hyperglycemia repairing after 24 weeks of pregnancy. Some of the data says 20 weeks, and they are between 142 to 199 post glucose, and their diagnosis CGDM. Overt diabetes, I told you, is nothing but the DIP, diabetes in pregnancy category, where you had earlier pre-existing diabetes but never tested before, and they are diagnosed with diabetes during pregnancy. That's overt diabetes in pregnancy or DIP, DIP. Then you have EGDM. EGDM is before 24 weeks, or some of the definition says before 20 weeks of pregnancy if you have hyperglycemia but are GDM, so that's called as EGDM. There's also mild GDM. That means if their 2-hour value is between 120 to 140, because if you see your target or goals, you say that fasting should not be above 90 or 95. 2 hours should not be crossing more than 120. And mild GDM is when you give glucose, and if your 2-hour value is less than 140 but more than 120, is called as mild GDM or gestational glucose intolerance. Now this is the IDF Atlas, a recent Atlas of 2025, which says an overall global prevalence is around 20%, and South Asian India is very high. And this is about the age distribution. If you are around 25 to 30, around 17%. Higher is the age, higher is the prevalence. Almost if you are 40 plus, 44 plus, almost 50% every second woman have. But here if you see 30 or 35 age, most of the women now are coming after around 29, 30. So almost every fourth woman is likely to have hyperglycemic pregnancy. And this is a diagram which you know, the ICMR in-depth study, where you have seen dysglycemia proportion, that is pre-diabetes and diabetes. If you add them, it's almost 2.36, almost 2.4 crore people. They have either a diabetes or pre-diabetes. And moreover, I always say that the adult population of our country 96 crore. So out of 96 crore, if I have 24 crore people above 18 years of age who are dysglycemic, that means again every fourth woman of the childbearing age belongs to this category, and that is why it is that every fourth woman is likely to have some kind of hyperglycemia in pregnancy. And this is the Southeast Asia data, which again says that almost 30% here and 28% prevalence here in the Southeast Asia. India accounts of 1 in 7 of the adult diabetes worldwide, and 1 in 3 live birth are affected with hyperglycemic pregnancy. That means almost 30%. Now, why should we treat hyperglycemia in pregnancy? So we know that it is a process. GDM gestation is a process whereby multiple stimuli, the stress and stresses that occur at the critical or the sensitive period of organogenesis, and even the development of the baby, and they can give you permanent changes in the structure, physiology, and the metabolism, and they might have its impact on the baby, and that's called epigenetic changes. And that's why the concept of fetal origin of adult disease has come from David Walker. So now we should be trying to diagnose these minor form of hyperglycemia in the early stages of the pregnancy, so that we can prevent the development of diabetes or obesity and non-communicable diseases in these children born to these mothers, and in their future. So if we want to really save future generation, we'll have to focus on pregnancy. So we have two generations getting affected: the children who are born likely to develop diabetes and obesity in future, as well as mothers who are delivering, they are likely to become diabetes in future. So both the generations can be protected if you aggressively control hyperglycemia in these individuals. So who should be screened and why, when should be screened? This is a simple example: someone coming to 22 years of age, 18 weeks of pregnancy, prima gravida, normal weight, no family history of diabetes, no past bed of static history. Will you screen this patient? Yes, in India, almost Indian women are 11 times higher risk to have GDM, and that is why every woman should be screened irrespective whether they have the risk factors or not. So universal screening has been advocated by Government of India as well as DIPSI, and this is the DIPSI criteria. You give the women 75-gram glucose irrespective of the time of the meal, and take 2-hour test, and it is more than 140, you diagnose as GDM. There are two more criteria. There is another criteria called as IAD-PSD criteria, where you have to call women in the fasting state. If the fasting is more than 92, or after 75-gram glucose, 1 hour more than 180 or 2 hour more than 150, you diagnose as GDM. But this criteria is based on the Caucasian population. On Indian population, we are following this, and Government of India guidelines, which are updated in 2024 as a SOP. The maternal health and and the family welfare department has started this distribution to all the PSCs, where they have given the method of DIPSI and the criteria, everything very much in detail. And these are the updates from 2024 guidelines from the Government of India. So if your 2-hour value is between 140 to 199, it is GDM. If it is more than 200 after glucose, is pre-existing diabetes. And this is a criteria again been accepted in the IDF at last 2025. The DIPSI criteria has been also mentioned. Now, people do ask whether we should go for the venous blood or the capillary blood. So capillary blood or glucometer is also being accepted, and in the least resourceful situation, you can do that. If you have venous plasma system available, certainly you can do that. At what week? So normally 24 to 28 weeks, but then it is being recommended that you should do it at the first given opportunity. You should be screening them, because pan India, the about 1/3 of the pregnant women are diagnosed during the first trimester, and that is why we should be screening them early. And this is data from Dr. Seshia, which says almost 42% of them are diagnosed before 23 weeks or before 24 weeks. So almost only 60% are diagnosed after 24 weeks, and that's why we should screen them early. What is EGDM? EGDM is early gestational diabetes, and this EGDM means when someone has been diagnosed before 24 weeks of gestation, and there's a big burden, as I told you, and we need to really focus on that, because if you miss out them, then they will remain hyperglycemia in the first and the second trimester, which might have its bad effect on the developing fetus. So we have this lady, as I told you, we have done the GCT, OGTT or GCT, glucose challenge test, and the 2-hour value is 136. HbA1c is normal. What is the diagnosis? Diagnosis here is gestational glucose intolerance or mild GDM. So if your 2-hour value is between 120 to 140, we call it as GGI. And there are different names to this. Australia, they call it as borderline GDM. Netherlands, they call it mild GDM. Some of them, they call it as IGT in pregnancy. But this category has been recognized by various countries. This is our own data, which again says if you diagnose them early those women who have bad obstetric history, and if you treat them with even mildest form of hyperglycemia, it is just GGI or more than 120 but less than 140, you can prevent the development of or prevent the BOH by almost 85-90%. So those women who had bad obstetric history, they have been picked up and they have been treated if they are more than 120, and the fetal losses have been prevented by almost 94-95%. So mild GDM, again now globally there is systematic review which again says that they should be treated. What are the glycemic targets? So we should try to achieve fasting as less than 90, 2 hours should be less than 120, mean blood glucose should be less than 105. What about HbA1c, SMBG, CGM, and GDM or for diagnosis and prognosis? So this is CGM data that continuous glucose monitoring. You should, if in pregnancy, you should try to achieve in GDM and type 2 diabetes, pre-gestational diabetes, should try to achieve the TIR of more than 90%, and the cutoff of TIR in CGM for pregnancy is 63 to 140. Unlike a non-pregnant state, it is 80 to 180. So here you have should be choosing it 63 to 140. In type 1 diabetes, you can target for 70% TIR, but in pre-gestational type 2 and GDM, you should try to achieve more than 90% TIR. What is the recommendation about HbA1c and CGM from ADA? So ADA says due to increased red blood cell turnover, A1c is slightly lower in normal pregnancy. So HbA1c should be target to be less than 6. But if there is a risk of hypoglycemia, you can up to 7 is acceptable in preconception care. When used in addition to pre and post SMBG, then CGM can help in achieving HbA1c targets. CGM can be a complementary therapy. SMBG cannot be compromised. And ADA recommends CGM to the women with type 1 diabetes, and they have shown that that there can be a better neonatal outcome in type 1 diabetes when you use CGM. What about metformin, sulfonylurea, or other drugs? So whenever you use oral drug, you have to be cautious that they should not cross the placenta. And even if they are crossing the placenta, they should not cause hypoglycemia or fetal hyperinsulinemia, or should not have teratogenic effect on the baby. So if you see this diagram, the glucose traverses freely, amino acid, ketones also, and then but insulin doesn't cross the placenta. If you see, insulin doesn't cross the placenta, while all oral drugs, they cross the placenta, and that is why insulin remains a drug of choice. Metformin, glibenclamide, agarmose, these are the 3 drugs which have been approved. Metformin has been approved by the European authorities from the preconception till delivery after the MITI trial results. But Government of India still stick to 20 weeks and after use, and DIPSI has recently come out with the criteria with the use of metformin after 12 weeks in gestational diabetes. Then what are the absolute indications for insulin therapy? So these women who are coming to with very high HbA1c, ketonemia, renal dysfunction, hepatic dysfunction, obstetric morbidity, microsomia, IUGR, hydramnias, polyhydramnias, or steroid use, they should be used insulin primarily. And any stage of placental insufficiency, preeclampsia, we should be using insulin. Every insulin now has been approved except the glulysin, and there is some reservation about glargine that if suppose someone is taking glargine from the beginning, and if you suppose if he feels that by withdrawing glargine the glucose control of a woman may get deteriorated, in such situation we can use glargine in pregnancy. Now this is a simple example of one of the lady who's a LADA or pre-existing LADA means that slow onset type 1 diabetes, and she had preconception. This is the insulin dose in this Indian population, which again has been endorsed by the other data. So here about type 1 diabetes, in the early stage she is required around 0.7 unit per kg body preconception. At the time of 36 it went up to almost 2 units, that means almost 3 times. And then the postpartum at 10 days, almost 50% of the original dose, and 30 days at day 30, it has come down to the original dose. That means you should get a message here that you start with the lower dose, built up the dose as the pregnancy advances. At full term, the dose may go up to 2.5 to 3 times, while at postpartum, immediate postpartum, it will remain as 50% of the preconception dose, and it will take almost 1 month to come back to the preconception doses. And this is another message for all of you. And this is how the insulin goes from the diagnosis 44 units to almost 130 units here, which comes down to almost 20 units, 50% of the dose, and then again goes up to around 50 units at 30 days pregnancy. And the before breakfast dose was actually lowest, and before dinner dose was highest. That's another message to all of you that we should be monitoring post dinner blood glucose also. Insulin in pre-existing type 2 diabetes, the dose requirement in these women who have pre-existing type 2 diabetes, first trimester almost 0.5 unit, third trimester almost 0.8 unit. Insulin doses in different population of different data. Those GGI who are requiring insulin 0.1 unit starting with goes up to 0.15, GDM 0.25 to 0.4, pre-GDM 0.5 to 0.8, and pre-GDM type 1 requiring on 0.8 unit goes up to almost 1.2 units. There's also data of insulin in twin pregnancy, and it was perceived by the US data in type 1 diabetes that twin pregnancy may require double the dose than the singleton pregnancy. We have published the data where we have compared twin in GDM, not type 1 diabetes, GDM twin versus GDM singleton, and there was no additional requirement of insulin, and it behaves as a singleton pregnancy only. Twin pregnancy doesn't require double the dose. Then this is a data which has actually compared the neonatal and maternal outcome in GDM women by using which women is likely to require insulin therapy and which women likely to do well on diet therapy. So this data is around 800 pregnancy, and women receiving insulin had lower risk of preterm and low birth weight and macrosomia. Neonatal hypoglycemia was more common in insulin treated group, while the 2-hour value of more than 162.5 and or fasting value more than 90 might need insulin therapy, and propensity score of more than 0.7. They have used 3 covariates, and higher the age, duration, the higher fasting postprandial glucose, and family history and weight, and these women require higher dose of insulin. So this is another message for all of you that how should we choose our patient for insulin therapy. Postpartum follow-up is equally important, and it's a rule of 6, the 6th day, 6 weeks, and 6 months. But there's another data which is coming now. We need to have more data on this line. That 2-day postpartum evaluation has almost same sensitivity and specificity as we do in 6 weeks, and that's why it can be done. Preconception care and fitness for those young women coming to you is equally important. So young women aspiring for pregnancy is on rise, and most of women with diabetes can get conceived, but dedication towards blood glucose monitoring, glycemic control is must. Preconception counseling is must in all these women, and should be evaluated for micro and macroangiopathy. Stop all contraindicated drugs like ACE inhibitors, ARBs, or statins or fibrates before getting conceived, and stop all other oral drugs except metformin in few cases. Insulin becomes a drug of choice. Try to achieve a HbA1c to less than 6 and fasting postprandial target before getting conceived, and indication and contraindication pregnancy needs to be emphasized. Finally, we should know that 90% of the diagnosed pregnancies are accidental, and we should be prepared ourselves to face this challenge. So for the awareness, we have National GDM Day, 10th March, as Government of India has approved this and have declared this day, which is a birthday of Professor Shaya, and we should have awareness on these lines about primordial prevention, and every one of us should do this. We do this Prega Talk since last 3 years now. We have already completed a 3rd cycle, and the 4th cycle is going to start from 10th of March this year on the National GDM Day. Finally, the long-term outlook of the offspring of diabetic mother. If the glycemic control can be maximized to the extent that fetus no longer recognizes that mother has diabetes, then the treatment of mother during pregnancy may become the first step in prevention of obesity and diabetes in the offspring. So focus on the fetus for the future, And this is the final message that every pregnant woman should be screened for HIP at the first given opportunity, irrespective of their symptoms or the risk factors. Government of India guidelines are most simple, feasible, accessible, acceptable in less resourceful situations. Tight glycemic control, fasting less than 90 and 2 hour most less than 120. HbA1c can be used as a prognostic marker. CGM can be complementary. Insulin is gold standard. Metformin can be used in selected cases. Breastfeeding should be encouraged. Postpartum follow-up is very poor in India. We need to emphasize that. And primordial prevention is a promising future. We need to have more data on those lines. With this, I stop here. Thank you very much once again, Dr. Alok Kanungo, for this invitation. I'm unfortunately unable to join there because of a lot of other commitment on these 2 days. So wish you all a very happy and prosperous and healthy 2026. Thank you. Thank you very much for patience listening.
Thank you, Dr. Gupta, for the nice presentation, almost covering most of the part of GDM, and just delivering that GDM is not only important, the eGDM, the concept of mild GDM is also important. The target is also important. Every pregnancy is important. That's so diabetes and pregnancy is also important, depicting a range that we should control the glucose in most of the diabetic patient with pregnancy, being target being 90 and 120, HbA1c being 8.6, and rightly said that not only pregnancy is important, postpartum care is also important. The rule of six, the preconception counseling, everything he has depicted in his short presentation. So I think this is a very good learning from Dr. Gupta, and no other than the president can deliver such a good talk. Over to you, Dr. Das, for any discussion.
Sikant, thank you.
Any
Very
question.
nice comments. Not only that, I'll call you by first name, Sikant. Sikant, Sunil has his entire life given for two things: diabetes education and pregnancy diabetes. Sikantji, are you listening, sir?
Yes, sir. Yes, sir.
He's an authority on this. So now I'll start with the questions. Both of you will ask. So the first question I'd like to ask Sunil. Sunil, are you there? He'll join a little late, he said. Okay, then let me start with then Dr. Shanmugavelu. Shanmugavelu, he is present with us. He's one
Yes,
of
sir.
the I think because you joined by the time he had started his talk. He's called as a diabetic and medical encyclopedia. He's absolutely
Thank you,
well
sir.
informed, well organized, and very well done. I want to ask you one thing. After listening to a wonderful lecture by Rakesh, we like to still call it a political question. Would you like to still call it CKM, or you like to call CKH oblique L? H for hepatic, L for liver, same thing. M. Will you, I call it deadly quartet. Deadly quartet, cardiac, C, K for kidney, H for hepatic, L or same thing, and M for metabolic. Do you think that liver should not be brought into the focus? Yes. Question to you. Samuelu?
Yes, sir. I prefer to use the term caramel. That is cardiac, renal, adipo-metabolic, eye, including eye, as well as liver. So caramel, that stands and that covers all the metabolic parameters with reference to what myself as well as Professor Dr. Rakesh Sahai, he has explained in detail. So the word caramel is an appropriate
I
for
think I
this.
fully agree with you. Okay. The whole idea is, I would like to speak for favor of the audience who have joined. You know, as Professor Shanmugavelu had just now said, we want to bring liver to the metabolic center. That's what Rakesh said some time back. Rakesh, am I correct?
Yes, sir.
Rakesh?
Absolutely, sir.
We want to bring liver to metabolic center. When we say CKM, the liver is little away, whereas 60% of the people in diabetics have, as beautifully showed, so Rakesh showed with that bar diagram, how the prevalence is very high. So that's the reason why I want to bring it. Same thing also, Dr. Sanuvalu is telling, it's only a question of semantics, but we, Rakesh, Sanuvalu and myself and Sikant sir, we are all telling the same thing, that cardio, kidney, hepatic, and metabolic aberrations have to be addressed, and that constitutes whatever you call it, the deadly quartet of diabetes, which needs protection. The next question to you, Shanmugavelu, a very important question. Now, how does applying this framework of CKM, how can it change the risk assessment?
Yes, sir. Nice question, sir. Of course, this framework transforms routine diabetes care from a narrow focus on glycemic parameters, that is A1C based approach, to a holistic integrated strategy that prioritizes the prevention and management of interrelated cardiovascular disease as well as CKD. Of course, this shift changes the risk assessment by integrating specific CKM biomarkers as well as modifies the treatment priorities by favoring therapies with proven cardiorenal benefits. So first of all, we need to assess the risk profiling. So let us take the body weight, BMI, waist circumference, A1C, lipids, blood pressure. Next is measurement of urinary albumin creatinine as well as eGFR. And we need to follow the patients meticulously.
Absolutely same thing.
And
So,
treatment priority with reference to SGLT2
just
inhibitor and
sir, 1
GLP2.
minute. You said everything that was in our mind. So the assessment of a diabetic, my dear friends, who have joined a large number, Srikant and me, on behalf of the entire group, would like to tell you that we have to take care of blood glucose, fasting, postprandial HbA1c. We have to take care of the lipids, as Sanagul just now said. We have to take care of the urea, creatinine, and albumin creatinine ratio. If you are doing a UCAR, am I correct? If you are doing urine creatinine albumin ratio, if you cannot do the full thing, at least the ACR, and then you have to take care of doing liver enzymes. That is very important because they play a central role. That's what Rakesh gave me last time I met him. And also do one, a fifth score. Fifth score does not need ultrasound. Fifth score, FIB, fifth score, and the cutoff is 1.34. So that gives us the idea where we are. So when this question was asked, as you, I think, Sanuvali, you are brilliant. You are brilliant to the point, brilliant. And you said the exact thing, how the risk assessment be done from fasting blood glucose to FIB4 score. Am I correct?
Yes, sir.
Good.
Yes, sir.
Second question I want to ask you, and this will be carried home, that which early clinical or biochemical markers best predict progression to multi-organ morbidity? I think there is not a single. The constellation of what Sanagavallu has said, they as a group will decide. Am I correct? Multi-morbidity. So all have to be. So please, we are just urging you, making a plea with you, my dear friends who have joined, make the assessment, initial assessment of the diabetic patient holistic and centered around cardio, kidney, hepatic, and metabolic. That's the only plea that we are making, because if you catch them early, as the expert says, and catch them young, you can make a great change, very great change in their life. Now, a question which might look superficial now, but Rakesh, which people with diabetes should undergo early and systematic screening for MASL? Rakesh?
Yes. So I think, sir, it is quite clear. I mean, from the data that we have seen, with almost 70% of people with diabetes, 60 to 70, anywhere between 60 to 70% being affected by having MASLD, and particularly when you see when diabetes with obesity is there, the percentage increases further. I think given that setting and knowing the fact that many of our patients are beyond the BMI of 23 that we look as a cutoff for for saying that they are obese. I think all patients with diabetes should have a screening for.
I think, yes, correct. Like Sunil said about universal screening, we must allow universal screening for this particular thing. Absolutely. The third question I want to ask both of you, which is little tricky. Which particular clinical marker or biochemical marker, clinical or biochemical marker, will best predict the progression to multi-morbidity?
So first of all, I normally do patient's body weight, waist circumference, and correlation with reference to waist hip ratio, number one.
Correct.
Second thing is glycemic parameters. Third important thing is increased urinary albumin excretion and GFR, along with the lipid profile. Next is I do screen, that is subclinical cardiovascular disease, subclinical cardiovascular disease. By that, we can assess the ankle brachial index, number one. If condition warrants, we can also do echocardiogram.
What is first one you said? Antiplatelet?
Ankle brachial index, which will definitely ABI. So next is very important thing is we can assess the subclinical cardiovascular by doing echocardiogram, see the ejection fraction, and if necessary, you can go for NT-proBNP level or high sensitivity cardiac troponin T or NI.
As the case demands, we can go for the other part. That's a good cut.
Yes, sir.
I think Rakesh, you agree with that? That it is the
Yeah,
holistic
absolutely.
assessment?
Absolutely. Dr. Shanmugavel has put it very brilliantly, how we should look at, right from simple clinical parameters, which can give us an idea about that, and going on to the biochemical parameters like the USCR is emerging to be a very important marker. And similarly, when you're looking at the liver disease, the FIB-4 score has turned out to be a very good parameter, which can actually help in stratifying patients based on that parameter.
Yeah, I think also Rakesh, what Dr. Shanmugavalu said doing ABI is also, I think, quite stands to common sense, because ABI has become the standard of male health index, because that's the vascular predictor, that's also the predictor of the impending coronary artery disease. If you have a less ABI, I think we will accept your point.
Yes, sir. One more parameter that I would like to add, which is very important, going to becoming significant, is the HSCRP, sir.
Yeah,
That again, because inflammation is the underlying factor.
The inflammatory markers very important, because everything in medicine today inflammatory. Yes, Rakesh, continue. You said that in the last meeting. Inflammatory markers are very important.
Yeah.
Please say.
Yes.
So I think I think a initial assessment of diabetes should include this. It doesn't cost much. Even if it costs little bit of extra money, we have the special proverb that treating diabetes appropriately is cheap, because you would not have later on many complications than not treating appropriately. Very good. The last question to Dr. Shanmugavalu, how can the people treating diabetes can practically integrate and synthesize C, K, H, M protection while avoiding therapeutic complexity?
So very important thing is first is we need to identify much early. Number two, aggressive.
They've identified. The question is
aggressive
about what
treatment.
drug.
Aggressive. That is stage one. Stage one. Only adiposopathy. Patient can have associated impaired glucose tolerance or increased waist circumference like that. Catch hold of patients at that particular stage. Our aim is to prevent that particular patients to develop subclinical CVD or CKD. That is the early stage. Having gone from stage 1 to stage 2, where the patient presents with multiple risk factors with evidence of CKD and subclinical CVD, we need to prevent further progression from subclinical CVD to clinical CVD. So we have guideline-directed medical therapies. So we have efficient drugs like SGLT2 inhibitors or GLP-1 receptor analogs, along with lipid lowering, blood pressure lowering. Next is weight management, cholesterol management, like that. We can slow down further progression. And when a patient presents with evidence of clinical CVD, we need to focus our attention on the guideline-directed medical therapies with reference to whether the patient has coronary syndrome or whether the patient has peripheral arterial disease or heart failure. We need to tackle those, especially guideline-directed medical therapies.
Yeah. I think, sir, we're going to make it very simple for our audience who have joined from villages. Many people have joined. Samavalu, I'm asking you for your approval. We'll say that if you want to address this CKHM, do subclinical and clinical classification, as you rightly said, but give that the benefit of SGLT2, which has become cheaper. Am I correct?
Yes, sir.
Only the contraindication.
Yes, sir. Yes, sir. SGLT2 inhibitors definitely it's a very important drug therapy for the management of patients with diabetes and without diabetes, with evidence of atherosclerotic cardiovascular disease and without atherosclerotic cardiovascular disease, with heart failure, with CKD, everything.
Yeah.
So
exactly.
it has pleiotropic effects. So we are prescribing drug with pleiotropic effects, not only managing hyperglycemia alone, but it takes care
All these
blood
things
pressure,
you're talking.
lipid,
So
and
my dear
protection.
friends who have
Yes.
joined us for the CKHM benefit, what Professor Sanagavallu and Rakesh both have to say, because H is there for Rakesh, that if there is no contraindication, since the prices are very affordable today, and the appropriate to be used there is probably SGLT2. And when the price of GLP-1 array comes down, it will come down, I'm told, in near future, the oral, then you can use them. Good. The second question to Rakesh, I want to ask you that, somebody made a comment, Rakesh, that anything, when the weight comes down, the muscle improves. You agree with that, Rakesh?
Yes,
Whatever you
absolutely.
do, when the weight comes down, muscle improves.
Absolutely. So absolutely, I think as the weight comes down, the muscle does improve. And
So,
then, so I just want to add to the previous question
yes.
that what I would say is that today the SGLT2 inhibitors and the GLP-1 RA have made the therapy actually not complex but simplified the therapy because they work on all the components of the CKM syndrome that we are looking at. No, not only the CKLM, we can say CKHM or LM. They are working on all the components, and therefore they are making
Absolutely. So
a
now the one
simplified
final
product.
question for you, Rakesh, a little difficult and maybe you can have multiple opinions. Now, in today's parlance, how does lifestyle intervention against pharmacological option, not for the obesity, I'm telling for the real world prevention of the progression of muscle?
Sir, I think lifestyle interventions have clearly been shown to be very good. We have the data from the direct study, and that was the one which actually gave us an indication that this could be reversed, muscle, and then we have the medications which have come in later on. So I think the initial data, whether you look at the muscle improvement in muscle, or whether you look at prevention of diabetes, in all these aspects, we see that the lifestyle data has come out earlier and is still is very good. But the only issue is that in terms of having compliance to the lifestyle measures is the major challenge, and therefore we have now we have elegant drugs which are sort of supplementing the lifestyle, and so therefore we shouldn't forget about lifestyle and we should re-emphasize.
Yeah, because the sustainability, you're absolutely correct. We all want lifestyle, and that is always the foundation. Even if you are giving drug, that is foundation. But in many cases, it fails. And like earlier, you used to wait for oral diet therapy for 3 months, again 3 months, metformin for 3 months. By the time the diabetes comes to real treatment is 1 year. So now that's why you judge if you. I'm told the effects are known in first 2 weeks. If not, then go for that. The last question, which I want both of you to respond, how should liver outcomes influence the choice and sequence of anti-diabetic drugs?
Sir,
yeah.
Yes, Dr. Rakesh has clearly made a mention, and he has highlighted the various stages of fibrosis, patient presenting with obesity, patient presenting with the diabetes, and patient presenting with MESLD. What are the drugs that has to be prescribed? He has highlighted nicely. So in our routine day-to-day practice, patients, we normally look into the child book score and we modify the dosage accordingly and we prescribe. He has also pointed nicely insulin when to give in patient with cirrhosis at the end, that is fibrosis, cirrhosis like that.
Correct. I think, dear friends, this was a great session with great points to take back home. A big round of applause for Dr. Shanmugavelu and Professor Dr. Rakesh Sahai, for Sunil Gupta, and of course for Deepak Jumani, who gave. I know there's a lot of things on the mobile phone. I think I must tell you that people have liked the interview, comprehensive interview. They have liked it. Thank you, Deepak. Thank you very much. Dear friends, we'll pass on the next session. Thank you, Sanugulu. Thank you so much. Rakesh, thank you. And my words fail to express our gratitude. The next session is very important. It is on the obesity. I think all of us should stay back for this session. Very important. First two is, I must tell you that obesity is the most important problem today. Right? And it embraces diabetes. We have the term called diabesity. Even and you know, obesity has become an integral part of diabetes management. The ADA 2025 said even you can start anti-obesity drugs if there is associated obesity for hyperglycemia. You may not have to give, you saw that 2025 ADA recommendation. You may have to give only anti-obesity drugs which takes care of it. So with this context, may I now request Nita is here, to speak to us on the challenges and treatment of obesity and diabetes. Dear friend, I must introduce our very dear friend, Dr. Nita Deshpande from the city of Belgavi, which was called Belgaum. Nita has changed the name to Belgavi, and you know, she is the presiding queen of Belgavi, and she is one of the very famous diabetologists, and also the bariatric physician. And she had a very wonderful center called Diabetes Center and Care Institute of Diabetes and Obesity and Metabolic Health called SIDM, Diabetes Center and Care Institute for Diabetes, Obesity and Metabolic Health. And so Nita is going to speak to us on challenges in treatment of obesity in diabetes. Over to Nita. Can we start the talk? Nita, welcome.
At the outset, I would like to thank the Nucd team for giving me this opportunity yet again to speak at this very prestigious conference. So the topic I'm going to be talking about today is about challenges in obesity management in type 2 diabetes. So let me start by sharing my screen. Yes. So as I said, I'm going to be speaking about challenges of obesity treatment in diabetes, and what we can possibly do about that is what I'm going to be speaking about. So let's begin with a very well-known reality, and that is that obesity and type 2 diabetes are inextricably linked. We all know that obesity is a primary driver of insulin resistance and the development of type 2 diabetes. And both these conditions actually they reinforce something called a feedback loop that complicates patient management and outcomes. And therefore, treating obesity within diabetes care is quite difficult because there are barriers at several levels. There are, of course, we know biological barriers, then there are therapeutic barriers, and then we have the socio-demographics. I'm going to show you a study about that as well, and several barriers at very, very different levels. So that is what I'm going to be speaking about. So this is the actually well-known reality that we have. Now, if you look at obesity and type 2 diabetes from the genetic point of view and from the environmental point of view, you can see very well here that beta cell function is also a function of genetic effects, and so is the susceptibility to obesity. And both of these together interact with the environment, as you can see here, where all your other factors like your energy balance, what you eat, your gut microbiome, maternal factors, epigenetic factors, the birth weight, the pollution nowadays that we talk about, sleep insufficiency, and chronomedicine, all of these make up the environment, and they are going to act in conjunction with the factors that lead to obesity and the genetic factors that lead to type 2 diabetes, and ultimately cause, on the one hand, excessive weight gain, which accelerates actually the process that leads to type 2 diabetes, because obesity, as I'm going to show you in the subsequent slides, is going to have an effect on the beta cells, on insulin resistance, all of those things, and hence perpetuates the cycle of type 2 diabetes. So this is the complex pathophysiology which I've tried to make as simple as possible of obesity and type 2 diabetes. So as I showed you in the previous slide, you have genetics, epigenetics, and environment, all those different factors that I showed you, including sleep, chronomedicine, etc., etc. And all of these are going to lead to adiposopathy on one side, and it is going to lead to changes in the biology, the incretin physiology, the gut barrier dysfunction, etc. And all of them act in conjunction and affect the brain centers for obesity and for diabetes. And this is going to excessively overburden the pancreas, leading to apoptosis, dysfunction, and that is how we are actually seeing the association between obesity on the one hand and type 2 diabetes on the other. And you can see very clearly here that one aspect of obesity that badly affects the pancreas and the beta cells, which in turn is going to be responsible for type 2 diabetes, is the beta cell death that can occur in obesity over a period of time. So we know that obesity leads to systemic changes such as lipid and glucose accumulation, which we commonly call glucolipotoxicity. It causes insulin resistance, which we know over a period of time causes hyperinsulinemia and beta cell exhaustion. And importantly, which is not really discussed many times, it is the inflammation part. So this inflammation and cytokine release, all of these three factors together are going to cause a reduction in the number of beta cells. They're going to cause amyloid deposition. And ultimately, all of these factors together lead to beta cell death over a period of time. And hence, we know that obesity can lead to type 2 diabetes in this particular fashion. So we have some key challenges. The topic of discussion for me is challenges of obesity treatment in type 2 diabetes. So we have biological challenges which lead to clinical challenges. You have the vicious cycle of diabesity, that is obesity driving insulin resistance and type 2 diabetes. And then you have the therapeutics of type 2 diabetes, which again is a challenge. I'm going to elaborate that further. Secondly, we do have evidence that it is harder to lose and maintain weight in type 2 diabetes. Third, you have multiple targets to hit. And we know that obesity doesn't only affect glycemic control, but affects all the other things which can in turn be excessive risk factors, multiplicative risk factors, which can worsen the type 2 diabetes outcomes. So this is the first barrier. And that is that the biological trap that is there, it actively resists weight loss. So patients with type 2 diabetes consistently, they have more difficulty, and there's proof for that. They consistently have more difficulty losing weight compared to individuals who don't have diabetes, regardless of the intervention used. You may use pharmacotherapy, bariatric surgery, even any of the modalities that you use, you will always find, and this has been borne out in all the clinical trials with the GLP-1 receptor agonist, that patients with diabetes respond less. The weight losses that you get with these drugs are less if a patient also has diabetes. Also, these patients who have obesity and diabetes, they exhibit faster and more significant weight regain. So that's a double whammy. That means it's more difficult to lose weight for these patients, and after having lost it, they have more propensity to regain that weight. So this is a huge challenge of obesity treatment in type 2 diabetes. And these effects are because of powerful physiological mechanisms that defend body weight. Of course, these mechanisms that defend body weight or the old body weight are there even in non-diabetes patients, but it is more pronounced in patients with type 2 diabetes, as you can see very clearly in this graph that I have shown you, comparing type 2 diabetes with non-type 2 diabetes. The weight loss trajectory and the weight regain trajectory, you can see it is worse in case of type 2 diabetes. So it's an uphill battle. That means patient, if you're using lifestyle change to reduce weight, there is a fight that is going on, both physiologically and environment wise. So though we know that diet and physical activity are the cornerstones, but their long-term maintenance is an uphill battle for patients who have type 2 diabetes. And we know today that it's not lack of willpower, but it is because the body actively resists and works to regain that lost weight. You have the set point, you have the ghrelin that goes up, you have the GLP-1 that goes down, and this makes for an environment which causes weight regain. Added to that, we have a very bad environment which we call the obesogenic environment, which is modern lifestyle. This promotes weight gain, discourages healthy behavior. So here you have the biology working against you, and here you have the obesogenic environment which is making you gain more and more weight, and that is why it is an absolutely uphill task, as you can see here. What's the clinical consequence of this? The clinical consequence is that multiple metabolic targets are missed. I'm going to show you a nice study, a real world study that shows you all of this. So obesity complicates the management of not just glycemia, but blood pressure and lipids simultaneously, as you can see over here. So the higher the BMI, you're going to miss those targets. A higher BMI is strongly and directly associated with the failure to reach all the three important metabolic targets. And mind you, these are the three metabolic targets which are going to affect the most important outcome, and that is cardiovascular outcomes. So this failure of achieving these targets persists even when patients are placed on more intensive drug therapy. That means you are doing everything that you can and you're trying to get the sugars down, you want to get the weight down, but this tendency towards missing these targets, it persists. So this means that simply adding more medication is not the solution. So that is what it shows to us. Then what are the next challenges that you have in obesity treatment in type 2 diabetes? And that is treatment specific issues. I talked to you about diet and physical activity causing problems. Then you have the drug therapy causing problems. So many glucose lowering drugs cause weight gain. We know that sulfonylureas still being used actively, insulin itself, glitazones, these are all going to cause weight gain. So we need to go more towards those drugs which do not cause weight gain, with the weight neutral drugs, and there could be certain barriers to the usage of those drugs as well. And lastly, it is bariatric and metabolic surgery, highly effective but underutilized for a variety of reasons. So this is our second barrier, the second challenge, so to speak, of obesity treatment in type 2 diabetes, and that is our therapeutic toolkit, which this is just summarizing what I just told you: drug therapy, lifestyle interventions, and metabolic surgery. So you have our entire toolkit that is there. We have barriers on each front for the effective treatment of obesity in type 2 diabetes. So this is the paradox that I was talking about, that many glucose lowering drugs, that means we are getting excellent glucose control, but we could be getting weight gain. I talked to you about these weight promoting therapies. So you have underutilized alternatives. Metformin because of its GI side effects, SGLT2 inhibitors for different reasons, like candidiasis and UTIs, GLP-1 RAs again because of cost and again because of side effects, so it may be underutilized. So you have drugs actually that can cause weight loss and or could be weight neutral, but there are barriers to the usage of those. But weight promoting therapies are used a little more frequently than the ones which are weight neutral or which have weight loss properties. So this is a snapshot of the medications that are used for type 2 diabetes and their overall weight effect, as you can see here. So the medications with a weight neutral or a weight loss effect are, as we know, alpha glucosidase inhibitors, metformin. These are the cheaper ones. DPP-4 inhibitors are weight neutral, so are biguanides and alpha glucosidase inhibitors. As you can see here, it is 0 kg, so it's hardly anything. Whereas GLP-1 agonists are the one that can give you a very good weight loss, and the SGLT2 inhibitors, they cause weight loss, but it is to a smaller extent. But medications with a weight gain effect can go all the way up to 5 kgs or even more. So you have to choose very wisely. You have to do the balancing act between the side effects, the cost, and the weight losing effects, and use these drugs very, very judiciously. So this is the third one, and that is bariatric surgery, which I want to talk to you about. It's a powerful solution, but it is underutilized. And according to some studies, this is the surgical utilization gap. So this is the number of patients who could actually benefit, the eligible. So this entire gray line that you see is an eligible patient population for bariatric surgery. But look at the number actually receiving that surgery. And we know that type 2 diabetes remission can also occur with this particular modality. It has been shown to reduce long-term mortality, but it remains vastly underutilized. And we all know that is because of patients not accepting this as a therapy, then the cost, availability. So all these are the barriers to the usage of this particular modality as a means of reducing obesity in type 2 diabetes. Now we come to the next level of barriers, and that is the psychosocial and system level barriers. So one of the barriers is the stigma. So obesity is often seen as a willpower issue, and a lot of patients go through this yo-yo effect, and that is going to worsen. So that's called weight cycling. Yo-yo effect is basically weight cycling, and we know that weight cycling leads to weight regain, and it causes a worse problem in the subsequent attempt of the patient. What about the life context? So it causes work stress, easy access nowadays to calorie dense foods, and the dietary norms in the family, in that culture. All of these are going to affect the treatment of obesity and lifestyle management in type 2 diabetes. Again, the health system. Obesity, unfortunately, is not managed like a chronic disease. So structured programs are very few centers in the country offer structured programs for obesity treatment in type 2 diabetes or even without type 2 diabetes. There is very limited coverage of insurance in the country. And lastly, the adherence. Pill burden is high in type 2 diabetes. Adding one more is going to be difficult. So non-compliance is a big issue and a major obstacle. So these are the different barriers at different levels. So you have barriers at the biological level, you have barriers at the clinical level, which is actually a consequence of the biological level. Then you have the treatment level barriers, and here you have the psychosocial and system level barriers. These are all the different kinds of barriers that you face when you're treating obesity, especially in diabetes. So what's the resolution? You have to break this cycle. So if you want to improve outcomes in type 2 diabetes, a weight-centric mandate seems to be the answer. So the combination of biological, therapeutic, and systemic barriers, all of these points towards the fact that if you go towards a glucocentric approach, it's not that it fails, but it is not sufficient. Because we know, I'm going to show you some data that obesity in type 2 diabetes actually prevents one from achieving the metabolic targets. That's what I'm going to show you. So if you need to really overcome this vicious cycle, you must fundamentally reorient your strategy towards weight loss as the primary strategy towards attaining the glycemic control. So this is a nice study. It's called the TEMD obesity study, which is, they've taken more than 5,000 patients. It's a real world study. So impact of obesity on the metabolism. So exactly the topic of discussion today, the impact of obesity or the challenge of obesity treatment in type 2 diabetes. This is exactly that study. So this is the result of a Turkish nationwide survey of glycemic and other metabolic parameters of patients with diabetes. So what they found was that 90% of these patients with type 2 diabetes are overweight or obese. The number could be slightly lower in our country, we don't know, but yes. So excess weight is a major barrier to metabolic control. That's what we're going to show here. So this is what they found. And 6 in 10 patients live with obesity. women, of course, have more obesity than men. And what they found in this study was that higher the BMI levels, they were the major determinants of poorer health management in terms of blood sugar, blood pressure, and lipids. So all the three major metabolic parameters that we are talking about, they get worse if obesity is also present. Also, interestingly, what they found was that obesity was very closely linked, risk factors were closely linked to socio-demographic factors such as lower education status, physical inactivity were very closely connected with obesity. Also, higher BMI was linked to more microvascular complications, and hence there was then a greater need for medications. So this study very clearly tells you that obesity is very, very difficult to treat in type 2 diabetes, number one. And secondly, that it leads to much worse outcomes in terms of metabolic control in general, because it affects the blood pressure, it affects the lipids, and it affects glucose. So to conclude, the problem is we have a vicious cycle here with obesity and type 2 diabetes being biologically interlinked, creating worsening insulin resistance. Weight loss is uniquely challenging in this group of patients, especially because there are strong biological mechanisms and some diabetes treatments which promote weight regain. And you have other barriers, systemic barriers like psychosocial, therapeutic, and health system barriers, which prevent effective long-term obesity management. So what's the solution? The solution, as I already mentioned, is a weight-centric model. So you shift to a weight-centric care model where you use therapies that will promote weight loss and adopt a long-term team-based approach. That is very, very important because this will sustain, and long-term support is very much required. And you must intervene early with modern therapies that use medications that are weight neutral, actively support weight loss, and maybe bariatric surgery wherever it may be necessary. So thank you all for a very, very patient hearing, and I would be very happy to take questions. Thank you very much.
Very much, Nita, for a very fabulous and great lecture. I never knew that subject can be so interesting.
Thank
And
you, sir.
the perplexity circles were very good. I think we have an interview with Nitin Kapoor. You know Nitin?
Yes,
So
of
he's
course,
coming
sir.
for 15 minutes. After that, we'll have question answer. He's just coming. He's there already, recorded one.
Okay,
After that, we'll
okay.
get questions. So can I
Okay,
have the Nitin Kapoor's interview? I'm interested to you to stay also along with others because I have interviewed him. So I did interview him. So he's
Sure.
Dr. Anti-Obesity Drugs. So can I have Dr. Nitin Kapoor, please? Yes, this is between Nitin, who is the professor and head of Unit 1, Department of Endocrine Diabetes at CMC Vellore, and myself. And let us start the interview. The topic for interview was the present and the future anti-obesity medications and anti-obesity interventions. Yes, please bring Nitin Kapoor. Do focus.
My dear friends who have joined last number for this 10th edition of the National Clinical Diabetes Update, I welcome all of you who have joined in thousands for this unique program today on obesity. We have with us Professor Dr. Nitin Kapoor, the professor head of the Department of Endocrinology, Metabolism, Diabetes at the CMC Vellore, and who is also an authority on diabetes. His work, both from India, from Canada, from Australia, and various other parts of the globe, have established him today as an expert, one of the most important person who has contributed maximally to the obesity research. most important obesity patient care, at the same time, very down to earth, very clinical, very practical. And today, let us listen to him on a very important aspect, the most important contemporary global challenge, that is obesity, and regarding the anti-obesity medications. May I just start by asking, Nitin, can you just give us what is the global burden or the regional burden of obesity? And today, in today's parlance, why anti-obesity drugs have become extremely important? Is it talk of the town, talk of the nation? Why it has assumed the central position as the most important contemporary challenge?
First of all, thank you so much, sir, for having me on board. It's a privilege and honor to be sharing a platform with you, sir. It's always a learning to be with you, and thank you so much for this platform and for this successful NUCD meeting for the 10th consecutive year. It's been my privilege to be part of this meeting for several years in the past as well. And answering the question that you've asked, definitely, sir, obesity has been increasing by leaps and bounds, not only globally, but also in India. More than 1 billion people today are affected globally with obesity. But the more worrisome fact here is that the prevalence is increasing rapidly. It is within the surveys that we see, within 5 years, within 10 years, the numbers are actually doubling. And that is the most worrisome part. If you look at the most recent data from the ICMR India study, which is indeed the study which has really captured nationwide data, we learn that about 20 to 30% of the Indian population has obesity today. So definitely for a disease of this magnitude, we need management strategies, and it is no big surprise that we have obesity medicines taking the center stage, and more so, though we've been trying to manage obesity with medicines for so many years. As you know, so many medicines have come and gone, but this is the first time in the hands of physicians we have powerful tools, medicines that really make big changes in short periods of time, very effective, easy to use, and hopefully even coming down in the cost in the future. So I think that's the reason why obesity is taking the center stage, sir.
Absolutely fabulous. As you rightly said, in today, the anti-obesity drugs, more than any other time, has really impacted, and their effort, prescription of those drugs has really changes the destiny of many patients. Absolutely correct. Many drugs came and went, but I think you'll be describing that. But the today's drugs are absolutely fabulous, and they have come to stay. And Nitin, in this informal talk, I may ask you, someone said that over the 5 years or many years that the drugs are in market, we do not have any serious side effects so far. We have 1 or 2 hiccups, but there is no serious side effects that these drugs have, but they have been more or less quite safe. The question next I want to ask you, what we advocate is a comprehensive obesity care. Now, how do you see the role of these anti-obesity medications in the gamut of the comprehensive obesity care? You have taught us regarding the lifestyle, you have taught us about the various facets of lifestyle which goes with this, but how does the medications impact anti-obesity management in the gamut of other aspects of lifestyle?
Absolutely, sir. I think this is a very, very important question. Though we've got these powerful tools in hand, they are the most important point that I'd really like to highlight. They are not a replacement for lifestyle change. Lifestyle change remains integral, is the first stepping point when we start managing obesity. It is an integral component. Both nutrition and physical activity coupled with behavioral therapy remains the first step. Even trials with these newer drugs today have told us that when we have good lifestyle modification, our patients lose weight, and after that, if we consider the usage of these medicines, we are going to have additional weight loss beyond the weight loss that we have with lifestyle medicine. So I would say pharmacotherapy definitely fits the comprehensive gamut, but it is not the first line. First line remains lifestyle. Lifestyle remains even during the management of usage of these medications. And it is not only the diet, the physical activity, but also the very important component of behavioral therapy, which is really important. So like we manage patients with diabetes, hypertension, like any chronic disease, I think the role of medication fits in after lifestyle in the bigger picture of management of obesity, sir.
I think that's a great direction you have given to the nation. Now, Nitin, to make the facts more concentrated, how much weight loss we expect from diet alone, and how much weight loss we expect when you start on these anti-obese medications?
Right, sir. So I would give, for example, in the obesity clinic that we run here at CMC Vellore, and a patient comes for weight loss medicine, and I tell them to follow diet and exercise. It's a multidisciplinary clinic. Our dietitian, exercise specialist, everybody would see. And if my patient really follows everything diligently, they would lose about 4 to 5% of weight, and they will come back to me in 3 to 6 months and say, "Doctor, I've lost so much weight, but I'm not losing anymore." So I would say it's 4 to 5% with lifestyle. And after that, once they've reached their metabolic set point, when they're not losing anymore, I think that's the point when we add these medications. That's when the actual weight loss of the medicines will kick in. And depending on the medicine, we may have weight loss up to 10, 15, even 20%. And with newer drugs coming up, maybe even 25%. Sir.
Great knowledge. So Nitin, to make a long story short, you will advocate and give the direction to everyone in the nation who is listening to you that to try lifestyle modification, behavioral modification first, and on that background, when the metabolic set point is there, then you start anti-obesity medications. And how long that takes for the lifestyle to get into that metabolic set point? Roughly, I mean, I can't be any number, but roughly 2 months, 3 months, or how long you wait for the lifestyle?
As you rightly, sir, it's not a fixed number, different for different patients, but on an average, 3 to 6 months, sir.
3 to 6 months. Then we started. Absolutely. Now, please tell us that drug therapy, as you rightly said, not a replacement of the lifestyle changes. Now, why we need the drugs to be continued for a long time? People say that they lose weight with the drugs, but as soon as they stop the drug, they regain that weight, and obesity itself, Nitin, you have defined as a chronic relapsing. So relapsing word is very much there. So what is this weight regain after stopping the drug, and how one can overcome it?
Absolutely, sir. So I think the answer for this question would lie in a simple comparison that when we are managing obesity, we are not running a sprint, we are running a marathon. We are keeping our energy, we are losing slow and steadily, and that is the weight loss that is going to be there for long term. Even before these medicines came, we know about so many fat diets which are available, which help lose weight, but only temporarily. Patients lose weight, and then, just because somebody else is following the diet, they try and follow this and that, but the moment they stop, they gain back. Another analogy to understand the chronicity of this: when we manage patients with diabetes, all of us have managed HbA1c of 10, 11. When we give medicines, HbA1c comes down to 7. But do we ever tell them to stop the medicine? If we do, the A1c springs back to 11. Very similar for obesity. When the weight is high, you treat it. And if it comes down, to maintain, we need to continue. And that's what's very clearly shown by step 3 study, by some Mount 3 trial. The moment we stop, weight comes back.
I think at this point, I just want to know who were the eligible population, according to you, who are fit to take these anti-obesity medications? At what point of various parameters?
Sure, sir. So I think what has really been given us as guidelines from the government, from the DCGI, based on all the clinical trials that have been done. Today in clinical practice, if I have to be legally safe to prescribe an anti-obesity medication, it should be to a patient who's got a BMI of more than 30 kilograms per meter square. But if my patient has comorbidities associated with obesity, I can start this medicine with a BMI of more than 27 kilograms per meter square. However, this is a cutoff which is based on international standards. This is a cutoff based on the clinical trials that have been done. But for many years, we know that Asian cutoffs have been lower. Our bariatric surgery cutoffs are lower than the West. And therefore, the Endocrine Society of India Clinical Practice Guidelines has given a slightly lower threshold of 25 and 27. But for now, till the evidence still mounts up in the lower BMI categories, for a simple message to all the clinicians who are listening to us: You are safe if you're prescribing these drugs to patients who have a BMI of more than 30 without comorbidities and more than 27 kilogram per meter square with at least one comorbidity.
I think very simple, and the greatest truths are simplest. You have given the simple 30 and 27, two numbers to remember, which is very important. Now, what are the main long-term anti-obesity medications currently in use?
Right, sir. So currently, US FDA had about 6 medications which are approved, but in India, we don't have many of the combinations. So if you're just speaking predominantly from an Indian clinical practice, we're looking at orlistat, which has been there for a long time, works well in some sex of patients overall. Many times the side effects make neither the patient like this drug, and the efficacy is also not so much as compared to the newer, highly effective anti-obesity medicines, but still, as a lipase inhibitor, orlistat is something that we remember. Liraglutide is available in India, but not in the dose in which obesity management is approved based on the scale trial. So what we have is up to 1.8 milligrams. What is approved for obesity is 3 milligrams. However, nevertheless, now with its loss of patent, it has been used more extensively in our patients. We don't have naltrexone bupropion as a combination. Separately, these drugs are available, but again, with the side effects, not so much in use. But the two main drugs which are now available at this point in time in India, which are powerful, newer, highly effective anti-obesity medications, is the injectable semaglutide and the injectable tirzepatide, both of them which can cause weight loss to the scale of 15 to 20%.
Good. I think that's the great message. The two new drugs which have flooded Indian market and they have taken over the older drugs, but old drugs, as you say, still used. These are the semaglutide and tirzepatide. So these are the drugs which are maximally used in our country, as you rightly said. Nitin, you had been one of the PIs of this study on the semaglutide, oral semaglutide, injectable semaglutide, also tirzepatide. Now, what is the simple message I like to give from the oral semaglutide as a weight-losing drug?
Right, sir. So oral semaglutide, what is available in the
Pioneer 7 and 8 trial, you have something which has changed the way world looks at oral semaglutide.
Absolutely, sir. So the oral semaglutide in the higher doses, which was in both the Pioneer Plus trial as well as the OSS trial, where they've used 25 and 50 milligrams of oral semaglutide. The site, we were part of the study, as you said, sir, and this particular trial did not have any placebo arm. So I knew all my patients who were getting this medicine were actually getting the actual drug.
And they tolerated it.
And they tolerated it. And that, in fact, gave me a really good confidence. That's a time when the other oral semaglutide 3, 7, and 14 was being launched in India. But when I was being able to prescribe 25 and 50 to my patients, the confidence that I got to prescribe the lower doses was great. But I think across different centers, I think there are about 10 to 12 centers in India who did this study, and all of us, saw weight loss of about 10 to 15 kgs in these patients. However, the oral semaglutide, which is now available right now at 3, 7, and 14, causes about 5% weight loss, not approved for obesity, only for diabetes. But very soon we are going to get approval for 25 and 50 milligrams to use, and then we should have a powerful oral drug as well, which will be helpful for weight loss.
Fantastic message. Now, what was the new drug that we learned in the last years, the orforglipron? I mean, which is, what do you think, that is comparable to the Rybelsus that we had, oral semaglutide we had?
Orforglipron, very effective, sir. Oral non-peptide GLP-1 efficacy of weight loss, fantastic. And I think it will be definitely a welcome, because in our clinical practice, when you prescribe these drugs, often patients don't want injection, and having an oral tablet, which is not a peptide, with the ease of taking this tablet without so many ifs, buts of water intake and all of that removed, I think it will be a big welcome. I hope the cost is not very high, and I'm sure it will be very, very helpful for our patients.
Absolutely. So I think the great message you have given, that with the oral 3, 7, 14 semaglutide, we expect up to 5% weight loss. If you want more, you have to go to other drugs and do higher doses of this drug. Now, a very simple question. Recently I was told that if you exceed that 120 ml of water, the drug becomes less effective. Is it true?
Yes, sir. So the mechanism of its action, it has to be in the gastric mucosa for that SNAC technology to work. Little extra water gives us that risk that the drug will be washed away to the small intestine, may not stay in the stomach and get attached to the gastric wall. Given that it's a really costly tablet, 300 rupees per tablet, we don't want that little extra water to take that risk of its reduction in efficacy. So
message that everybody should carry. 120 ml is 120 ml. Absolutely fabulous. Now, Nitin, beyond obesity, anti-obesity effect, what other benefits these drugs have? The ADA 2025 had given guideline for these drugs to be used first for some hyperglycemia, etc., etc. So kindly tell us, what are the other benefits beyond weight loss?
Absolutely, sir. And I think very important message in this question is we always look at the patient. We look at the bigger picture, just not getting stuck to BMI alone. We want to improve the quality of life of our patients. So by and large, if you're talking of benefits of these drugs beyond weight loss, definitely two main things that come to our mind based on data from the SELECT trial and similarly with tirzepatide and also the FLOW trial and currently ongoing renal data with tirzepatide. The two main things are cardiac protection and also protection in terms of CKD progression. Cardiac, we are talking not only of ASCVD, but we are also talking about heart failure. And both MI and heart failure are helpful, especially in those with preserved ejection fraction. But beyond CKD and heart failure, these drugs do help in reducing blood pressure. Obviously, dyslipidemia has improved. The glycemic parameters improve, HbA1c reduction. Also, some ongoing studies today are talking about reduced progression from pre-diabetes to diabetes as well. So I think the whole spectrum improves, sir.
I think it's great knowledge that you have shared with us. I mean, beyond weight loss, so many benefits: cardiac, kidney, the progression, the cessation from pre-diabetes or early diabetes to full-blown diabetes, and etc., etc. It's a great news. I just want to know from you, for such a wonderful drug, what are the concerns regarding its safety, and what are the concerns regarding its tolerability?
Right, sir. So I think this is a very important question in clinical practice. The patients often come and ask for these drugs, but what is really in their mind is also to know from the doctor which are the side effects that they should be worried about. And I think part of these side effects are actually more hype than actual. We know most commonly we see in clinical practice the GI side effects, definitely nausea, vomiting. If they overeat, definitely vomiting. And some patients experience diarrhea. But the important thing is these side effects are often well managed with medicines. If you are able to slowly titrate the medicine, don't rapidly increase. Maybe sometimes if the patient is having a lot of these side effects, go back to a smaller dose. These side effects can be mitigated. Apart from nausea, vomiting, and diarrhea, sometimes constipation happens. Definitely these patients are eating much less than before, and therefore their ability to eat is less, the fiber intake is less, and at times even water intake is less if the counseling has not been done. So I think constipation is important. But I'd like to mention, sir, two more important side effects that have to be kept in mind, though they are extremely rare. One is pancreatitis. I would again like to highlight gallstones and pancreatitis can happen with any weight loss because of severe calorie restriction, even after bariatric surgery. Because of the less intake of food, the gallbladder sludge tends to remain in the gallbladder for a longer time. Gallstones are possible, and therefore pancreatitis is also possible. So that is one. The second important component, which is related to the vision and the optic neuritis and retinopathy, I think the important message here is that those patients who have diabetes and very poorly controlled diabetes, any kind of rapid control of glucose, as that can happen with these drugs, can worsen diabetic retinopathy. And for optic neuropathy at this point, I think the data is very minimal. There are only a few handful of cases. What really helps to predict the occurrence of this complication, whether it's the cup disc ratio or whatever, with very limited data at this point, these complications are extremely rare. Handful of cases, we are not even sure whether there is a causal link which is there. I think we need more data. There is ongoing literature and studies which are looking at this specifically, and in some time we'll have more answers. But by and large, for telling all our patients, GI side effects are a rule than an exception. However, they can be managed easily. Go slow on the dose of drugs. Come back to the original dose if the patient is not tolerating higher drugs, and use supportive medications with which these side effects can be easily managed.
I think it's a great, I mean, you have given great assurance. And the other thing rightly said, do you think that we should advise while giving the drug to the patient to report back to us if they have any problem with the vision? And any trial, Sustain 6, or even the earlier Paris trial, Hivida trial, the Copenhagen trial, all have shown when the blood sugar drops suddenly, there is always a vision which goes down, retinopathy worsens, but at the end of 1 year, it should benefit. So what will you advise the patient, if at all you have to say them about it, or just to keep quiet about it?
I think the main advice is to monitor frequently before starting. You can, it's standard of care for every patient with diabetes. We should look at the fundus at least once in a year. So before giving these prescriptions, make sure that a baseline retinopathy screening has been done. If there is severe retinopathy to begin with, we monitor more frequently. I think that's what is important, so that rather than waiting for severe problems to happen, suddenly if we are monitoring, then we know whether we are going in the right direction or not. I think in clinical trials also, we've been monitoring these drugs, and at least in our side, we've not seen any problems with respect to vision, despite giving so many patients these drugs.
I think that's the key. I think monitoring is of paramount importance. You have highlighted it. It is great. Now tell me that what are the real barriers for very widespread use of this anti-obesity medication? It's a great boon for the mankind. What are the barriers?
Right, sir. So from an Indian standpoint, I think cost always rules the roost in Indian market. At this point in time, till these drugs go off patent, cost is a barrier. I often have in clinical practice many patients who really would benefit with these drugs a lot, but I am not able to prescribe this from the market. I try and put them on a clinical trial or some kind of a scheme where they are able to
I
get.
must compliment you in CMC Vellore. You look after the patients who really have nots.
Thank you, sir. So yes, so that cost, I would say, is one of the barriers. But I think another important barrier, which gives some kind of responsibility for all of us, like healthcare professionals, we have to put the right message. Now, the social media is full of so many wrong kind of misinformation, which is available, which is, unnecessary, creating fear for some of the patients to take these drugs. I think it is our responsibility to put the right message. We cannot be fighting with everybody who's giving a wrong message, but at least our responsibility to give the right message. I think that is the second barrier, which is really coming up, the misinformation which is available. And
I agree with you. That's very, very important in our country, because that is happening. For insulin, for every drug that we use, people have different opinion, and that myth must be done away with. I 100% agree with you. Now, one very important question: how these newer medications, anti-obesity drugs, compare with the bariatric surgery?
Right, sir. So often in many conferences now we hear debates between bariatric surgeons and metabolic physicians talking about how, which is better, which is not. I think the answer lies is yes, they are both very effective. Bariatric surgery has been there for a very long time. I would still say it is the king of obesity management because it is very effective. Long-term data is available. What I would say is which patient will benefit with what, how we can complement the use of both in some patients, and I think how, if a patient is having weight regain after bariatric surgery, how these drugs are effective. Sometimes before going for surgery, when the patient's weight is too high and they are not fit for surgery, how we can improve the fitness by giving these drugs. So I think the answer to your question, sir, is using them in complementary to each other is the right answer, rather than thinking one is better than the other. Both are available, and I think for which patient, which to use, when to use, would be the more important point.
Yes. I think now we're coming towards the end of the interview. I think, Nitin, we would like to know from you, what are the other newer drugs that in the pipeline? They have not yet come to Indian market, but with your wide experience, what are the drugs that are available in the pipeline, and what are the promising drugs out of this many more which are in the pipeline?
Right, sir. So a lot of drugs are there, sir. This field is exploding, but to mention a few which are really near, and I think I would say, as we already discussed about orforglipron, an oral non-peptide GLP-1RA is coming up. We talked about higher doses of semaglutide, that is coming up. Retatrutide, which is a triple agonist of glucagon, GLP and GIP, causing weight loss of about 25 kgs. Again, we've been doing those trials here in Vellore and fantastic results. Yesterday I had a patient who's lost from 75 to 53. She's so happy that, her weight is phenomenally less. But also a combination of cagrilintide with semaglutide, CagriSema, is coming up with some promising drugs. So yes, there are a lot of these medicines, both oral and subcutaneous, which are in the immediate pipeline. And obviously there are a lot of other drugs which are being currently tested in phase 2 trials. But these four, I would say, we would get in the next year or two in the market, sir.
Fantastic. I have one question to ask. One of the things that we encounter in the anti-obesity management with the newer drugs is sarcopenia. The nation wants to know from you, what is your message for managing sarcopenia, preventing muscle mass loss, and what do you suggest to the nation?
Absolutely, sir. So I can actually share some of our own data that we just submitted for publication, 50 patients follow-up with the use of these drugs, real-world study. By and large, if you look at global literature, about anybody who's losing about 10 kgs of weight with the help of these drugs, 7 kg is fat, 3 kg is muscle. This is global. This is almost similar with all kinds of these drugs. So it's not only for GLP, but GLP, GIP, all of them.
7:3. 7:3 fat and 3 is muscle mass.
What we found in our study, sir, that I'd really like to highlight, and this is an important message for clinicians who've joined us, is that we found the ratio is similar, but much more in women than in men. We found about 37% muscle loss in women, about 22% muscle loss in men. So I think when we are giving these medicines, especially in women, we have to talk about ways of mitigating muscle loss. Till we have these drugs that are available for reducing muscle loss, I think we have to talk about diet, improving the protein intake of these patients, teaching some simple resistance exercises, and that itself would really help to prevent muscle loss. We are not going to be able to avoid muscle loss, any kind of weight loss, even after bariatric surgery. There is fat loss and muscle loss. Our aim should be to preserve as much as possible. The bigger devil is that once we regain weight, we will regain only fat. We will not regain any muscle. So that's where it is important to preserve muscles.
I think, Nitin, before we close, I think I'll just need the take-homes from this great interview we had. And this type of interaction with you will continue. And just the simple messages, take-home messages that you leave our patients with, not patients, our doctors with, what they should do, do's and don'ts for in another 1.5 minutes.
Sure, sir. So I will leave with, say, about 5 messages that we've discussed. 1, obesity is a problem that is going to increase. We will have more and more patients walking into our clinics asking for medicines for weight loss. So definitely the prevalence is increasing. All of us, no matter we are a physician, we are a gynecologist, we are an orthopedician, pulmonary medicine, everybody will see obesity in their specialty based on their problem. So this is the first point.
Cutting across specialty, obesity is going to rule the roost.
Increase. And therefore all of us need to be well equipped to know how to manage patients with obesity. The second important point that I'd really like to highlight, though these newer anti-obesity medications are very effective, they are not a replacement for lifestyle. Lifestyle should start and lifestyle should continue before and after these medicines. So the third message I'd like to leave here is the important cutoff point as an indication for starting these medicines: BMI more than 30 without comorbidities, BMI more than 27 kilogram per meter square with at least one comorbidity. Fourth point, we have these newer highly effective anti-obesity medications which are available in India like tirzepatide and semaglutide. But when we prescribe these medicines, we should be able to tell our patients that this is a long-term treatment. We are running a marathon, not a sprint. If we are going to stop these medicines, weight gain will happen. And it's better to tell that to the patient initially before starting, rather than once the patient has started and then to tell. So that is the fourth message. And the last message about the side effects, again, going slow, giving good supportive care for these side effects, the GI side effects which are common, and reducing the misinformation by providing the right information to the patient about the other rare side effects. I think that is the duty of the responsible doctor, and we have to keep ourselves very updated, because this is very rapidly evolving field. We have newer medicines coming every now and then, so we have to be equipped with the latest knowledge, sir.
Nitin, on behalf of everyone that is present and listen to this interview, I will just remain silent, because in silence is the greatest respect, greatest regards, gratitude, and thanks. You've given us the cream de la cream, and I can put my hand on the heart and say this is one of the best gift that my audience, our audience, will get from this conference. Thank you.
Thank you so much, sir.
I'm speechless beyond this. Thank you. Dear friends, now I invite my very close friend, very dear Dr. Professor J.V. Kanwar to kindly take over to conduct the panel discussion. Can I have the Dr. Kanwar's introduction slide? He doesn't need an introduction. Do we have a slide for Dr. Kanwar, please? Hardik? Dr. Kanwar is the professor and head of Department of Endocrinology at the IMS and Som Hospital, a very famous hospital with 2 campuses and on the verge of expanding further in Bhubaneswar. Publications, he has published 18 articles in peer-reviewed journals, written 4 book chapters, published 12 abstracts. He has been the reviewer of several journals, including IJEM, founder secretary of the Odisha Endocrine Society, which does a meeting every year, and I have been fortunate to come, and I see one of the highest standard meeting. Co-organized secretary for the ESICON annual conference, national conference in 2018, organizing and scientific secretary for the ESICON 2016 and 2022. JB, as we popularly
Good evening, sir.
call him,
Good evening,
he's
sir.
one of the
Namaste to
MD
all
PMs
of you.
of the country, of our state's pride. JB, on behalf of all of us, welcome you and head over the session to, you joined quite early. I was seeing an interview you could have enjoyed, but you joined early, and
Thank
very
you,
much.
sir.
Please carry on.
Very good evening to all of you. I enjoyed the interview with Dr. Nitin Kapoor very well, and almost every aspect has been discussed. I think many of the panel members are not available. I think Ashok sir is the greatest panel member to us. So we'll try to ask many of the questions to Ashok sir, as well as Dr. Alok Kanungo is also available with us. So after the discussion with the interview with Professor Ashok Das with Dr. Nitin Kapoor, so many of the doubts have been cleared. So I would start today's panel discussion with few of the practical questions. Sir, we do understand, we have seen from the Surmount 4 trial that those who stopped, this is the practical question normally being displayed every day in our TV. If you stop the medication, you are going to regain weight. But what we have seen in the studies from the Surmount 4 and Step 4, Surmount 4 with Munjaro and the Step 4 with 2.4 milligram semaglutide, we have seen that those who continued this medication, they continue to have weight loss. From 20%, they have gone to 26% even. And those who have stopped in the placebo group, they have regained weight. But distinctly, if you can see that even after 1 year, almost 52 weeks of stopping the therapy, still in Surmount 4 study shows that there is still the 10% weight loss is still there. The 10% weight loss benefit is still there. It's a good benefit. So obviously the patients were on lifestyle measurement,
But the primary question of people regaining weight, that's the normal TV discussion nowadays. People are regaining weight after stopping it. So these surmount 4 and the stay 4, they have answer even for about 52 weeks. The weight regain is not up to almost not reaching to the baseline. So, is there any possibility? My question to Ashok sir is there any possibility you continue to take this medication for about 2 years duration of time, then you stop for maybe for 3 to 4 months, 6 months, is gain slightly you may regain weight, then you can start this treatment and till continue the lifestyle measurement. We do understand it's very easy to state the first line of treatment is lifestyle management, but it's difficult to continue lifestyle management throughout the life. You can continue anti-diabetic, anti-hypertensive, anti-obesity throughout the life, but it's absolutely difficult to continue the lifestyle management. Hardly, I think, only 2% people would be able to continue the
I
lifestyle.
think, JB, you have asked, you have hit the nail on the head, in the sense that is one of the most important question to ask. Now, to make a long story short, being the endocrinologist of repute, you know that the set point theory has been challenged. People say we have a body set point for weight that is fixed by the adipose tissue, and even if we lose, the adipose tissue wants to get back to the normal, to get back to the set point. But this has been challenged. That is the first answer. The second answer, as you rightly said, if we stop the drug after 1 year, there is a regain. At least 10% remains weight loss. But in some patients, 30% weight loss still remains. Some patients, but 10% is very common, 20% is quite common, but 30% some people maintain. I fully agree with you that for a disease like diabetes and hypertension, to say to continue anti-diabetic drugs, anti-hypertensive drugs is very easy, doable. But to tell a person of obesity chronic disease, should take on taking these drugs is very difficult to convince him. Economically, socially, not possible. I fully agree with you. But the observations that have been made, that if you have three things, I know I'm telling you the answer, JB, that if you give injectables and you want to stop it and give a gap and give the oral, I am told that some people have done this and they have found the regaining of the weight is less than not giving anything. So they have given Manjaro or Retatrutide, they have given oral Rybelsus after a gap of 6 weeks, and they have shown that there was no pancreatitis, no side effect. The weight gain has become lesser than when they're left alone. Third thing, the very beautiful point was ingrained in your talk, that if you maintain the lifestyle, mainly three things, the physical activities for the cardio. I have made it very simple. I tell patients physical activity for cardiovascular fitness. To weight loss, it is diet. Am I correct, JB? Diet,
Yes,
weight
sir.
loss is most important.
Absolutely. And behavioral therapy. So three
If you
things.
adhere to your diet that you are taking, that you avoid obesogenic diet, then you do not gain back the weight. So one of the secrets that I usually tell my patients, you may not take the drug lifelong, but please adhere to the diet that you are taking. Final thing is that, there are some people whose thermostat, obesostat is placed which you cannot touch. But majority of the patients, I find that if you give this drug and stop, you are absolutely correct. Weight gain, regain will occur 10%. If you are careful, maybe 70% will be lost. 30% weight loss will still be there. But by these tricks of giving oral and giving
Hello, sir.
Are they continuing drugs? He said, no, I'm not continuing drugs. I did it for 2 years, and today I'm just on the diet and oral drugs. So that's what I'm telling you that I have some experience but that's where it remains. But also, JB, in spite of time interest, I'll tell you that we know the benefit of 2.5 kg weight loss on the blood pressure. We know am I correct? We know the weight loss of 2.5 kg on the cardiac function. So if you are losing about 15% and gaining back about 10% or 12%, then also the benefit remains.
Sir, this is the right platform. I think you have to clear the doubts. We already have asked the question to Dr. Nitin Kapoor regarding the negative advertisement regarding these anti-neuro, anti-obesity medications. I have recently heard this Oxford study says whatever weight you have lost, you will gain in 1.5 years after stopping the medications. And whatever the metabolic benefit, whatever the metabolic benefit of reduction in the systemic blood pressure, reduction in the fat mass would be regained with the normal, come to the normal baseline in 1.5 years. And some Australian study shows that it has effect on the mental aspects and also on the contraception. So there are multiple effects. And the most important thing is the study also negatively also saying that the weight regain after stopping this medication is 4 times higher than the weight reduction you do with the diet and lifestyle. So weight regaining is 4 times higher in the way on the anti-obesity medication as compared to the lifestyle therapy or diet, exercise, or behavioral
Yeah,
therapy.
I think weight regain, if you stop lifestyle, is there, but minimal. I fully agree with you. But the weight loss during the drugs and stopping the drugs is much more. But there is a set point. Number two is that even bariatric surgery, the weight loss is more stable than the tablets. But in today's world, the bariatric surgery is widely practiced, no doubt. Recently met Mohendra Narkuria, the president of he has got 8 hospitals doing that. He has put this obesity body composition machines in the airports. People can do it and go to his clinic. But you see, still, bariatric surgery has not become very popular because of the complication 1 to 1.5%. But the nesidioblastosis, the fatigue, and there also the weight gain occurs may not be this much. Now, I just want to ask one question to Nitin. Nitin is here. He said he will join. Nita, are you here?
Yes, sir, I'm here.
Nita has come back. Nita, my questions to you, that you said that the response of all the anti-obesity drugs with diabetes is less.
Yes, sir.
But I also want to tell you that the benefits also are equally more. JB, I agree with that. Sometimes we say that for diabetic should get cabbage or not, diabetic should get beta blocker or not, aspirin or not, smoking cessation or not. But all these things are much more beneficial in diabetic than non-diabetic. Agree with that?
Yeah, but the thing is that in all the trials across that have been seen, they have seen that whether you take tirzepatide, whether you take semaglutide, you find that the response is several percentage points lower in type 2 diabetes patients as compared to non-type 2 diabetes patients. And this has been well documented. So some of the reasons which I have put forth in my talk are maybe related to inflammation, maybe related to the different kind of adiposopathy. We don't know, but for sure that the benefits are less.
Yeah,
Good.
I do
Very
agree with
normal. The benefits compared to non-diabetics are more. Maybe one
Correct.
thing which Nita, in a
sir, I have got
inevitable
one.
style, mentioned that in females, when you give anti-obesity drug, the effect is less. She said that compared to the males. I think somewhere that. But you give the medication for sugar control.
We
Did
we
you say
do.
that if you give it sugar control, it is if you give the anti-obesity drugs not for obesity alone, but for blood glucose also.
Of course, of course. The only thing is that we have very effective drugs for diabetes outside of GLP-1 receptor agonist, which we would give, otherwise also. Of course, the one place where I would give these drugs, even if the weight loss benefit is not there, is where there is a very high cardiovascular risk. So today we know that regardless of the HbA1c, regardless of the weight, these patients benefit from GLP-1 receptor agonist for prevention of cardiovascular disease, or a person who's already had it, it's going to prevent a second episode. So these are the patients, yes, I would use it if the cardiovascular risk is high. But otherwise, just for glycemic control, at least at this point of time, I think it's too expensive to use in the Indian scenario.
Yeah, I think I fully agree with you. Even though 882025 guidelines
Yeah.
said you can use,
Yeah.
does
Yes.
not say you must use.
Yeah, I have got a question for Dr. Deshpande. In your clinical practice, so while treating the patient with obese and type 2 diabetes, and having the diabetes is well controlled with the treatment, whatever medication you are using, and for obesity, when you ask for these newer GLP-1 or GIP agonist, how do they accept? How many of them do accept, and how difficult do you find to prescribe once the blood sugar is well controlled, only to reduce the body weight? Are they convinced with your
They do, yeah, they do get convinced, and nowadays people have become very aware. They actually come to us for weight loss solutions. So they want weight loss because they know that weight loss can reduce their other medications for diabetes. So there are those. But then if you try to convince, say I have a patient of BMI 35 who's well controlled on all other medication, but has other mechanical effects of obesity, for example, sleep apnea, or the person has osteoarthritis of the knees, then of course you need to get the weight down, and this has to be explained to the patient. At the end of the day, I find that it's all about counseling. How you do the counseling and how you can convince the patient. You will have to show some trial data in a different way and tell the patient that these are the benefits for you if you use this drug, regardless of your HbA1c being under control. Even if that is 6.5, but the BMI is 35, it still warrants the usage of anti-obesity medication, in my opinion. And we do convince the patient.
Correct. If you look at, if you are practicing at Mumbai, so many
No.
of your patients.
I'm in Belgaum, in a tier 3 city.
Okay, then how many of your patients, of your patients may not be able to afford for that?
Yeah,
And,
not many can afford, but there are a few who can afford it. And we, of course, see, we don't underestimate the patient's economic status, actually. We ask. It's my policy to always offer. Let the refusal come from the patient. No assumptions here. So always, whether it is for reversal of diabetes, whether it is for anti-obesity medications, I always offer.
so many of the times, the practical scenario where the people stop these medications, newer anti-obesity medication, is two reasons: because of the cost and the side effects. I think the way you treat, maybe side effect may be gradually reduced by escalating the dose, but cost that has to be managed by the patient.
Yes.
So now the so many companies are coming with the combinations of GLP and GIP-1, even the semaglutide, various companies are coming, and you expect the cost to go down maybe in a year or 2 years' time. How do you expect in near future? Maybe this primary, I think barrier nowadays, other than the side effect, is the cost in the
Yeah.
Indian setup. So how do you think how the clinical practice would change after maybe 1.5 years or 2 years, when it will be
It
much
will change. Yeah.
economic?
It will change, just like diabetes practice changed from the usage of sulfonylureas primarily to DPP-4 and SGLT today. Even they were expensive in the beginning. The same way, the treatment for diabetes with obesity is also, I feel, expected to go through a sweeping change because of the availability of cheaper options. So liraglutide, though it is underused, is a cheaper option already available to us. But it's a daily injection, so acceptability may be poor. But with the coming of once weekly injections at lower rates and giving better results, I'm sure things are going to change a lot. If 8 out of 10 patients...
Many of the patients...
Yeah. Yes, sir.
Yes, sir. What I was referring to, Nitya, that no, the LL people now in their talks, they want us to give, they must have approached you the real world evidence of how the other benefits of weight loss. And there I presented, and Gopal, Jayashree Gopal also was there. We presented data together of 10 patients.
Okay.
No, they were pleasantly surprised that when they took the anti-obesity drugs, their diabetes got controlled. But we know
Of
this,
course.
but they got surprised.
Yeah.
So I think that it was not a question of acceptance. We achieve it. The blood
Yeah.
glucose control is achieved when you, if they have hyperglycemia, it's achieved. Now,
True.
JB, what is other things that I would like to know? That there are two things. Now, sarcopenia is probably being covered, by being addressed, and we don't may not be fully, but next session also Alok is going to discuss with Bridge regarding the dietary benefits which can definitely address sarcopenia, and also the whatever exercise test, resistance, whatever. But there are three basic principles of living, Nita. We live for three things, and one of the things we live for is food. They say food, wealth, and sex. This is from Gita, Bhagavad Gita. That the three strongest attractions, JB, for human beings. My teacher is here, Professor Tripathi, my teacher is here. Food, wealth, and sex are the strongest attractions of human ego. Now, when this drug is taking away hedonic pleasure of eating, JB, any comments on that?
Sir, there are two aspects, sir. So, the hedonic pleasure being spreaded over the different spectrum of the ages of patient's life. So, if it is achieving if somebody is having in the early age, maybe in the school age, when a younger age, younger person, like you see
We can,
many
we
of
can
the
only
people
use
in
above 18.
school
Or
and
let us take, say, 40,
elementary places,
35,
they're
40.
all obese because of this hedonic having the high calorie diet. So that's become a problematic thing. I think at the extreme part of your age, maybe after
Yeah,
50,
old age, it
60
doesn't
years,
matter.
you enjoy your life.
Correct.
That's another part of your life. So sometimes you have to be liberal, sometimes you have to be strict about this hedonic pleasure.
Nita, what is your take on the hedonic pleasure of eating?
Yes, sir. My view is
Nita's BMI was 13 before these drugs.
yeah.
Now
I
it
never
is
took drugs, sir.
12.9. Yes, Nita, tell me what is your
Yeah.
take on this hedonic pleasure of
My
eating
take
going
on
away?
this is that
Of course,
let's
JB
get
said
the
good answer. It is if
yeah.
it is going on early in life, it is a deterrent. If it is
Yeah.
going on middle life or less, people want to eat less, they cannot. Now
Yeah.
this gives through hypothalamus. JB, you rightly said it gives them the clue to reduce the diet. What is
Yeah.
Nita's take on
So
this?
I have two takes on this. Number one is that it is the hedonic pleasure which ultimately has led to obesity in the first place. All right. So that the patient has to understand. Second, what I feel is it is very close to what Dr. Kamar said. It is the race between hedonic pleasure and longevity. You have to ask the patient to choose. So I am pretty sure that a patient will think hard, especially as he said, if they are post 50 years old, they are going to think of longevity more than the hedonic pleasure. So having said that, the hedonic pleasure is not entirely taken away by the GLP-1 receptor agonist. Once you reach a steady, once you reach a steady state,
And it is reversible.
it does not happen.
Reversible. Yeah.
So all in all, it is health and longevity versus hedonic pleasure, and that's always been, the forbidden fruit is always more attractive.
You cannot argue with Nita. Nita knows the first question Nachiketa asked Jama, that how can I live long? Jama laughed. Jama said, you after your birth, the date is important. I mean, the only truth after birth that you will die one day. Why do you want to become immortal? There the Nachiketa answers that from the very beginning of the civilization, the man's aspiration has been to live long. I think that's universal. Nita,
That's universal.
I compliment
Absolutely.
you. I compliment you. I compliment you. There's one
With
question,
permission,
ask you question to ask.
with permission from Professor
Yeah,
Das,
yes.
can
Alok,
I
please.
ask Nita one question and to JB also?
Sure,
Yes.
sir.
Do you find lot of people on GLP-1 either reception, no, GLP-1 oral or injectable are dropping out, and we don't know that, we don't track them. Some are still taking Rybelsus for last 2.5 years, and some have stopped after 4 months without coming to us. They have rejected us and rejected the tablet. So, what is your takeaway? How do you counter this? Because not only money that affects the continuity of the drug, it is the side effect that stops it. So,
let us
please
listen
tell
first
something
from
on that.
JB.
Yeah.
JB, does it happen in your practice?
Yes, absolutely. I agree with Alok sir. So I think data says about 40 to 50% people drop taking medications. And my view is those who have started the medication, they know they can afford this medication. So the cost is not a factor for stopping the medication as been shown in the various articles, we being costlier.
It is not cost. I
We,
also
we
agree.
always, we being a clinical practitioner, we always assess the patient's capability whether we can afford for a long term or not. Then only we decide. Hardly, I think 2 to 3% of the cases being given patient having difficulty in purchasing those medications. And the primary reason why it is being stopped, I think, is the natural weight loss with these medications are initially in the first 6 to 1 year of time, and they are very excited at that time when they start losing about 5 kgs 10 kgs weight loss, and after that they think there will be further weight loss, and it actually plateaus after that. And that is the time the hormonal changes occurring, the ghrelin coming in the picture, gradually overcoming the good effect of the medications. So their appetite is also increasing. So they are not able to maintain the weight. Then they find it is useless to continue such a costly medications and not further losing the weight. I think that is the primary reason where they are stopping it.
Yeah, I have a little different take on that. And my take is that I never start anti-obesity medications unless they have enrolled for a 6-month program at least, or for a 1-year program. I never give anti-obesity medications as one consultation to another. Never. I refuse to do that. There are patients who ask for it, but I don't do it. So they're always part of a particular program. The reason they're part of a particular program is then we track their side effects, we track their problems, whether it is cost, whether it is side effects, or whether it is anything else. We are continuously in touch with them. Where the plateauing is concerned, many a times there are ways to break that plateau when a person is on GLP-1 receptor agonist. And the way to do this is slightly reduce the dose, give a break of 1 or 2 weeks, because the saturated receptors, then they can again become receptive. So you find that somebody who is at 10 milligrams of, say, tirzepatide, if you give a break of 1 or 2 weeks, or if you actually reduce the dose and then restart, what you find is that they respond even better. So there are various ways to break that. But having said that, I never allow my patients to break or just stop just like that, because they've already signed up for a 6-month to 1-year program. And that's always the case. And we track their side effects. We help them with their side effects. We reduce their dose. If someone really doesn't want it, we do a gradual wean off. We always tell them right in the beginning, don't suddenly stop. You will have a rebound weight gain. If you really want to stop, we'll help you to stop it. And then we slowly do a wean off and institute something else instead to make it better for them.
Nita, how many of your patients, are having gastritis? Nita?
A lot of them.
Have you done endoscopy in them?
No, I haven't.
Please do it. Please do it. In some of the cases.
Okay.
Where there is excessive weight loss, facial color has changed, and symptom of lack of appetite is there, please see it and make a series of 20-30. This is my personal request as a clinician.
What do we expect to see, sir?
You do it. You'll see what you see. I'm not giving a bias.
Okay,
I'm not giving you a bias. Please do it.
Okay, sir.
Dear friends, we have got 2 sessions more back to back, and we are in correct time now, 5:35, and it's my great pleasure and honor to thank JB JB, we're really delighted that you could join, even for a small time. Next time you have to join for the whole program. And thank you very much for joining. Nita, I'm very much thankful to you. You came, you have to go back for a sports event.
Yes, sir. I'm
You came
participating
back.
actually, so I
But
have
in
to
a,
rush.
in a, in a, in
I'm
a lighter
actually in
vein,
the
these young
auditorium.
girls like Nita and Richa from Ahmedabad, I've seen, you know, they have a robust anti-obesity program. I don't know how many you have. Richa has got 6 or 7 girls who counsel them on the day they come. So I think obesity practice has to change. It's not one time giving drug.
Yeah.
It's a time, and you know, I think you might have heard that we are on the verge of advising Government of India to establish few metabolic clinics. In the metabolic clinic, one of the objective will be, one of the objective, not the objective, will be regarding the body composition analysis, which government will support, and also the anti-obesity medication. So let us see what's going to happen. So with this note, with permission of JB and Nita, we'll stop the session and pass on to the next.
Thank you, sir.
Thank you very much, Nita, for joining. JB, thank you very, very much.
Thank you, sir.
Extremely thankful to you. And I hold you in very high esteem, JB.
Sir.
Thank you.
Thank you.
So now over to the organizers to put the next session.
Our next session is on nutrition management in diabetes.
It will be late.
Dr. Paningrai is there.
Dr. Alok, you know, long back, I heard Dr. Alok on a radio talk, and it was on the topic of the nutrition. So whenever nutrition comes, I always request Alok to take over. It was a fabulous lecture, and you know, so dear friends, I invite Dr. Alok to kindly come and take over the session.
Yes. I invite Dr. Bharat Paningrai sir, former Director and HOD Medicine and Critical Care, Capital Hospital, Government of Odisha, an academician and astute clinician, Dr. Bharat Paningrai sir.
But his photograph looks different. He's not looking like Bharat.
No, he's
looking. No.
Dr. Paningrai is
old
there.
Photograph. Anyway, I know Bharat well, and he looks different. Now I'm joking. Let's continue.
Is he there? Bharat sir?
Bharat is there. Bharat? Stuti, is Bharat there? If Bharat is not there, Alok, you can kindly invite the next speaker.
I'll invite our first speaker, because the challenge is nutritional management in diabetes. It is not day-to-day dietary practice, but it is the challenges in when the patient goes into renal failure, he has GI and liver disorder, he has MSLD, all those typical conditions where we find the clinician and even dietitians are facing problems. So we have requested one of the famous gastroenterologists of the city, Dr. Pratap Behera, who is excellent in his clinical acumen and technology, to discuss on nutritional management in liver and GI disorder. Dr. Behera, please. Please project this recording. You will join the panel. Stuti?
Yeah, they're putting it. Alok, they're putting it. So, Professor Pratap Behera's talk. Yes.
Good evening, and I welcome to this session of nutritional management of liver and GI disorder. At the outset, I thank Dr. Kanungo for giving this opportunity to give a lecture on nutritional management of liver and GI disorders. So, the GI tract is primarily responsible for acquiring and digesting, absorbing nutrients and water, and expelling waste from the body as feces. A proper diet and normally functioning GI tract are integral for the delivery of nutrients, prevention of nutrient deficiencies, malnutrition, repair of damaged intestinal epithelium, restoration of normal luminal bacterial populations, promotion of normal GI motility, and maintenance of normal immune functions. The amount of food, its form, the frequency of feeding, and composition of diet each have important effects on GI function and may be used to help ameliorate the signs of GI disease. GI tract are often associated with nutritional deficiencies. The complications range from digestive problems to nutrient absorption disorders. which necessitate an adequate nutritional therapy in order to support the medical treatment. Liver is the main metabolic organ of the human organism because of its multiple functions. In addition to that, important body functions, body proteins and lipids are metabolized and synthesized in liver cells. Next to these metabolic pathways, the liver has an exocrine function by secretion of bile acids, detoxification of ammonia by urea production and glutamine synthesis. Another important organ which can develop inflammatory process is the pancreas. This organ plays a central role in digestion of its exocrine and exocrine functions. The total of 98% of pancreatic tissue is a part of the exocrine function, whereby pancreatic enzymes are secreted for food digestion. The endocrine part is located in the Langerhans cells, secreting insulin and glucagon for regulations of glucose homeostasis. Acute pancreatitis is a severe disease causing self-digestion of the pancreas due to prematurely activated digestive enzymes. The largest digestive organ in the intestine, which regulates the absorption of nutrients, is the GI tract. The important diseases of the intestine are Crohn's disease and ulcerative colitis. In Crohn's disease, the small large bowel as well as the mouth, esophagus, stomach and anus is involved, and the typical ulceration that occur discontinuously. But in ulcerative colitis, the colon and rectum are usually involved, causing diffuse. There are multiple differences between these two diseases, and they also share some similar symptoms such as abdominal pain, diarrhea and malnutrition. Nutritional care is clearly important in the treatment of patients with IBD, pancreas and liver diseases. Nutritional management includes prevention and treatment of malnutrition, micronutrient deficiencies as well as specific recommendations for each condition. Nutritional treatment, that is clinical nutrition, is a medical procedure involving the assessment of patient's nutritional status and needs, administration and adequate supply of energy, protein, electrolytes, vitamins, trace elements and water by enteral, parenteral and oral feeding while monitoring the clinical status. It is an integral part of the treatment process. Indications for nutritional treatment are current malnutrition or expected inability to incorporate a full oral diet for more than 7 days. The incidence of malnutrition is high in patients with advanced gastrointestinal diseases. Malnutrition increases the risk of complications, worsen prognosis, while proper nutrition mitigates these risks. Disease-related malnutrition is exacerbated in hospitalized individuals, has a significant negative impact on patient outcomes, hospitalization time, and treatment cost. Unfortunately, nutritional status is often not assessed in outpatients, and the inclusion of nutritional treatment is in comprehensive gastroenterology treatment is rare. So, liver is the major organ involved in maintaining appropriate nutritional status. The role includes metabolism of carbohydrate, fat, which are essential sources of nutrition. Major functions include digestion, absorption, storage, synthesis, metabolism of macro and micronutrients. Malnutrition and sarcopenia are common in patients with chronic liver disease that is associated with increased risk of decompensation, infection, hepatic encephalopathy and ascites. Patients who suffer from CLD often experience debilitating and severe malnutrition that both reflects the severity of the disease, thereby disease prognosis. Assessment of nutritional status and management of malnutrition are therefore essential to improve outcome. The permanent functional deficits in cirrhosis result in nutritional deficiency with systemic impacts, which coupled with several mechanisms by which these nutrient deficiencies are realized. Approaches to management and support are increasing complicated. So advance in both assessment and management of patients with liver disease, the provision of appropriate nutritional support for these patients is frequently lacking. Except for elimination diet indicated for some hereditary and metabolic diseases that affect the liver, the general nutrition recommendations for most cases of compensated liver disease are analogous to the customary recommendations for balanced diet. So there are diagnostic and therapeutic issues that link outcome of liver nutrition. So there are two things: hepatic assessment and management, and the nutritional assessment and management. So in hepatic assessment, there is anorexia, malabsorption, decreased protein synthesis and glycogen stores, increased protein degradation, free fatty acid fasting mobilization, glucose intolerance and insulin resistance. In nutritional assessment, there is we see sarcopenia, loss of adipose tissue, immune dysfunction, decreased Fisher ratio, hypoalbuminemia, hyperammonemia. So coming to the etiology and pathophysiology of CLD, so I will be touching briefly on etiology and pathogenesis. There are multiple factors contribute to malnutrition in CLD, including anorexia, ineffective digestion and absorption, iatrogenic measures and impaired metabolism. Many patients with CLD experience reduced food intake often due to hepatic encephalopathy, digestive symptoms such as anorexia, nausea, and early satiety. These issues may be linked to micronutrient deficiency like zinc and magnesium, which causes lost taste alterations, and also conditions like gastroparesis, ascites, elevated leptin levels. So overly restrictive diets, particularly those limiting sodium, along with frequent paracentesis and medications such as diuretics and lactulose, can further contribute to nutritional deficiencies. Alcohol consumption also suppresses appetite. Cirrhotic patients frequently have impaired digestion and absorption associated with portal hypertension. Conditions alter intestinal mucosa, increasing permeability, leading to protein loss, which can also occur due to bleeding from ulcers and varices. So, additionally, lack of bile acids, especially in cholestatic diseases, and severe insufficiency often seen in alcoholic diseases of pancreatic function can result in steatorrhea and defective reabsorption of certain nutrients. Intestinal dysmotility and bacterial overgrowth may further exacerbate these digestive and absorptive impairments. In CLD, there occurs a decrease in branch chain amino acids and aromatic amino acids ratio as observed in sepsis and major trauma. During overnight fast, ketogenesis, gluconeogenesis are increased. Lipids represent 75% of the calories expended during this period, causing an increased amino acid consumption by the muscles. The pancreatic dysfunction, increased lipolysis, fatty acid oxidation, and ketogenesis, reduction of plasma triglycerides, phospholipids, cholesterol, lipoproteins, and polyunsaturated fatty acids. This decrease in proportion to the severity of the liver disease and degree of malnutrition and is associated with decreased survival and is considered an independent predictor of mortality in alcoholic cirrhosis. Micronutrient deficiency are prevalent as well. Deficiency of water-soluble vitamins like B group vitamins common in cirrhosis, particularly in alcoholic diseases. Deficiency of fat-soluble vitamins have been reported in alcoholic disease in presence of steatorrhea associated with cholestasis and bile salt deficiency. These are the main micronutrient deficits like thiamine, vitamin B12, folic acid, and the causes are decreased intake, absorption, alcohol intake, and like retinol, vitamin K, and vitamin D. All these are micronutrient deficiency in chronic liver disease. Also zinc, selenium, and magnesium. So most of the cases, the cause is decreased intake and decreased absorption along with treatment with diuretics and other medicines. So nutrient assessment, how you will do? The assessment in malnutrition cases is challenging, but in early stages of cirrhosis, there is no consensus about the best method of quantification and classification of malnutrition. And the data record is simple tool and probably the best method available to recognize all data related to food intake. The subjective global assessment scale, which includes elements of the clinical history and physical examination, weight, food intake, GI symptoms, functional capacity, nutritional requirements, metabolic requirements, and physical examination is validated for the assessment of nutritional status in cirrhotic patients and provide prognostic information. So the underlying cause of malnutrition in patients with CLD and cirrhosis is multifactorial. Low dietary intake is commonly found among cirrhotic patients. Liver also contributes to spontaneous production of cytokines that reduce the hypothalamic mediated drive for appetite. The addition to low dietary intake, alteration in the pattern of fuel consumption in the body, there is higher rate of fat oxidation in the fasting state of CLD patients. Malabsorption is also an important factor in CLD. Liver disease that leads to decline in the bile salt pool can contribute to malabsorption. This is commonly found in patients who suffer from comorbid biliary and pancreatic diseases, which is often there is a decrease in fat and fat-soluble vitamins. The extent of malabsorption in CLD patients without related cholestatic disease is currently a topic of controversy. So how you assess sarcopenia? There are three things. There is muscle mass, muscle strength, and physical ability. Method of assessment: DEXA, BIA, CT-SMI index, measure total muscle mass at the level of L3 divided by height square, and there are defined cutoff values for men and women also. The reported dietary intake, a detailed assessment of dietary intake is suggested, which include food, fluid, supplement, number of meals, and interval between meals, breakfast and late night meals, calorie, quality and quantity of the protein intake. So this is reported dietary intake. So nutritional assessment, physical examination, and serum markers are essential. So medical history is important. Asking about the eating habits, the daily food intake, 24 hours recall helps possible cause of malnutrition. So reviewing recent weight loss is also crucial. Deficiencies in nutrition can also show up as specific physical signs like pale skin in iron deficiency, skin problems from lack of vitamin A, easy bruising from lack of vitamin K and C. Nutritional assessment, physical examination, and serum markers. So based on these findings, there are grade A, grade B, and grade C malnutrition. The examination also checks muscle loss, swelling, edema, fluid in the abdomen, ascites, and fat loss. So in addition to the appropriate history, physical, and there are various laboratory markers that help evaluate the nutritional status. So these laboratory markers like key plasma proteins include albumin, pre-albumin, and sometimes transferrin, which are measured during biochemical test. The pre-albumin transferrin, a liver-produced protein, is considered a reliable indicator of overall body protein status. The malnourished patients' albumin levels may remain normal even when severe protein calorie malnutrition is present. So coming to the anthropometry, the mainstay of nutritional assessment is history, physical examination, and biochemical investigation. Patients with a more complicated picture of malnutrition can undergo anthropometric ancillary test for better characterization of their nutritional status. So one of the best simplest method of anthropometric assessment is BMI. BMI evaluates patient weight and height to determine if they are underweight, normal, or overweight. And the next common thing is obesity and cirrhosis. So obesity and NAS-related cirrhosis, attention should be paid to obesity in patients with cirrhosis. Obesity does not rule out malnutrition. The combination of loss of skeletal muscle and gain of adipose tissue is termed sarcopenic obesity and is observed in significant number of patients with cirrhosis. Post-transplant obesity and metabolic syndrome are common, and weight gain after transplantation is considered to be primarily due to an increase in the adipose tissue. So BMI less than 18.5 kg per meter square in overt malnutrition, and these are high risk malnutrition. BMI more than 40, less than 18, and child C disease. So the obesity in cirrhosis, post-transplant obesity and metabolic syndrome are common, and weight reduction of 5 to 10% is typically sufficient for obese individuals with cirrhosis and can be achieved through moderate calorie restriction while ensuring adequate protein intake and exercise based on patient's capabilities. Energy and protein requirements in cirrhosis. Accelerated starvation is aggravated by reduced dietary intake due to variety including dysphagia, anorexia of chronic disease, salt-restricted food that is not portal hypertension that contributes to impaired gut motility. Additional factors that result in decreased dietary intake include inappropriate dietary protein restriction, hospitalization with periods of fasting for diagnostic and therapeutic procedures, encephalopathy, and GI bleed. So this is a flow chart showing advanced liver disease cirrhosis, how you proceed for nutritional management. So calculate the child score. If this is child C, then he is high risk, underweight high risk, less than 18.5 kg per meter square, they are all high risk. And child A and B, so assess further whether fluid retention is there or not. So nutritional assessment and lifestyle intervention is required if more than BMI more than 30 kg per meter square, and accordingly the sarcopenia, malnutrition, and no malnutrition status, looking at those figures, the nutritional assessment and the further management is done. For assessing sarcopenia, the consider CT scan to measure muscle area at L3, consider DEXA or BIA if no fluid restriction. So these are the all short practical dietary advice for bedside and outpatient clinical use. So again, another important topic is non-alcoholic fatty liver disease, or now the nomenclature has changed it to metabolism associated steatotic liver disease, so MASLD. So this is also important factor which contributes to cirrhosis. So non-alcoholic fatty liver disease is a liver disease closely linked to dietary habits characterized by excessive fat accumulation within the hepatocytes. So key pathological features of NAFLD include insulin resistance, hyperinsulinemia, elevated plasma-free fatty acids, hepatic fat deposition, hepatocyte injury, liver inflammation, and so nutrition for NAFLD. Currently, there is no approved medication for the NAFLD. One reason is that underlying mechanisms are still not fully understood. So excessive calorie intake is the main cause, and most patients are overweight or obese. Weight loss is considered the most effective treatment. Intensive lifestyle changes, including diet and physical activity, are well studied and recommended. So clinical guidelines suggest 7 to 10% of body weight loss will improve the liver fat and levels, while more than 10% weight loss is needed to improve fibrosis. Lifestyle modification should always be the first line treatment. Diet composition plays an important role in liver fat accumulation. Low carbohydrate diet can add weight loss. Long-term use has been linked to muscle development in animal studies. So therefore, antioxidants such as vitamin C and polyphenols, that is resveratrol, curcumin, quercetin, anthocyanins, green tea extracts may offer benefits. And animal studies show carotenoids like beta cryptoxanthin and astaxanthin can prevent and reverse NAS by modulating immune cell activity. Soy protein, fish oil rich in omega-3 fatty acids also show promise in reducing harmful liver changes. So the Mediterranean diet rich in antioxidant, fiber, healthy fats, low in simple sugars appears to be the most effective dietary approach for NAFLD management. Studies indicated that Mediterranean diet low in carbohydrates mobilize more liver fat compared to low fat diet with similar weight loss. So there are other conditions like alcoholic steatohepatitis and acute liver failure. Nutritional management also somewhat similar to cirrhosis of liver. So only in acute liver failure, intensive critical care management should be there. To nutrition of alcoholic, to prevent this, fasting should be avoided. In patients with severe liver disease, must fast for more than 12 hours. They should receive intravenous glucose. The fasting periods longer than 72 hours TPN may be necessary. At home, patients should minimize starvation periods by eating 3 to 5 meals daily, including a late evening snack. One major complication of advanced liver disease is hepatic encephalopathy, which affects brain function and can range from mild impairment to coma. In these cases, protein restriction is no longer recommended as it worsens muscle breakdown and malnutrition. Instead, patients with advanced cirrhosis may benefit from branched chain amino acids 0.25 gram per kg body weight to improve survival and quality of life. So this is the recommendation in liver disease and alcoholic hepatitis, liver cirrhosis, 35 to 40 kilocalorie body weight and 1.2 to 1.5 gram protein per kg body weight. Avoid periods of starvation. Encephalopathy protein restriction is not required. 0.25 branched chain amino acid per kg body weight. For alcoholic steatohepatitis and liver cirrhosis, acute liver failure analog to critically ill patients, and for NAFLD, 7% to 10% weight loss. So the other important disease is pancreatic disease. There are two things. One is acute pancreatitis and the other one is chronic pancreatitis. So symptoms and signs vary. Accordingly, the nutritional status and the malabsorption status also varies. Coming to the nutrition of pancreatitis, the severity of pancreatic inflammation determines the nutritional approach. Patients with mild and moderately severe pancreatitis usually do not require special nutritional interventions. However, all patients with acute pancreatitis should be screened for malnutrition. And contrary to the older practices, fasting after an episode of pancreatitis does not improve recovery or prognosis. For patients who can tolerate oral feeding, and early introduction of a low-fat solid diet is recommended. Nutrition for acute appendicitis, acute pancreatitis. So early entrant feeding provides more of a preventive benefit than a nutritional one, as it significantly reduces mortality and complication. So the recommended targets: energy 25 to 30 kilocalorie per kg body weight, glucose 2 to 4 gram per kg body weight, protein 1.2 to 1.5 kg body weight, lipids 0.8 to 1.5 gram body weight. So coming to the next thing, chronic pancreatitis. Patients with chronic pancreatitis are high risk of malnutrition due to maldigestion caused by pancreatic exocrine insufficiency. Is the primary cause of malnutrition in these patients. Vitamin A, D, E, K deficiencies are always there. Malnutrition increases the risk of complications and mortality. So nutrition for chronic pancreatitis: energy 25 to 30 kilocalorie per kg body weight, protein 1.5 kg per body weight. So complete alcohol abstinence is the key for chronic pancreatitis and malnutrition management. For patients with pancreatic exocrine insufficiency, enzyme supplementations are essential. Condition is diagnosed when patients have steatorrhea, more than 15 grams per day fecal fat, or clear signs of maldigestion, malabsorption. Initial screening can include asking if stools contain undigested food or are difficult to flush. Further evaluation may involve pancreatic function test, fecal elastase 1 measurement, and assessment of symptoms such as diarrhea, bloating, poor nutritional status, and weight loss. So nutrition for chronic pancreatitis: supplementation of fat-soluble vitamins A, D, E, K, proteins, albumin, lipoproteins, apolipoproteins, and minerals like magnesium, zinc, and calcium. Pancreatic enzyme therapy should be taken with meals. Pancreatic enzyme therapy should be taken with meals. High fat intake does not need to be avoided if enzyme therapy is effective, while enzyme replacement improves digestion. Complete normalization is rare. Dosage based on lipase activity: main meals 20,000 to 40,000 IU international units, and snacks 10,000 to 12,000 20,000 units. Nutrition for chronic pancreatitis: add a proton pump inhibitor before breakfast and dinner to prevent enzyme inactivation by gastric acid. Increase enzyme dose is needed to improve digestion and nutritional status. If these measures fail, investigate other causes such as bacterial overgrowth. So these are all nutrition for chronic pancreatitis and acute pancreatitis I have already discussed. So the other important disease is inflammatory bowel disease. Inflammatory disease has two parts: ulcerative colitis and Crohn's disease. So coming to the nutritional aspect, malnutrition is more common in Crohn's disease than in ulcerative colitis because Crohn's disease affects both small and large intestine. You see, ulcerative colitis affects only the large colon. So because of this risk, regular malnutrition screening using validated tools is recommended at diagnosis and throughout follow-up. Malnutrition is present, nutritional therapy is essential, and energy needs of IBD generally not increased, and protein requirements remain normal during remission. However, during active disease, protein needs rise 1.5 to 1.2 to 1.5 gram per kg body weight. Nutrition of inflammatory bowel disease: patients of common deficiencies showed calcium, selenium, zinc, magnesium, as well as vitamins, particularly B12, folic acid, vitamin A, D, K should be supplemented. Loss of selenium, zinc, and magnesium often result from poor intake and chronic diarrhea. These deficiencies can lead to bone problems, fatigue, poor wound healing, and cartilage degradation. So certain medications such as cholestyramine can interfere with absorption of fat-soluble vitamins, iron, and B12 may cause steatorrhea. Therefore, regular laboratory monitoring is essential. The most frequent extraintestinal complication is iron deficiency anemia, especially in Crohn's disease. Anemia often causes fatigue, sleep disturbance, restless legs, poor concentration, and mild anemia. Oral iron is sufficient. Active IBD or intolerance to oral iron, intravenous iron, especially if hemoglobin less than 10 grams per deciliter, or erythropoiesis stimulating agents are required. Other common deficiencies include calcium, vitamin D, folate, B12, and zinc. If more than 20 centimeters of the distal ileum is resected, B12 supplementation is mandatory. The low levels of calcium and vitamin D are common in IBD, especially in patient duodenal and jejunal involvement. Calcium deficiency is often linked to vitamin D deficiency. Prevalence is up to 70% in Crohn's disease and 40% in ulcerative colitis. And preclinical studies indicate that active vitamin D can regulate growth and promote anti-inflammatory effects. Parenteral nutrition is reserved for cases where oral and tube feeding is not possible. So during active disease, the special formulations, glutamine, omega-3 fatty acids, and probiotic are not recommended. However, probiotic therapy with E. coli or BSL-3 may be considered for mild to moderate UC to help induce remission. Exclusive enteral nutrition is widely used to induce remission in pediatric Crohn's disease. So coming to the regular screening for malnutrition and micronutrient deficiency, energy and protein requirements are stable in remission. Supplementation of iron in case of anemia, oral iron is not sufficient. So coming to the conclusion, clinical nutrition is clearly important in the treatment of patients with liver, pancreas and inflammatory bowel disease. A major knowledge gap exists regarding the progression of NFLD in children and adolescents, and weight loss remains the most effective strategy for improving liver health, offering benefits beyond those achievable medication high risk of NASH. And with an aging population, the incidence of cirrhosis due to NASH is expected to rise sharply over the next 2 decades unless effective preventive and therapeutic measures are implemented. Trillions of microbes living in symbiosis with the host play a critical role in health and disease. Research on human microbiome continues to expand. So, although several mechanisms have been proposed, more research is needed to fully understand how the microbiome influences the liver disease. So, IBD closely linked to dysbiotic gut microbiome, though it remains unclear whether this imbalance contributes to disease development or it is a consequence of the disease. Because of the microbiome's role in IBD therapies, targeting microbial composition have gained attention. Additionally, a deeper understanding of the complex interaction between dietary nutrients, immune function, and the microbiome is essential to improve effectiveness of nutrient intervention. So, more research is also needed to define optimal laboratory markers for nutritional assessment and chronic pancreatitis and to determine their reliability and accuracy in diagnosing pancreatic exocrine insufficiency. Thank you.
Thank you, Dr. Pratap, for excellent talk, very academic, and you have touched many aspects of GI and liver complaints and pancreatic pathology and problems which was possibly never discussed. So thank you very much. We'll require your presence for 10 minutes after 30 minutes. Thank you. Now I request to run the recorded slide of Dr. Sirang Bichu, the famous nephrologist from Bombay Hospital, who has many practical experience, and I have experienced many patients, those who are treated by Dr. Bichu, and so meticulous in his clinical planning, diet, everything. Welcome, Dr. Bichu. And he is a senior nephrologist with 30 years experience, currently professor and head of nephrology Bombay Hospital. So a lot of things he is doing. He has a kidney foundation and many national and international presentation. Welcome, Dr. Bichu. Stuti. Stuti, we are expecting the presentation.
Stuti, can you put Dr. Bichu's talk? Yeah, it has come. It has come now. It has come.
A very good evening to all of you. I thank Dr. Alok for giving this opportunity to me to talk to all of you and share my thoughts. Today, I will be sort of revising the various aspects of renal diet and the challenges of planning it. I will address the dietary prescriptions rather than going into the specifics of meal menus, you can say. So we all know that chronic kidney disease is very common in our practice now. CKD patients have a higher mortality than the general population. Major causes of mortality in chronic kidney disease are cardiovascular and infection. Protein energy wasting is largely responsible for infections, falls, and general debility. This last point is very significant. While we should do our best to prescribe an appropriate diet, we should ensure that we do no harm by causing excess protein energy wasting. The planning and executing and following up of a renal diet is complex, and hence it is also challenging. Optimal diet for individual chronic kidney patient varies depending upon the changes in the estimated glomerular filtration rate, lab biochemical parameters on each follow-up visit, type of kidney disease, whether it is proteinuric or non-proteinuric, whether it is salt and potassium wasting or no, and the presence of other comorbidities like diabetes, hypertension, and heart failure. Also, there are multiple competing goals like kidney protection, nutrition, comorbidities. There is no one size fits all when planning the diet. For chronic kidney disease patients not on dialysis, a daily protein intake of approximately 0.8 grams per kg is what is recommended. I have taken this slide from Up2Date, and the authors of Up2Date, who are all masters in this field, recommend this. Most of the protein should be plant-based. Potassium, phosphorus requirement varies, and I will get back to this later. Calcium intake should be about 1 to 1.5 grams, and caloric intake should largely follow the DASH diet, and fiber should be adequate. And we need to know that fruits and vegetables form the major source of fiber, and these are what are actually told to be restricted in patients with chronic kidney disease. National Kidney Foundation KDOKI guidelines for chronic kidney disease prescribe a diet of 0.6 grams per kg per day for non-diabetic chronic kidney disease patients and 0.8 grams per kg per day for diabetics under close, but this should be under close observation. I want to stress here that our Indian diet is largely carbohydrate heavy and protein light. Our usual diet has around 0.8 grams per kg per day of protein. Hence, in diabetics, actually no further restriction may be required. Also, this diet is only for adults and stages 3 to 5. And more importantly, only for patients who are metabolically stable. The guidelines also emphasize on mandatory safety conditions when we prescribe a low protein diet. With low protein diet, we must ensure that there is enough caloric intake. For this, there should be proportionate increase in polyunsaturated fats rather than processed carbohydrates. Also, more than 60% of the protein must be first-class protein. A regular 3-monthly nutritional assessment must be done. Blanket orders asking patients to avoid protein-rich food must be avoided at all costs. We must revert to a high protein diet if there is unintentional weight loss, if there is AKI superadded on chronic kidney disease, if there is fever, infection, other catabolic states, is a patient undergoing surgery, there is uncontrolled acidosis, if there is increase in proteinuria, and the earliest signs or symptoms of muscle mass should alert us to revert to a high protein diet. And if there is any admission to the hospital, that is also a trigger to think about whether we should continue with the low protein diet. Also, muscle loss can cause decrease in the creatinine. So there is a downtrend of creatinine as we lose muscle. This is because creatinine is a product of muscle metabolism. This gives a false assurance that we are doing well, and actually the creatinine is falling, so the eGFR is expected to be better. But in fact, this is a sure recipe for disaster. We have to course correct here. Also, another much overlooked area in a patient is when they start dialysis. We have to remember to advise patients to revert to a high protein diet. In fact, the requirement is 1 to 1.2 grams per kg per day for these patients who are on dialysis. Patients should be told that proteins are not bad for the kidneys. They misunderstand that the proteins are bad for the kidneys and overdo restriction. Also, in this day and age of ACE inhibitors, ARBs, SGLT2 inhibitors, MRAs, the incremental benefit of aggressive protein restriction is likely even smaller, and the risk of sarcopenia should always be kept in mind. I get questions about use of keto analogs. This is recommended if at all we have to use this. This is with a very low protein diet. It is 0.3 grams per kg per day. And this should be under very, very close observation. And the dose of keto analogs is, if you take a tablet, which is like Ketostril, it is 12 tablets per day for a 60 kg person. Now, if you don't do this, then if you don't restrict the proteins or if you don't give enough dose of Ketostril, the patient will land up with problems. I have seen prescriptions of keto analogs without patient adhering to low protein diet, without a proper nutritional assessment and follow-up. I have also seen prescriptions of keto analogs of only 2 to 3 tablets a day. And I have also seen prescriptions of keto analogs for patients on dialysis, patients with normal eGFR, patients with significant proteinuria, and AKI. If this is only out of ignorance, we should please avoid this. Sodium restriction is one of the most important aspects of planning a renal diet. High salt intake is common in Indian diet. Pickles, papads, chutney, bakery products, farsan, salt, nuts, salted fruits, restaurant foods, packed food, all these are rampantly available all around. Poor adherence is there despite counseling, and direct impact of the sodium restriction has a direct impact on blood pressure, edema, and proteinuria. And it also leads to very, very poor control of BP and this is a major cause for progression. We should advise patients not to take more than 2 grams of sodium, that is about 4 to 5 grams of salt. And this is particularly so in patients who are volume overloaded and proteinuric. With certain patients who have chronic interstitial nephritis without hypertension, we can be a bit liberal on salt restriction. Sodium restriction and thereby control of blood pressure is much more important intervention than restricting proteins. If you ask me what is the single most important measure to reduce progression of chronic kidney disease, I will say without a doubt that it is a restriction of sodium. Potassium restriction should be individualized, and as variety of fruits, green leafy vegetables are important for health. It should not be a blanket order for all patients with low EGFR. For example, patients who are diabetic have got type 4 renal tubular acidosis, and patients on ACE inhibitors, ARB, MRA, decreasing EGFR, will all need a stricter restriction of potassium-rich food. However, a patient with chronic interstitial disease with normal or low serum potassium values will benefit from a liberal potassium diet. Now, coming to phosphorus, many patients get hyperphosphatemia, and this leads to secondary hyperparathyroidism and bone disease. Hence, restriction of phosphorus-rich food becomes paramount in these patients. The most important intervention is stopping intake of processed food. Also, following a largely plant-based diet helps. All said and done, diet alone is not sufficient in advanced CKD, and pharmacological intervention may be necessary in pre-dialysis as well as dialysis patients. How much fluid should a patient with CKD have? There are a lot of questions about this that are generally asked by doctors as well as by patients. One thing I do is to ask the patients to check if they have swelling of the feet in the evenings. If they have swelling, they should restrict fluids. Also, if they have to take a diuretic, it is a must to reduce salt as well as fluid intake. More so, salt intake. By having less salt and fluid, we can reduce the dose of diuretics. Low salt intake helps in controlling thirst as well. So here, the key take-home messages are from my talk as at conclusion. Renal diet must be individualized, not formula-based. Avoid over-restriction. Monitor nutrition very closely. We should lay more emphasis on salt restriction rather than being after protein restriction. General health of the patient is more important than possible delayed progression of chronic kidney disease. And periodic nutritional assessment is vital. Thank you.
Dr. Alok is on mute.
Yes. Thank you, Dr. Bichu. It's an excellent clinical talk. Our doctors, dietitian, nutritionist, everybody will be benefited, and patients will be benefited out of this. Many doubts you have clarified, and we have few others which will ask you during the panel after few minutes. Now I request Professor Ashok Das to conduct the interview with another giant, Professor Breeze Makkar, and they will be talking about current relevance of weight loss diets such as keto and VLCDs. Professor Das, please.
Thank you, Alok. Dear friends, before I start, I must compliment Dr. Bichu for a very brief but very impactful lecture. You know, today's world, the renal problems have become very huge. And in diabetics, it is still much more than what we see. Therefore, your talk, Professor Bichu, has been a veritable heaven. And the talk by Dr. Pratap Behra was very good. In fact, we would like to ask him the questions after the interview on the diet that is of our concern. Like he also dilated on the muscle diet, he dilated upon the diet in pancreatitis, and we'll ask you questions, clarify our doubts. Thank you, both of you, very, very much. Now I'm going to do an interview with one of the very famous person in the field of obesity. Can I have the biodata, please? Professor Breeze Makkar got his MD from Maulana Medical College many years back with honors. After that, he was in the state government service for some time, and then he shifted to his own hospital and own practice. If you want to summarize in very short sentences, Professor Makkar is the presiding officer in the obesity management in our country. He is the president of the AIRO, which is the international organization. He is the president of the AOCO, that is Association of Obesity and Chronic Diseases in our country. He is a bariatric physician, obesity physician, and very widely read. He is in the Canada Network for Research on Obesity, and he has been the president of our RSSDI, the Secretary General for 10 years, organized conference in Delhi. So Breeze has been absolutely fabulous and top of the ladder in the field of obesity. And I requested him to answer a few questions that we have regarding, there are many anti-obesity diets. Two diets that are very much prevalent in our country is VLCD, very low calorie diet, and ketogenic diet. And in next about 12-13 minutes, we'll go through the important aspects of that. It is very interesting. I want to have all your attention. Let us start it. Breathe. Let us start. Please put it. Breathe. We are starting the program now.
My dear colleagues and friends who have joined in thousands for this update, Clinical Diabetes Update, NUCD, the 10th edition, I welcome you to this unique session with a very well-informed, well-researched, very kind and very eminent physician, obesity physician, bariatric physician session with Professor Dr. Breeze Mohan Makkar. I will call him Breeze because he's much younger to me and lots to my younger brother. Dear friends, to make a long story short, Breeze had his MD from the famous Maulana Medical College, New Delhi, and he had been a prominent figure for last 43 years and more in the field of diabetes, in the field of obesity, and of course, internal medicine. Dear friends, he has kept the Indian flag of obesity research and obesity care flying high in our country and abroad. He has been an invited member of the ADA, EASD, is a very prominent member of the European Association of Study Obesity, and of course, needless to mention, the face, the figure of AOCO, Indian Obesity Association, of the SCOPE, the teaching program of the Obesity Association for the doctors to make them eminent bariatric physicians, and also he has made seminal contribution in field of obesity. Widely traveled, a member of the Canadian Research Network on Obesity. He has also contributed immensely in the field of diabetes. He had been a very eminent general secretary. He had been the president, given orations, and contributed very immensely. If you want me to pick up one person who is the face of India in the sphere of obesity, one of the prominent faces will be Breeze. Breeze, hearty welcome on behalf of the 10th edition of the NUCD to this unique session. Dear friends, we are going to discuss today the role of nutrition focused on the very low calorie diet, BLCD, and the ketogenic diet. We'll also briefly allude to other diets that is very important in obesity. Dear friends, obesity today has become very important, very contemporary, and very challenging, and the number is increasing by leaps and bounds. However, a comprehensive care of obesity is paramount, and always Breeze has stood for it. But my first question that nation wants to know from you is there a role of nutritional management in the current era of GLP-1 drugs, GLP, GIP-1, GIP plus GLP, triple combinations, which are very eminent therapies in the field of suppressing the appetite.
Thank you, sir. Thank you very much for very, very kind, almost humbling introduction. And I must thank NUCD also for this great invitation. So I think it is very relevant question. Now people are thinking that we have got GLP-1 based therapies which are wonder shots to suppress appetite, and you don't need to have any nutritional management. So you can, suppress appetite and you will lose weight. But one thing everyone forgets is that nutrition management is not just cutting down the calories. It is cutting down the calories while making sure that you are providing everything else that is required by the body.
Correct.
So simplest way to cut down, calories is you cut down your food into half, but you will cut down your vitamins, minerals, proteins, everything into half. And you will be compromised in terms of nutritional adequacy. So maintaining nutritional adequacy during weight management is of very, very high importance. Otherwise, what happens is person is losing fat and muscle both. If you are doing, just the cut down of calories, if you are putting somebody on GLP-1 based therapies and you are not providing adequate nutrition, or the person is not exercising, there is loss of muscle mass also. So you have to make sure that person gets adequate protein, minerals, vitamins, and all the essential amino acids and everything to make sure the health is sustained while only calories are being lost. And that is where the nutritional management is of key importance in management of obesity.
Absolutely fabulous, Breeze. It is very educative for all of us. You have rightly said diet as the cornerstone of the weight management, along with interaction with the physical activity and other lifestyle factors. And today we are here to listen all about that from you, from your experience, from the literature that you have contributed and published and gone through, and also to make us very eminent in the field of nutritional management of obesity. Breeze, to make it very informal, shall I ask you, does nutrition play an eminent role when the anti-obesity drugs, it has to be continued for a very long time? For whatever the reason, if the anti-obesity drugs are discontinued, be it anything, does nutrition play a role in maintaining the weight loss, at least at a set point?
Absolutely, sir. So first thing is, we have to understand obesity as a disease process. We just think that it is, either the excess consumption of food or calories or lack of physical activity, which is leading to obesity.
Correct.
We have to understand it is a multifactorial, complex, relapsing disease. Relapsing disease is very important part of the definition.
That's the definition.
That once you stop treatment, everything will come back. Now, we have to compare this with diseases like diabetes or blood pressure, where anybody who's coming with blood pressure or diabetes, we advise them lifestyle interventions, we put them on medication, we achieve the target levels. Once we achieve the target levels, can we stop the treatment? The answer is no. Once we stop, everything will go up. Similarly, in obesity, you initiate the therapy with lifestyle interventions and medication. You achieve a target weight loss, after reducing weight, and then you have to sustain it there. Now, during sustenance, if somebody is eating, excess calories or whatever the irregular habits the person had earlier, then weight is bound to come back
again.
So lifestyle interventions still play a very important. In fact, I would say lifestyle interventions are the integral part of obesity management right from the beginning till the end of maintenance part. So they have to be ongoing as long as we are managing obesity.
Good.
And during weight loss, it is the calories restriction which is very important, but exercise is also important. During weight management, again, you have to maintain, a calorie balance as well as exercise.
Very important. Breeze, what is the dietary goal in the obesity management? How much weight loss you expect, you target, and does it provide any other benefit than weight loss?
So, sir, earlier we were looking at 5 to 10% weight loss as the target because, that was the best we could achieve with medical management. And if somebody had morbid obesity, the answer was bariatric surgery. With the newer molecules, we are able to achieve 15%, 20%, 25% weight loss. And now we are looking at something called ORC. Obesity-related complications is a very key component of consideration when you are defining therapy. If you look at the ESO framework 2025, which has come up, ESO is one of the pioneers in giving a framework of management of obesity. Clearly states that first thing is you have to institute lifestyle interventions. Now the target weight loss depends on what you are looking at. If we are looking at something like correction of MASLD or remission of diabetes, which we know will happen with 15% weight loss, so our target will be 15%. If we are looking only mild improvement, somebody is having initial diabetes or having diabetes which is not getting controlled, or has snoring, or not severe OSA, mild derangements in the metabolic parameters, maybe 5 to 10% will help in reducing blood pressure, reducing glucose levels to some extent, but will not reverse the process. Similarly, if there is osteoarthritis, you would like to reduce as much as possible. You are looking at HFpEF, you want to reduce anywhere around 10 to 15%. You want to cut down the cardiovascular mortality, we know 15% will do that. So it depends on the risk reduction and the organ obesity related complications. And higher the weight loss, better are the results. That is also seen. Suppose we need 15%, if we are achieving 20, we are having even more benefit.
Good. I think great knowledge you were given to all of us, that the degree of weight loss is dependent upon what you want to achieve. And the graded weight loss will provide the graded benefit. And that's a great answer. Please, there are so many types of diets that we prescribe in the obesity. Today, our focus is on two types of diet. One is VLCD and the other one is ketogenic diet. Now, can I ask you in the very beginning, very simply to tell our audience what is VLCD and then what is ketogenic diet?
So VLCD, sir, is a very structured diet. By definition, it is 800 calories or less. So you reduce the calories significantly, but you make sure that you are providing adequate protein, adequate minerals, vitamins, and fiber. So it is a formula diet where the structure of the diet is such that you have reduced the calories significantly, while at the same time you are providing all essential, nutrients as well as protein, sufficient protein for the daily requirement. So a VLCD by definition will have the recommended daily dietary allowance of all the nutrients as well as protein. It is only calories which are reduced to 800, but rest everything is equal to the recommended daily dietary allowance.
What is ketogenic diet?
So ketogenic diet is basically typically a diet where you have increased the quantity of fat as the core nutrient, core macronutrient, and reduce the quantity of carbs.
I see.
So the carb is the classical keto diet has a ratio of 1:4 between carb and fat. So if you have 20 calories coming from carb, then 80 are coming from fat. Now, because of the acute shortage of carbs, what happens is you are not getting carbs, so ultimately body starts metabolizing fat and producing ketone bodies, which become alternate fuel. So you induce nutritional ketosis, and this leads to reduction in fat. And again, classically it was this keto diet was initiated as a treatment for epilepsy, but then it has come into vogue for weight reduction. Now, difference between VLCD and keto diet is keto diet doesn't have that structure to provide everything else. It will cut down the calories. It is providing excess fat calories, but it is not also looking at 800 calories only. It can be more. Second thing is it is cutting down protein also significantly. Then it is not taking care of all other essential nutrients. While VLCD also is leading to ketosis, because the calories are so low that you are not providing even half the calories for the daily requirement. So ultimately, it will also induce ketosis, but it will make sure that you are getting adequate protein, which is recommended daily arounds, and all other essential amino acids and everything also.
Great. I think great answer, Breach, is greatly educative and very clinical, practical tips you have given. Just wanted to know that what are the other metabolic benefits of these two diets?
So actually, if we look at the metabolic parameters, the best achievement happens in reduction in the glucose levels and reduction in weight. Lipid parameters, in some of the patients we see increase in HDL, but there are studies which have shown that there is increase in LDL also, and there can be increase in triglycerides. VLCDs are prone to cause, because of acute weight reduction, they can lead to gallstones also. That is one of the complications that we have to look at. Then we have to also make sure that they are supervised, these diets, because they can lead to nutritional deficiencies in some people who are not tolerating particularly, or the electrolyte imbalance can also happen because the intake is so low. So you have to use these diets as a supervised, treatment.
Very correct. I think it's a great information and great advice to our bariatric people who are practicing bariatric medicine. Breeze, I wanted to know that the BLCD diet was used in the direct trial. So just three, 4 sentences about it, about the remission of diabetes with this BLCD.
So again, sir, this was basically the concept came up from the counterpoint study which was done by Roy Taylor and Lim before this direct trial, and they showed that possibly the benefits that we saw in bariatric surgery were not because of the the incretin changes. They were because of the acute restriction of calories that happened, which led to the reverse traffic of fats from the adipose tissue into the circulation, or from the different organ fat. Actually, the focus was on pancreatic fat. So it showed that because of the acute caloric restriction, you have, instead of fat going into the ectopic sites, the fat starts getting mobilized from the ectopic sites first. And because of the first mobilization from the ectopic sites, you immediately get improvement in insulin sensitivity and correction of the glucose levels. Now, again, important thing is, when do you intervene? So the study showed clearly that these were the people with diabetes who were within 6 years of duration. Bariatric surgery studies have shown that if you are beyond 5 years, the chances of remission are lower and lower. Now, how does it do it? It cuts down the glucose metabolism. So you start breaking fat, and the mobilization is coming first from the ectopic sites. Now, again, in direct trial also, this diet was given for 3 to 5 months at best. And at the end of 3 months, actually, they started introducing the normal form diet. Between 3 and 5 months, they reintroduced the diet and brought them to the normal this thing. Within 1 year, significant numbers started gaining weight also. But people who followed the sustaining diet, they maintained remission over 2 years also. We have already 2 years data with us, and I think 4 years data is already there. But again, these diets are used as short-term measure. They are not long-term diets.
Absolutely. Absolutely. That very important message is short-term measure. I think we have beautifully emphasized both.
And another study is there, sir. The study was done, I think, 20 years back, which showed that if you compare the low-calorie diets, which is the usual recommended diet for management of obesity, and you compare with the VLCD, the initial weight loss is very high with VLCD compared to low calorie diet. But after 1 year or 2 years, the weight lost is same. So initial loss again, gains back very fast, and you are losing more or less same weight at the end of 1 year.
Great, great message. I think, Breach, everybody talks about the fat-free mass loss, sarcopenia, that occurs with the VLCD. And can high protein intake offset this sarcopenia?
High protein intake is important in offsetting sarcopenia, but it will not do without exercise.
Exactly.
Unless you are exercising, that protein is not going to be utilized by muscle also. So ultimately, muscle building will require both exercise and protein supplementation. Just giving protein supplementation will not, take care of sarcopenia.
I think very important information. I want everybody to carry home this important message. I think next important step, Breach, is nutritional ketosis is a mandatory necessity, or do low carbohydrate diet that you alluded to, low carbohydrate non-ketogenic diet can achieve similar metabolic outcome.
So all the long-term studies have clearly shown that it doesn't matter whether you are using VLCD or you are using low calorie diets, or you are using different, intermittent fasting and all those. At the end of day, it is the amount of calories that you are restricting will translate into the weight loss benefit. Now, important thing is when we are managing obesity, as we initially discussed, it is a long-term plan. It is not short-term plan that you achieve weight loss and then you forget it. You have to sustain it. So we should look at a dietary pattern or a nutritional management plan which is sustainable over long term and which can become a part of the daily routine or the eating behavior of the person. Otherwise, we have no benefit of that diet plan. If the person is not going to follow it, so it is of no use. So there is a common saying that medicines help those people who take them. Those who don't take them, nothing will happen to them.
Exactly. I think right. Very important. Now, does ketogenic diet improve insulin sensitivity?
Sir, to begin with, yes, but they are again short-term thing. Insulin sensitivity will come down because you are breaking down fat, you are removing fat from the organs, and that will improve insulin sensitivity to begin with. But again, if a person is diabetic and is in severe hyperglycemia, I would not take a chance of inducing further ketosis in that person. First, I would like to have good metabolic control or at least decent metabolic control before putting them on a ketogenic diet. I would rather use a VLCD where all other things are balanced rather than using a keto diet.
Absolutely. I just want to know two other things. What is the impact of these diets on one, systemic inflammation, and what is the impact on the gut microbiota, which is very much talked about today?
So, sir, both the diets, again, gut microbiota is one area which is very difficult to tread in. We are seeing papers coming on gut microbiota for last 25 years now, but we do not have anything conclusive to say that, okay, we do this and this will be the translation in terms of improving gut health. So both these diets have been shown. In fact, any kind of fasting has been shown to improve gut health.
Correct.
Absolutely. So these are practically, different types of fasting, you can say, that are improving gut health. But does it actually translate into reduction in inflammation through gut health or directly? We don't know. But certainly, if you are cutting down, the free fatty acid turnover, or you are increasing the fatty acid oxidation, certainly you will be able to cut down inflammation.
Correct. I think very important. I just wanted to know a very practical answer. What is the long-term sustainability of these diets when you prescribe it? You have been one of the most eminent physician.
So, sir, long-term sustainability is very poor, and that is why we hardly use these diets on a regular basis. Once in a while, yes, we keep. Actually, when we are treating people with obesity, we are also looking at the change in eating behavior, which is part of behavior therapy. So during that part, a lot of education is involved as far as the different diets are concerned. So they are, educated about different kind of dietary patterns that they can follow. We expose them to, a regular low calorie diet, very low calorie diets also, intermittent fasting also. All these things are, doable. And there are settings when one may be, easier to do rather than the other one. So even if they keep changing, it doesn't really matter. But important thing is, as long as they are not going for weight regain, any diet is okay. If the weight is being regained after weight loss, then whatever diet is there is not sufficient and you need to support with pharmacotherapy.
Yeah. I think the last two questions are very important, Breach, just to educate our people. What are the adverse effects that you have seen with this diet prescription in amongst Indian patients? Any adverse effect of this?
So one major one is the formation of gallstones.
Yeah,
people start feeling weak also. The sarcopenia is one of the risks with keto diets because they are not protein sufficient. Then there is something like which is called keto flu. They develop flu-like symptoms after starting keto diets.
I see. Good. I didn't know that.
So this is one thing which commonly happens. But otherwise, you have to make sure that they are, not getting into, because of the ketosis, they get nausea also, quite a few people. So their water intake and, hydration can be at risk. With the VLCD, again, rapid weight reduction can lead to, small risk of gallstones and even pancreatitis to some extent, if you're looking at, but it is rare. Monitoring, I think, is very important. And another important thing is sustainability is poor. So these are the common things which come to my mind as the major, drawbacks. And the worst thing is that they are not sustainable over long term.
Great. I think you have given a great insight to our esteemed audience regarding the nutrition in obesity in general and VLCD and ketogenic diet in particular. Before we close, and I would like to offer our sincere thanks and gratitude on behalf of thousands of people who have joined this program and about all our faculty, Dr. Kanungo and the entire team in Nucd. But before I close, I would just want you to, in last couple of minutes, you can give your key takeaways, the core tips that you will give about diet in obesity in general and any particular diet that you will adhere to, you will allude to in your talk.
I think, sir, diet is one of the key components of obesity management. And it has to be ongoing. Dietary management has to be ongoing throughout the weight management therapy. So first thing is you have to pick up a very practical dietary plan which cuts down calories while ensuring adequate nutrition. Second, you have to look at the components of diet which are routinely available in any house kitchen. If we are giving them fancy or fat diets, they are not sustainable or long term. Third thing is we also should make sure that person is eating the same food which is being cooked for everybody. If for one person you have to cook separate food, it is not going to be sustainable anywhere. So rather than, having a separate diet for this person, you have to tell the family to modify it towards a healthy diet. And this person can have more focus on portion size and the routine eating. Another important thing is if we give them monotonous diets, they become boring and the adherence again is poor. So we have to give them very, very practical approach to dietary management. And we have to educate them how to keep, making changes in their diet without increasing calories while maintaining the taste and flavor of the diet and still maintaining good health. So every diet that we should, tell them should be sustainable over long term.
I think, Breach, my words fail to express on behalf of all of us our great gratitude. We will follow what you have said today, and this is a very highly impactful interview, which also greatly impacts the nation's health. Thank you very, very much, Breach. On behalf of all of us, I again offer our sincere love, greetings, and gratitude for this great interview.
Thank you, sir. Thank you. truly obliged to be on this platform
Professor Das.
and convey my regards to Dr. Kanugo also.
I'll do that. I'll do that.
Thank you, sir.
Thank you, Breeze. Thank you, Breeze. Thank you. Thank you.
Thank you, Breeze. Thank you, Professor Das. And we have come to a short panel discussion. I'd like to request Breeze Saab if he's there, Rakesh is there, Dr. Pratap Behera, and Dr. Siram Bichu, and Professor Ashok Das.
Yes.
Can I find them? Professor Das is there, and I saw Rakesh also, and Pratap.
Yeah,
are
good
you
evening.
there?
Good evening,
Yes.
sir. Yeah.
Yes. We'll go quickly for few questions.
Pratap, I have got few questions to ask Pratap, very clinical,
Sir,
practical questions.
Good evening, sir. Sir.
Pratap, it was a very, as Dr. Karunko described, very comprehensive and fulsome. I just want to, from our clinical practice, three things. Diet for the muscle. You did mention about the 7% to 10% weight loss. You did mention about the other things in that Mediterranean diet. You also mentioned regarding the weight regain and what happens. My question to you is to light to light the dark corners of muscle diet. Number one, to get 10%. We know that but any weight loss will improve muscle. Am I correct? Any weight loss will improve muscle. Now, when you say Mediterranean diet, in the Indian scenario, that is possibly very difficult, Pratap, no, to get Mediterranean diet.
Yeah.
Is there an Indian equivalent to Mediterranean diet?
Actually, now the concept is changing. Now, gradually, we are shifting maybe in cities, in urban areas, and in villages also. The concept regarding diet in the general population is also changing. So now, as for diabetes and for liver disease and for GI health, so people have become more conscious regarding the diet pattern. So I will tell you certain things for cereals, for pulses and vegetables. What are the recommended Indian scenario diet? Like instead of white rice, we need to go back to whole grains and millets. Nowadays, millets have become more available. Government is also in a spree to promote millets. That is a very good thing, and millets have a very low glycemic index that improves
Good. I think you're Pratap, very
sir.
clear. My question is over and above advice for a quote unquote diabetic diet. You know what we mean by diabetic diet.
Sir.
What extra that person should do for muscle diet?
The extra diet means to reduce carbohydrates, number one. Number two, increase the protein intake. And protein intake is beneficial both for muscle and for the liver and for the diabetics. So protein probably all the pulses and legumes they can take, excepting red meat, organ meats, full fat dairy, fried meals and prawns. These things to be avoided, and the rest all the pulses and protein diets they can take. In addition to the vegetables like non-starchy vegetables, they can take in their food, and fruits like apple, guava, papaya, all these are beneficial.
Correct. And
Professor Das.
the last question from my side is a very simple question. Now, you said about acute pancreatitis. And we know from our experience that many people die because of starting the nutrition late. Am I correct? You also
This
said
is absolutely correct. So only when in the management of acute pancreatitis, only when patient is critically sick, not able to tolerate orally, he is vomiting or any low parameters in sepsis or electrolyte imbalance and other thing. So fluid and patient should be kept on NPO. Otherwise, if mild and moderate pancreatitis, patient should be allowed to take oral feeds. and that benefits the patient.
That's a great change from the old teaching. Remember old teaching, Pratap?
So
Maybe
nowadays,
that
nowadays
was,
what we are
but now it
practicing,
is early feeding. Now
very
you
early
did
feeding.
mention two things, NG tube and NJ tube.
Sir.
And we use NG especially, but are you using NJ also by bypassing the gastric? You get any special benefit? It is worth it?
Yeah, it is worth it if patient has very distended abdomen and we want to feed him early, we give NJ instead of NG.
Okay. The last question from my side. You know, I know somebody very close to me, very close to me in relation and in my close proximity to him as a colleague and a friend. Have you encountered any time Rebelsus induced gastric mucosal, pan-gastric mucosal, or even pan-gastric, pan-intestinal mucosal ulceration?
Till now, we have not seen those kind of cases because maybe in our experience, Ribelsus has not been used that much.
Okay.
And in my practice, I have not seen.
Why I'm saying you this that Dr. Neeta Deshpande poo-pooed it. You were there. She didn't agree with that. But I have seen giving a full dose of 14 milligram for a long time can possibly handle, land a patient in that. So I do not usually exceed 7 milligram, very conservative. And so I have seen one or two cases where this can occur. You can keep it in mind, Pratap, and let me know you are in SOM. So I come to SOM, we can exchange notes, do that. Oh, I must congratulate you for a very, very robust advice regarding the entire. You touched upon IBD, touched upon the Crohn's, you touched upon everything. And it was a veritable experience. Any other questions that Alok you want to ask?
Professor Das will ask Dr. Pratap to give his slides or a write-up of 3 pages for our NUCD update.
Yeah, I would like to mention that in the very beginning of this year's planning, we have made
That
it
is a very and
mandatory
gives. You can
that
we
we'll
can
publish
produce
not
reproduce
full
it.
articles, but cream de la creme. We have a new term for it, which NMC has accepted, called short summaries edited. So, and we'll try to get it from the authors. So, what is request made by Professor Professor Alok Kanungo to Professor Pratap Behra is that please give us a short summary edited with bullet points and tables algorithms so that people today generation want it, and the volume will be e-volume, but we'll be having enough of print copies also for distribution, and we'll try to get it included in the Scopus because Pratap, I understand Scopus is our lifeline. We'll try for that. Thank you, Alok. But it will be for
Thank
all
you.
the authors, and I'll be writing a letter. Me and Alok will be writing letters to all the authors.
Yes.
If there are
We'll
no
do
more
that.
questions to Pratap, can I pass on to Dr. Bichu?
Thank you,
Dr.
sir.
Bichu, are you there? Thank you,
Dr.
Pratap.
Bichu, are you there?
Thank you, sir.
Is there? Sir, is there? But he touched
Dr.
upon a
Bichu
point which is I really
is a
liked it. Because whenever the creatinine is high,
busy
we
clinician,
usually
may
do
not Rakesh.
Rakesh can answer. Rakesh is there? Okay, doesn't matter. We are towards the end of the day program. Only one program is left, which is by my close friend. So before that, I must like to tell you that the role of chronic kidney disease diet in diabetes has become paramount because the prevalence of chronic kidney disease has increased. And the first thing we do in the time when the creatinine slightly rises is to decrease protein. That's what Dr. Michu also agreed, but he said for a long term, you cannot do that. It's a vicious cycle. Person will go back to it. The second thing he mentioned regarding the CKD in diabetes is about the sodium and said that the maximum 3 grams of salt or 2 grams of sodium salt per se is indicated. And I must tell you that his talk on the chronic renal failure diet. Renal diet was very good. We used to remember this with very mouth-filling terms that this diet, that diet, name diets, but he made it very simple and gave it very simply to all of us the diet. Thank you, Dr. Vichu. And any other questions somebody has about this? If not, I have got few questions which I have collected from the audience and others. Now, what are the key practical challenges in designing the renal diet for people with diabetes across various CKD stages? So what Professor Bichu said is that it's not one size fits all. Had he been there, I would have asked him. There is some papers which are claiming that vegetable protein is slightly better than the animal protein while you would decide about the diet. He also said that. He said vegetable protein is the best. That is Dr. Mani from Apollo Hospital's advice. The second question was that in the various stages, the amount of protein, amount of sodium will vary. And so it is, we have to be careful in what stage of the kidney failure, what EGFR, and then give the proper diet. And the advancing renal failure produces a lot of protein loss. The UCR, the albumin excretion by urine is high, and therefore we need protein replacement also, along with calorie replacement. And it was a great lecture. Thank you, Dr.
Professor Das, I think we have come to a close. So if you feel, then we can, if you know that.
So let us now come to the last session of the day.
Yes.
Thanks to Dr. Breach. Thanks to Dr. Bichu and Dr. Pratap Behra. Dear friends, seen brilliances and dazzling splendor of academics and clinical practice. And long ago, we had all our authors of medical books and the people who brought in the whether it is pacemaker implantation or complicated surgery, it was the West Bengal and Calcutta. Today we have amidst us somebody who is that brilliance, that dazzle. I'm not praising you, Kalenda. I know only praise you, but I must tell you, I'm speaking from heart. Kalenda's talks are exemplary, fine, clinical, practical, and very detailed whenever I have heard him. Last time I heard him was on lipids, and I had supposed to send him a paper for him to correct it, and if he agrees to co-author it. So without any other time being spent, I'll request Alok to take over and conduct this session.
Thank you, Professor Das. Thank you very much for a whole day. You have been really at this age, you are have so much of energy. You are sitting in front of the laptop, not left for a minute. Now, there is a small 5-10 slides for me to present, and after which Dr. Kalyan will present his talk. So this is a topic on holistic cardiorenal metabolic type 2 diabetes mellitus. Next, please. Stuti. Yes. In 1990, the rank 10 causes of death in India was enteric infection, cardiovascular, respiratory, maternal and neonatal, and like that. But in 2021 rank, cardiovascular diseases is at the top. Respiratory and TB, chronic respiratory, neoplasms, other COVID outcomes and enteric infections remain secondary. So these things are now changing, and the phenomena of disease orientation is also changing. Next, please. Next slide, please. If you look at type 2 diabetes, early type 2 diabetes, you find dysfunctional fat and insulin resistance is high. Indian people with new onset type 2 diabetes, but higher adiposity, higher central obesity, more insulin resistance, and greater cardiometabolic risk. And newly diagnosed type 2 diabetes, if you compare between India and UK, there is a lot of difference. Whereas our BMI is low and our problems are more. Next, please. Risk of CV events starts rising before the onset of type 2 diabetes. As you know, clinically, 10 to 12 years before the clinical onset, the biochemical diabetes starts inside. It is 3.6-fold increased risk of MI or stroke within 10 years prior to diagnosis of type 2 diabetes. In the nurses' health study, risk of myocardial infarction or stroke, where 2.2 million persons year of follow-up was taken place, that non-diabetic throughout the study had 1%, 15 years or more, 2 point diagnosis. It is increasing to 3.64 relative risk. Next, please. Cardiovascular risk in newly diagnosed type 2 patients in India was studied by many stalwarts like Unikrishnan, Rakesh, and Uday Phadke, and others, S.K. Sharma, and all others. And that says newly diagnosed Indian type 2 diabetes patients are at high atherosclerotic cardiovascular disease risk, and therefore more studies and a countrywide investigation should be made. Next, please. If you look at the pathological landscape of cardio-renal metabolic risk in type 2 diabetes, you see type 2 diabetes due to insulin resistance and beta cell dysfunction. It leads to hyperglycemia, endothelial dysfunction, and anemia, leading to CKD with albuminuria and EGFR decline, hypertension, neurohumoral dysfunction, fluid overload, and leading to CVD, which causes heart failure and atherosclerotic CVD. There is dyslipidemia, cardiomyopathy, and dysfunctional fat, and leading to all those, again the cycle is moving. So all these parameters are affected before the onset of diabetes, and it continues throughout the continuum. Next, please. Nearly 1 out of 9 Indian adults have type 2 diabetes. ICMR India study. 1 out of 3 people with type 2 diabetes have CBD. 1 out of 2 people with type 2 diabetes have LVF, left ventricular diastolic dysfunction. And like that, CKD and other things are taken care of. Next, please. And that study also shows 3 to 4% increased risk of death due to these problems. So screening for cardiorenal metabolic risk status in adults should be measured for BMI and waist circumference annually. Metabolic syndrome component like BP, TG, HDL cholesterol, glycemia every 3 to 5 years. USCR and serum creatinine, cystatin C based EGFR levels annually more frequently as required, and subclinical clinical heart failure through echocardiogram and cardiac biomarkers likely based on age, comorbidity and risk, and social determinants of health should be studied. Next, please. So these are some of the recommendations, and to which Dr. Kalyan will go through. Next, please. Measuring kidney function, EGFR as well as albuminuria is necessary to predict risk of kidney events and CV death in CKD. Observational sub-analysis of advanced study show that how baseline USCR gives a prediction value for CV death and kidney events. Next, please. CKD screening and diagnosis of people living with diabetes, ADA KDIGO consensus statement, diabetes management in CKD, who and when to screen. Type 1, 5 years after diagnosis. Type 2, yearly starting at diagnosis. What to do with a positive result? Repeat and confirm. Evaluate possible temporary and or spurious causes. Consider using cystatin C and creatinine to more precisely estimate GFR. Only persistent abnormalities define CKD. Initiate evidence-based treatments. How to screen spot urine or ACR can be done in any clinic, and EGFR defines CKD diagnosis. Persistent urine ACR more than 30, persistent EGFR less than 60, and other evidence of kidney damage. I think this is my last slide. Next, please. Intensive glycemia control reduces microvascular risk but doesn't consistently lower risk of macrovascular events and mortality in type 2 diabetes. Whatever glucose control you do, microvascular risk will come down, but you are not very sure about macrovascular events and mortality. So we have to continue the treatment and preventive measures. Next, please. So, holistic cardiorenal metabolic risk management is essential at every stage of progressive cardiorenal risk continuum. Prevention, regression, and retardation are to be done in all the continuum, and as you know, all the parameters needs to be addressed. Next. People with type 2 diabetes have renal and metabolic problems. So CKD, MSLD, heart failure, obesity, heart disease, and they need lifestyle management, essential treatment for risk factor control, and essential treatment for organ protection. Early coordinated treatment is crucial to improve patient outcomes and quality of life. Next. Thank you. I request Dr. Kalyan for starting his talk.
My talk is, thank you, Dr. Kanungo, and thank you very much for inviting me. My talk is recorded, so I think the RX team will play it.
Yes.
Hello, good evening, everybody. It's always nice to be there in the program NUCD with Dr. Kanungo. And thank you very much for inviting me. Now, my topic is 2026 vision of managing type 2 diabetes with CKD, optimizing the prevention continuum. It sounds like a very, very heavy and big topic. I'll just keep it simple. And I will just use a case to guide my talk, a simple hypothetical case. So this is the case. The disclosure, I think this talk is sponsored by Boehringer Ingelheim, and I'm the speaker for Boehringer Ingelheim. Now, this is a 50-year-old male with type 2 diabetes for 1 year. He's asymptomatic. His BMI, yes, he's overweight, bordering on being obese. His blood pressure in the clinic seems to be satisfactory. Hemoglobin a bit on the lower side. HbA1c needs better control, so blood sugar control needs to be done. Lipid profile, LDL is above target. Now, his urine ACR is 20. So, and his eGFR, as you can see here, is 82. So this together means that he is technically not in CKD. So this is the barn door, relatively newly diagnosed diabetes, not having any complications. He's just on metformin 1 gram and atorvastatin 20 milligram. Now, I tell my juniors and I tell myself as well, first look at the lipid profile, then look at the blood pressure, then look at the lifestyle, then look at some other factors, and last, you look at the blood sugar. Because if you straight away start with looking at the blood sugar, all the other things which I have told you takes a back seat and you spend 95% of time on the blood sugar, whereas all the others are perhaps as important, if not.
Tuti, see what is the problem with the recording?
More than blood sugar. So looking at the LDL cholesterol, it is 102. That needs to be corrected. Somebody on Atravas 20 milligram, I would have expected LDL to be lower. So I will straight away ask the patients, how many days are you not taking the tablet? Rather than asking, are you taking the tablet? If you ask, are you taking the tablet? Answer will be yes. So how many days have you not taking it? So that's first, ensure compliance. And then you can think about increasing the dose of the atorvastatin. Now, second is the blood pressure. That seems to be okay. Third, other things. Amongst that will include any symptomatology of heart failure. That is not there. There is no complaints. Clinical examination seems to be okay. ECG is fine. There is some anemia. So that we need to find out if this is new, old. A lot of people have got thalassemia. So always train yourself to look at the MCV. Anybody has got complete hemogram, hemoglobin level, look at the MCV. In a thalassemia, as you very well know, the MCV will be a bit on the lower side, less than 65, 60 also. And then that should alert you that there is some thalassemia trait, particularly if the patient is asymptomatic. So now for this type of person, what is the evidence we have that if we use medications, how can we stop him from developing CKD? Now, I'm going to show you this slide, this graph, which is a bit busy, but I'll just talk you through it. It's very important to understand the component. And this chart entirely shows all the evidence that we have till date. Now, this here is the urine ACR. So as we go up, the urine ACR is going up. And on this side is the EGFR. So as we go down here, the EGFR is going up. So EGFR, so the urine ACR less than 30 will be where my pointer is. So here is the urine ACR less than 30, okay? So here, up to here. So if somebody is here where my pointer is, that is EGFR is 65 and ACR is less than 30, they're technically not in CKD. So you can see here that all the trials with the SGLT2 inhibitors, EMPA, DAPA, Credence, with the Finrenone, all are in the group where the urine ACR is high. Okay, the highest is the renal trial, and then the IDNT trial. These are all the trials with losartan, irbesartan, all these with very high urine ACR. And you can see here with the DAPA CKD also had very high mean urine ACR. The flow will be somewhere here, which I will bring up later on. This is the Finrenone data. Again, the urine ACR is quite high. And in the Figaro DKD, at least the urine, the EGFR was quite good. So overall, where does the STENO2 trial, because we keep telling about the STENO2 trial, that multifactorial improvements in the STENO2 trial, you know, with type 2 diabetes, looking at the blood pressure, cholesterol, glycemic control, if you improve all of them, then that will reduce your micro and macrovascular complications. It will also reduce the hard CKD endpoints as well. But again, in STENO2 trial, the inclusion criteria was type 2 diabetes with microalbuminuria. So all in all, what I'm trying to impress upon you is there is not a single trial done in patients with urine ACR less than 30 to see whether any intervention can prevent the diabetes, prevent development of CKD. And I'm not just talking about albuminuria. I'm talking about increase of creatinine or reduction of eGFR. So there is, as you can see here, all the trials, they have the inclusion criteria with some amount of urine ACR. So no trial done with involving patients with urine ACR less than 30 and eGFR more than 60, that is normal, no CKD, no trial done. So therefore, this is the KDOQI, because I see many patients, many prescriptions where patients are started on RAS blockers, and the patients are told that I've given you a tablet which will prevent you from developing kidney disease. Now, this is the KDIGO 2022 guideline, which suggested that in normotensive, no albuminuria, like our patient here, available data suggests ACE inhibitors and ARB. This RAS treatment is not beneficial for patients with neither albuminuria nor elevated blood pressure. So if you give these patients RAS inhibitor, actually in these two trials also, where the urine ACR was quite low, not less than 30, micro end, there also the doubling of the eGFR was not affected. So there is no data that if there is blood pressure is normal, there is no albuminuria, there is no data that RAS inhibitor helps. So that's not me talking, that is the KDIGO. So there is no point in unnecessarily giving the patients RAS blockade. Now, this is the data with the SGLT2 inhibitors. Here is the EMPA-REG, and they're all very close together. This is the DECLARE-TIMI, ENVA-REG, and CANVAS. Now, here you see the interesting bit is, in EMPA-REG trial, in 60% of the patients, the urine ACR was less than 30. So more than half of the patients had normal or no CKD at all. Urine ACR was also less than 30. CANVAS trial, median ACR was 12. And in DECLARE-TIMI, ACR less than 30 in 70% of the patients. So if we can show that in these three trials, if there was prevention in progression of CKD, we can say this is the closest we have of data for the patient have shown that giving an intervention will stop progression for CKD. Otherwise, these all are data with urine ACR more than 30 and or eGFR less than 60. I hope I've made my point clear. So clearly, if you were to start an SGLT2 inhibitor for our patients, then we can say that yes, whatever evidence we have is with the SGLT2 inhibitors in preventing progression of hard endpoints of CKD, not just the albuminuria. Now, this is the data with the EMPA-REG outcome. This is the first study which demonstrated kidney protection with SGLT2 inhibitors. Now, you can see incident or worsening nephropathy, and that is not just the albuminuria. It is a doubling of creatinine or renal replacement therapy. You can see here there was 39% reduction, and the Asians did just as well as the rest of the world. Progression to macroalbuminuria was 38% reduction. Doubling of serum creatinine, initiation of RRT, renal death, 46% reduction. I'm not a great fan of albuminuria reduction. If a drug just causes albuminuria reduction, I will not be happy. I want it to be accompanied by this reduction in doubling of serum creatinine or RRT, initiation of RRT. If you just cause albuminuria reduction and there is no benefit here, what's the use really? Because almost all of the DPP-4 inhibitors, they cause albuminuria reduction. Multiple drugs, sulfonylurea is called albuminuria reduction, pioglitazone causes albuminuria reduction, all of them cause. Many drugs cause it, but they don't stop the kidneys from getting damaged. So what's the use of reducing the albuminuria? That's my question. So it is not just albuminuria reduction. You have to show that it prevents the doubling of serum creatinine. It prevents the creatinine from going up and the eGFR from going down. Then I'm happy man. So here in the EMPA-REG outcome, it did show clearly that the doubling of creatinine, this was all reduced by 46%. It was such an encouraging result, really, that for the first time, patients who did not have CKD, urine ACR less than 30, EGFR more than 60, where there is no data, no evidence so far, now we have got data, albeit it is not a trial, especially for those patients, and it is not a primary outcome, but at least we have got exploratory outcome suggesting the benefit. And the rapid decline of EGFR, that is, we call it more than 3 ml per year, that was reduced overall, and you can see there was a 68 overall, there was 68% reduction in the rapid decline of EGFR. So whether the EGFR was more than 90, 60 to 90, 45 to 60, and less than 45, you can see, and the p-value for interaction, you can see here. So again, it did not matter whether your kidneys were very healthy or very unhealthy. The rate of decline, it is reducing. So that I can challenge you, not many drugs are there which will show these results. It's only the SGLT2 inhibitor group which will show it. And amongst them, we have got these three which shows. And I'm showing the data for the empagliflozin. So again, if the urine ACR is normal or there is micro and macro, all of them will show similar stoppage of rapid decline of EGFR. So significant for those who are keen on albuminuria reduction, there is significant reduction of albuminuria. Patients with prior microalbuminuria, there was a 43% likelihood of coming back to normal. Although I must concede that albuminuria really is an indicator of inflammation in the kidney. And patients who have got albuminuria, I'm not saying don't take that seriously. I'm saying that those who have got albuminuria, they are at higher risk of having cardiovascular events. So we must concentrate on their blood pressure, on their lipid profile much more than we would have done otherwise. But what I'm trying to say is, if a drug just causes reduction of albuminuria without having any impact on the EGFR, then that doesn't cut the ice for me. So here, patients with prior macroalbuminuria regression to normal or micro, there is 82% reduction. So there is a reduction of the inflammatory aspect as well. And this is something, dear friends and my respected seniors, this is something which baffles me a bit. With the GLP-1 receptor agonists, I can understand that there is some anti-inflammation activity involved. But with the SGLT2 inhibitor, where there is no direct anti-inflammatory activity involved, there is reduction of the inflammation, which is manifested by reduction of the albuminuria. So the cardiovascular outcomes, and this goes in favor, and I think the empagliflozin companies are very happy to project this slide with the EMPARAGE outcome, because it is the only one which shows 38% CV death reduction and all-cause mortality reduction, whether the other CVOTs with the SGLT2 inhibitors did not show this. So which is good. Because many a times a commonly asked question, if somebody has got CKD, which drug will you choose? Empagliflozin, dapagliflozin, or canagliflozin? Now you see here, the CKD doesn't come in isolation. There is always something else associated with it. So we have to take those into consideration as well. So certainly, if somebody has got CKD with atherosclerotic cardiovascular disease, which is quite common in CKD patients, if we have got combination of CKD with ASCVD, then of course, empagliflozin, for me, empagliflozin will be the first choice. Why? Because the patient will die of cardiovascular causes rather than the CKD. And in the EMPARAGE outcome, the atherosclerotic cardiovascular disease patients were 100% of the patients, and there they reduced the CV death by 38%. So therefore, if somebody has got ASCVD, then empagliflozin comes up first in the ladder. Now, this is an interesting concept which is coming up, the perirenal fat. This is another one of the mechanisms I feel which is perhaps a bit more applicable for the GLP-1 receptor group of patients, because that a group of drugs. Because again, GLP-1, we are not very clear as to why there would be some kidney protection. But mind you, again with the GLP-1 receptor agonists, it was with the flow trial that there was a benefit, where the kidneys were ill to begin with, where the eGFR was 47 baseline. But when in the flow trial, in the SOUL trial, where the eGFR was 74 and the kidneys were healthy, there was no benefit. I did ask the trialists, and they said that probably when the inflammation has set in, like in the flow trial, when the kidneys were unhealthy, that's when the GLP-1 receptor will act. But when the inflammation is not there, it will not act. That is the difference between GLP-1 and SGLT2. The SGLT2s, as I just showed you, it will work even before the inflammation has set in, before the CKD has set in. Now, another one of the mechanisms is the perineal fat. Now, impact of perirenal fat on CKD, there were no systematic reviews and meta-analysis before that. This trial meta-analysis included more than 2,500 patients. And if you see here, those patients who had just CKD, those patients who had type 2 diabetes and diabetic nephropathy, those patients who had heart failure, everywhere there was an association between the perirenal fat, that is the fat around the kidneys, and CKD. This is particularly more applicable for patients who have got higher BMI, like our patient, which I showed you, has got a BMI of 27. If he is more obese, then you'll get more perirenal fat likely. And therefore, the association between perirenal fat and CKD, whether you have got diabetes or heart failure or just plain CKD without any other comorbidities. So this was a trial done with dapagliflozin, actually, where they particularly looked at the perirenal fat. They looked at the fat of various other areas, but perirenal fat was one of them. So there they trialed with metformin and metformin plus dapagliflozin. Now these are the other areas: subcutaneous fat, periperitoneal, omelton fat. But look at the perirenal fat. Now, if you see here, the blue one is metformin at baseline, and orange is metformin at 6 months. And this is metformin and DAPA, another group patients at 0 baseline, and metformin and DAPA at 6 months. And you can see here, there is a clear reduction. This is 2 stars, which is statistically highly significant, clear reduction in the perirenal fat with the SGLT2 inhibitors. With the GLP-1 receptor agonists as well, there is data with liraglutide, good data with liraglutide and with semaglutide, where it showed that there was a similar reduction of perirenal fat as well. Now, because the fat is closely applied to the kidney, the automatic hypothesis is that if you have more perirenal fat, that will put more pressure on the kidneys, ischemic component will set in, the fat is in close proximity with the kidney, so any extra inflammation will then spill over into the kidneys. That's the hypothesis. Now you can see here clearly in this, the SGLT2 inhibitor reducing the perirenal fat. So I'm just outlining another one of the other theories regarding why there would be improvement in CKD, because there is no clear explanation why the inflammation bit will be reduced. So this was the results with the dapagliflozin. And so now coming to this slide. Now, if the patient is normotensive and there is albuminuria, what's the data we have? Now, again, I'm quoting the KDIGO 2022 guideline. So again, they've said the benefits of RAS blockage have been less studied in patients with diabetes and CKD without hypertension. So although IDNT and renal, I can see here, recruited exclusively patients with type 2 and hypertension, a small percentage in the renal trial and 30% in the innovation trial, which is here, were normotensive, suggesting therefore that RAS blockage may be beneficial, not a strong word that is beneficial, may be beneficial in patients without hypertension. Because of these two because there were some of the patients did not have hypertension, but they had albuminuria and they also benefited. That is why it is said. But the evidence is strongest if you have got high blood pressure and albuminuria. Now, how about just hypertension, no albuminuria? Again, the KDIGO says they're at lower risk of CKD progression when the urine ACR is normal, that is less than 30. Existing evidence does not demonstrate clear benefit of RAS inhibition for CKD progression in this population, meaning hypertension and normal albuminuric. So, therefore, you will see in the ADA guideline, in the diabetes guideline as well, if the patient is hypertensive and there is no albuminuria, they give a choice of the blood pressure tablets, not just RAS. It's only when the hypertension and albuminuria is there, that's when they will say, yes, now RAS blockage is the treatment. So now if I change the urine ACR and increase it to 290, and I reduce the eGFR to 56, now this is proper, this is in the CKD range, less than 60, this is also in the CKD range. Now you have got a host of all of these drugs will apply here. All of these trials will be applied to this patient. And this time I've included flow as well. You can see in the grand scheme of things where they stand. So urine ACR was between 400 to 600 here. And the eGFR was around 47 with the flow trial. So then all of them will be applied. Now, not just the SGLT2 inhibitor, now you can get into the GLP-1, semaglutide in particular, and the finrenone. The difference between credence, DAPA-CKD, and EMPA-kidney. So, of course, it's important to remember that the inclusion criteria. So, for the EMPA-kidney, the inclusion criteria was eGFR between 45 to 90 plus ACR more than 200. But if the urine ACR was between 20 to 45, you did not need to have albuminuria. So therefore, urine ACR less than 30, you can see here, 20% of the patients in EMPA kidney trial included patients who did not have albuminuria, as opposed to 0 in dapagliflozin. But they are not, it does not mean that they are not sick kidney-wise. Their eGFR is less. The eGFR is between 20 to 45, okay? But at least those group of patients who did not have albuminuria, till now we did not have any evidence in those patients who had low GFR but no albuminuria. But here we now have evidence with the EMPA kidney trial, because 20% of the patients out of the 6,500 patients is quite a big number. So again, you see it was sicker urine eGFR less than 30, about a third of the patients had it. And you can see here, this is the credence trial, the population it catered to. This is the DAPA-CKD, the population it catered to. And now we have got the EMPA-CKD. Now look at the population it catered to. Such a big population up to here, okay? So here is credence, here is DAPA-CKD, and there is the EMPA-CKD. Now, with the EMPA-CKD trial, there was 33% reduction in end-stage kidney disease reduction. And if you add in CV death, there was a 27% risk reduction. Now, this is, I think this, I like, this graph I like very much because it really shows the value of the SGLT2 inhibitors. Now, you can see here, when the EMPA-REG outcome, how it stops the eGFR from going down. This is the placebo arm, and this is the empagliflozin arm. So here in the EMPA-REG outcome with the eGFR, normal eGFR around close to 75, there also it is stopping the GFR from going down. Now in the EMPEROR program, where the eGFR is slightly lower, there also it is stopping. And in the EMPA kidney trial, where the eGFR is close to 35 now, there also it is stopping the eGFR from going down as compared to placebo. So you can see in the various subgroups, depending, it doesn't matter what the eGFR was, more than 60 or less than 30, it will stop the GFR decline. Albuminuria or no albuminuria, GFR low or normal or high, and regardless of the cause of CKD or heart failure. So, but we must always remember that CKD doesn't come in isolation. There might be associated other comorbidities as well, particularly ACVD. So risk factors must be taken into account: obesity, management of obesity, lifestyle, smoking, etc. As I said before, lipids, blood pressure, glycemic control, uh, telling the patient again and again, reminding them and telling them of the consequences, lifestyle modification, and of course, aiming for weight reduction. So GFR decline, if you just use blood pressure control, GFR decline will be like this. If you add in RAS inhibitors, you prolong it somewhat. You're adding SGLT2, prolong it even more. And now with the MRAs, Spinranon, you're prolonging it even more. So that, to be honest, in the past, I used to always think that what's the use of doing the urine ACR? I don't have any good medications to reduce it and stop the eGFR from going down. But now, with these multiple agents available, particularly with the Finranon, I write it with a positive attitude that yes, now I have got agents which will really stop the eGFR from going down, along with the albuminuria. So with the SGLT2 inhibitor, there is always a little bit of a dip. And so it is important that if the dip is more than 30%, and it does not just SGLT2 inhibitor, for RAS inhibitors as well, for MRAs as well, you review into other causes. But don't stop it and don't say that never use it. Don't use that terminology, because many patients in whom there is a dip, they do better, particularly for RAS blockage as well. Now, few other points. SGLT2 inhibitors is not contraindicated in asymptomatic bacteriuria, commonly asked questions. Genitourinary infection is usually mild, non-recurrent, easily treatable with a cream. If it is troublesome, then you give a fluconazole 150 milligram tablet and repeat it again after 1 week. One important point right at the beginning when the SGLT2 inhibitors came into the market, one patient told me a very important thing. He said that you said always wash your private areas. Previously, I didn't have this fungal infection. After washing it, I began to have it. Then I realized that the key is keep it dry. So that's what the patient taught me. And actually, it's written there that not only wash, keep the area dry. If you have carry tissue paper with you, then after washing, dry the area. That is the key. Even if you are not on SGLT2 inhibitors and for diabetic patients who are having fungal infections, keeping it dry is important, not just washing. So that's important regarding the counseling for genital infections. Then stopping it if you have got an active UTI. If you have got history of recurrent UTI for more than 3 years in the past 1 year, that is defines history of recurrent UTI, then you might think of other options. And once the genital tract infection is, if you stop it for any reason and it goes away, then think about restarting the SGLT2 inhibitors. Elective surgeries, not just SGLT2 inhibitors, we have to stop a host of drugs like it's given here for the reasons which are mentioned here. The SGLT2 inhibitor, ketoacidosis, euglycemic ketoacidosis is very important, albeit it's very rare. But so if somebody is having a small operation, suppose a lap chole, so that patient will not be near my mouth for a long period of time. So if you stop the SGLT2 inhibitors 2 days before, is very unlikely to go into decay. But if the patient is having a big operation, say like a colectomy, a big colon surgery, will be near my mouth for a few days, then the starvation aspect comes in. Moment the starvation, big surgery, stress comes in, then this question of the CABG surgery, then the question of euglycemic decay comes. So the standard advice is that you stop it 2 to 3 days before elective surgery and restart it as soon as possible at the time of discharge. So I think, of course, during prolonged fasting, surgery or critical medical illness, when the patient is admitted, you need to stop it. So the KDIGO guideline mentions clearly that SGLT2 is the first pillar in the management, one of the pillars in the management of CKD patients in diabetes, in preventing CKD in type 2 diabetes patients. So with that, I end. Thank you very much, and I'm open to any questions.
Thank you,
comments.
Kalyan. Professor Das is there. He may ask, interact with you.
It has been a very great advanced lecture. I think I'm delighted that you spoke about it. I'm a strong believer in empagliflozin for two reasons. Number one, they are the first people to give in 1914 in the ASD, they get the EMPA-REG trial, whereas the DAPA was an afterthought. The second thing, as you rightly showed, that perinephric fat is very important. You know, perinephric fat stranding is one of the findings on echocardiogram. Am I correct, Kalenda? And that is the forerunner of many things, including pyelonephritis and one of the serious conditions like emphysematous pyelonephritis. Emphysematous pyelonephritis also starts with a perinephric fat stranding. So I think the fact that it has an impact on the perinephric fat is going to be beneficial. I can't tell you how, but it is going to be beneficial. The first thing that you pointed out that this drug, you compared all the trials, the Pideligo, Pideliver trial, all the EMPA kidney, DAPA kidney, all the trials in that small square you showed. The benefits of this drug in reducing, in preserving EGFR is great compared to others, and that definitely benefit. Only one thing I'm not very sure, Kalenda. I believe that microalbuminuria or albuminuria is a feature of pan endothelial dysfunction. Am I correct? Leaky syndrome. So when you said that reduction of albuminuria will not be beneficial, I was not very convinced. But you qualified. You said if it is only reducing microalbuminuria, it may not be beneficial. It has to help EGFR also. But I recently read that to provide longevity, one has to take care of UACR. I mean, I don't know whether it is universally true or for that article it is true. Good. And like you rightly said, the simple tips of how to prevent SGLT2 urinary infection, I think it is great. I know I particularly feel that this drug is unique, and more information is pouring in, which benefits our clinical practice. I do not know whether there is data on the EMPA-LINA combination, which has produced a great change in the destiny of the patients. Is there any data, new data, EMPA-LINA combination?
Not that I'm aware of. I think all the data is for showing glycemic control and bioequivalence and bioavailability studies. So no data
But
separately.
I think your analytical presentation has been very convincing, saying that this molecule, namely empagliflozin, still rules the roost and is one of the unique molecule which stands out tall in all the trials for the EGFR protection and for the perinephric fat stranding. The urinary infection is not a deterrent factor, and all that you said. Thank you very much, Kalyanda, for the great
Thank you,
talk.
Kalyan. Thank you very much for a nice presentation, highly clinical, but backed by academic data. Highly clinical with backed by academic data, which will help clinicians to decide the fate of their patients with renal problem. Thank you very much for taking out time and joining us.
Kalenda, thank you.
See you next year. See you next year.
Thank you.
So at the end, I have no words to thank Professor Das. Professor Ashok Das has done extremely. He has been my mentor, elder brother for last. He has been supporting NUCD from the day one. I would like to again thank our partners, US Vitamins, our premium partner, and unconditional academic support, and they have supported whole team. I want to thank every one of them for their help. Sanofi is also a great help, academic partner. Novo Nordics, in spite of their recent hither-dither, they are still with us in a very supportive way. Medley is very helpful. Their whole team, their general manager also came today. Boehringer Ingelheim was the last stop. Mukti and others, they are helping a lot. Lupin, Three Dots, Abbott are our academic partners, and our Dr. Kanungo's Diabetes Center and its staff, and Kids Hospital and Kotak Diabetes Research Foundation are all with us, and we thank all of you for this academic support. And I will request all the guests, all the delegates and speakers to reach tomorrow by 7:30 to 8, because we have a very good breakfast tomorrow from 7:30 to 9, 8:30, 8:45. Because sharp at 8:45, Professor Das has told us, instructed that the first session must start at 8:45.
Recap. And look, I just wanted to understand, tomorrow's session will be both
virtual and
will be also
physical.
broadcast virtually?
Yes. Everywhere. Those who have joined from different places today will see the sessions tomorrow also in their phone, in their laptop, in their YouTube, everywhere. We have made that arrangement. And 15 minutes recap from 8:45 to 9, and dot at 9, our esteemed speakers will be available and we will start the session. Welcome and good night to all of you.
Thank you very much. Alok, see you tomorrow. I'll be here in time, or you
Yes.
can, I'll be there. Thank you.
Good night,
Thank
sir.
you. Good night, Alok.
Good night.
I'll go to Bangor Challenge.